I might lose my daughter while appearing cheerful and strong in front of her, right? But both of us cried in the room while she was sleeping. Being emotionally supportive and being able to communicate among each other between my husband and I actually really helped both of us to cope during this tough period.
We are one of the private hospitals in Malaysia with pediatric oncology care. And I think the difference between sunmed and other hospitals with this care is that we practice holistic medicine. The other thing that makes us different is we have art therapy. So we have an art therapist who comes and works with all of our patients. So it's looking at a patient from the whole perspective, not just treating them medically, but also treating them mentally and emotionally.
Initially, she was quite reserved. She showed some depression, the symptoms of depression, expressed herself in the hospital. And then she started drawing, graveyard. Then she started saying that in Chinese, 升天 is going to the heaven.
At the beginning, when she was first diagnosed with cancer, she painted a lot of very dark paintings. There is a lot of uncertainty that a doctor telling you that you have cancer. And then when she started treatment, she was on a medication that increased her appetite. So all her paintings were about food. After that phase, she became happier because she can see the light. She felt better. So I saw a whole transition, and she was able to verbalize it, which is something very special, very unique for a 7-year-old girl.
She shared something very interesting and meaningful when we had deep conversations. 当有一个人跟自己喜欢的东西一起死，我估计他不会那么的孤单。你知道我最喜欢什么吗？你们的爱和真心。就算什么都不能带去天堂，你知道什么还可以被带去吗？你们的爱和真心。I'm also very grateful that two-way communications with the medical team is really helpful, very supportive towards the treatment process or journey. I'm grateful that the needs in this area is seen by the whole team. All the nurses in 2B ward, they show compassion toward her condition. She also mentioned once that hospital is the second home to her.
How she caught me off guard when she told me getting cancer is a blessing. I never imagined a child telling me that getting cancer is a blessing. And she said, getting cancer allowed me to spend more time with my parents. They no longer spend so much time at work, and now they spend time with me. We view life as work, you try to work and you support your children that way. But actually, children just want you to spend time with them. And so now they have realigned their focus. They work, right? But they also spend equal amount of time with the children.
Childhood cancer is not the end. They have hope to be healthy again. This is the hope that we hang on to. For Yu Yan, right, her bravery, continuing what a child at 7 years old does, studying, playing, enjoying the activities as a child. She is also one of my motivators to keep on going.
When you hear the words heart condition, it can feel overwhelming, especially when it involves someone you love. But today, even the most complex heart conditions can be treated, managed, and in many cases, successfully overcome. I'm Dr. Ahmad. For over 30 years, I've dedicated my life to treating heart conditions present from birth in babies, children, and teenagers. And in that time, I've performed more than 5,000 surgeries across 4 countries. I also led volunteer missions for underserved communities. But for me, it's never just about numbers. Every case reminds me of the trust patients place in my care. Congenital heart conditions mean the heart didn't develop in the usual way. Some children are born with a hole in the heart or born as blue babies, while others have valves or blood vessels that don't function as they should. Some conditions are detected early, others only become clear later in life. But without proper care, they can lead to serious complications over time. Every patient is different. Some may only need monitoring and medication. Others may require surgery to repair or reconstruct the heart. Where possible, I use minimally invasive techniques, allowing for smaller incisions, less pain, and faster recovery. But heart care is never done alone. At Sunway Medical Center, Sunway City, I work closely with a dedicated team of specialists, nurses, and support staff, ensuring every patient is cared for at every stage, from diagnosis to recovery. At the heart of my care is communication. I always take the time to explain each condition clearly and simply, so you and your family feel informed and confident moving forward. Whether you are parents seeking answers or someone facing a heart condition, you are not alone. And with the right care at the right time, many patients are able to heal, recover, and live life more fully again. At Sunway Medical Center, Sunway City, this is what we strive for every single day.
Good morning, ladies and gentlemen, and welcome back to day 2 of the Pediatrics Without the Borders Symposium 2026. I hope everyone had a restful evening and a wonderful breakfast. This morning, we are excited to continue another day of insightful discussions, knowledge sharing, and meaningful conversations with you. Without further ado, we will begin our first session of today. For our first symposium of the day, the topic will be Pediatric Liver Tumors, a Multidisciplinary Approach. To moderate this session, I'm honored to introduce Dr. Zakaria Zahari, a consultant pediatric surgeon from Sunway Medical Center, Sunway City. Throughout his distinguished career, he led the pediatric surgical service at the Institute of Pediatrics, Hospital Kuala Lumpur, followed by National Women and Children's Hospital, HTA, where he played a pivotal role in advancing pediatric surgery and training future generations of surgeons as the head of service. He had also served as the president of the Malaysian Association of Pediatric Surgery. Without further ado, let us welcome Dr. Zakaria to begin.
Thank you, Farah, for that kind introduction. Okay, the symposium today, symposium number 4, is on pediatric liver tumors, which is basically a fairly niche area in even in amongst pediatric surgeons. I think last year, in 2025, we had a total of about 35, and that's probably a high number of pediatric liver tumors in the whole of Malaysia. And interestingly, a third of them are from the private sector. So the numbers are increasing. Even though the numbers are much less compared to our adult colleagues, the difference is that in children, almost all tumors, all liver tumors in children are technically curable. So all of them will undergo some form of chemotherapy followed by surgery and followed by other treatment. So the first speaker of the day will be Ms. Chia Hugh San, who's worked with me in Pediatric Institute and who now deals with many of these conditions in this hospital. May I invite Ms. Chia to deliver a talk on this liver tumors, which we saw a lot last year on hepatocellular neoplasm, not otherwise specified, which is basically a type of hepatoblastoma. Chia?
Yeah, so I would like to introduce the emergence of this newly recognized disease entity, hepatocellular neoplasm, not otherwise specified. All right, so malignant liver tumors based in children accounts for 1 to 2% of all solid tumors. Hepatoblastoma is still the most common type, accounts 70 to 80% of all the malignant liver tumors in children. The peak age is of onset usually happens in between 6 months old to 3 years old. Only about 10% of them occurring after 4 years old. So it consists of epithelial of both epithelial and mesenchymal components with a mixture of different histologic patterns. So generally, like Dr. Zakaria mentioned, they are chemoresponsive and successfully treated with a combinations of chemo and surgery. So 5-year survival rate in hepatoblastoma, which is quite good, approximately of 70%. So the second tumor, the most common second tumor of liver tumor in children will be the hepatocellular carcinoma, or we called it a HCC. It is more common in older children. Usually we encounter them in above 10 years old, especially 10 to 14 years old. And frequently, it is associated with chronic liver disease, such as hepatitis B or C. And it exhibits conventional histology like adult HCC, viral lamellar histology, or clear cell histology. Unfortunately, it is often chemoresistant and associated with a poor prognosis compared to hepatoblastoma. For survival for this group of children, approximately about 30%. So now we come across this new entity of disease, hepatocellular neoplasm, not otherwise specified. So, or we call it a HCN-NOS. So it is a characteristic of both hepatoblastoma and HCC. So it is reported as a new disease concept in pediatric malignant liver tumors and recently introduced in WHO classifications of tumor with additions as a provisional entity for such patients. And actually, when we look back, it was initially reported by the Procurate et al. In 2002 and is known as transitional liver cell tumor with HB with HCC-like progenies, hepatoblastoma with carcinoma features, or in between, HB demonstrating focal atypia or pleomorphism. So there are a few journals we're going to go through today. First, it's published in the Modern Pathology. It's a study done in United States. They compared the clinical pathologic and genomic analysis of this HCN-NOS and hepatoblastoma. So from this table, we can see that, the male still will be the predominant group for both the hepatoblastoma and the HCN-NOS. And you can see from the HCN-NOS, actually the peak of the age is slightly older compared to the hepatoblastoma. So in this HCN-NOS group, they mean that the median age is about 7 years old. And in the hepatoblastoma, usually is younger, about 2 years old. So, and we can see that both of them carry a very high alpha-fetoprotein, majority of them above 10,000. And for this HCN-NOS group, there are more patients with multifocal primary tumors, which is, statistically significant. Yes, and they also carry a high pre-treatment axonal tumor, but when they usually come with presentations, they always come with a pretext stage 3 or 4 compared to hepatoblastoma treatment. Yeah. Then also this HCN-NOS group significantly more high-risk patients compared to hepatoblastoma. So what did they find in this paper? So they found that patients with this HCN-NOS were basically older and they are more frequently classified high risk. However, there's no significant difference in alpha-fetoprotein levels or survival outcomes compared to those with hepatoblastoma. And about some genomic analysis, so this HCN, NOS, and hepatoblastoma has a comparable frequency of sequence variants, with CTNNB1 mutations being the predominant in both groups. Notably, these third promoter mutations and some rare clinical significant variants like BRAF, NRAS, and KMT2D were exclusive to this hepatocellular neoplasm, not otherwise specified. And also, they demonstrated a higher prevalence in the gains of the chromosome 1 long arm, and also with a loss of heterozygosity in the chromosome 1 short arm. Also, they noticed some other chromosome involved as well, like in chromosome 11, when they compare with hepatoblastoma. So they found that there is a recurrent loss of LOH of chromosome 3, 4p, 9, 15, and the chromosome Y, which is observed in this HCN-NOS. So the next paper, which is probably more practical to us because this was done in Korea, is published by the Koreans. So they compare the malignant hepatocellular neoplasm, not otherwise specified, display a poorer chemoresponsiveness and post-operative prognosis compared to hepatoblastoma. So what did they observe in this group? So they found that the similar findings that we encounter, the median age was actually higher than the hepatoblastoma, so which was about 8 years old, but is similar with the HCC group. So if they compare to the hepatoblastoma group, it is less frequently had underlying liver disease. So we can say that the underlying liver disease usually happen in HCC only. So, but high serum alpha-fetoprotein concentrations at diagnosis also more commonly in this group of HCN NOS, and tumor size at diagnosis was significantly larger. So if they compare with hepatoblastoma and HCC, so they found that these new disease have a pretext stage which was higher, and higher proportions of patients presented with metastasis at diagnosis, and about 90% of them were classified under intermediate to high-risk categories according to this CHIS-HS risk classification, which is significantly higher than both group of hepatoblastoma and HCC. And something new, which is lymphovascular invasion, which is more commonly observed in this HCN NOS. So this is about the response to preoperative chemotherapy. So they noticed that this HCN NOS group of patients require more than 4 cycles of neoadjuvant chemotherapy, so which indicates a poorer response and the need for extended treatment. So it was higher in this group of children, and majority of hepatoblastoma, actually they achieved more than 90% of decrease in alpha-fetoprotein after the neoadjuvant chemotherapy, but it was only about 60% in this group of children. So tumor size, where they compare again, but that is not statistically significant. Portal veins invasion status and metastasis and still remain unchanged in both groups, and differences between pre-tax and post-tax after the neoadjuvant actually remain not significant as well. So something interesting from the surgical specimen that they found that in this HCN NOS group, 70% of them still exhibited more than 50% of viable tumor compared to 50% of hepatoblastoma. But unfortunately, it is not statistically significant. So we can conclude that prognostic significance of children with malignant liver tumors is if they are aged 8 years and above, advanced pretext stage, presence of portal vein invasion, metastasis at diagnosis, presence of lymphovascular invasion, as well as the diagnosis of this new entity, hepatocellular neoplasia not otherwise specified, they actually carry a poorer prognosis. So to conclude this prognostic significance of this group of children with HCN NOS, sex, presence of the underlying disease, and serum AFP actually did not affect the event-free survival or overall survival. And diagnosis of HCN, NOS, and hepatocellular carcinoma, pretext stage 4, and the presence of lymphovascular invasion were significantly negative predictors for event-free survival. So, presence of underlying liver disease, portal vein invasion, lymphovascular invasion were significant negative predictors for overall survival. Liver transplant still display the longest event-free survival and overall survival in both hepatoblastoma and HCN NOS groups. The next paper is about the chemotherapy, where I think Dr. Yap will go deeper for this. Yeah. So this is a study done in the United States as well. So they conclude that one of the papers they reported that actually these patients with this mixed histologic phenotype actually has a better overall survival compared to the classical HCC. So this is still ongoing researches and studies to prove this statement. So since this entity contains hepatoblastoma components, which are often chemosensitive, so it is recommended to treat such patients according to hepatoblastoma staging. HCN NOS do not appear to have a favorable as a prognosis as a pure hepatoblastoma, given a tendency to develop chemoresistance. So regimes like CyPL3 high risk, C5VD or CyPL4 have been trialed, but however, there was no data to guide what is best at the moment. in the context of metastatic disease, cell-4 chemotherapy is still recommended. So careful monitoring for response of this therapy is by the AFP level and imaging. It is important to effectively titrate the therapy or to make changes as needed. So for chemo-resistant disease after this hepatoblastoma-like therapy, HCC-like therapies can be considered. So this is something basic about the hepatectomy. So we have 8 segments of liver, 1, 2, 3, 4, 5, 7, 8. So with the right hepatec, we know that this is commonly we know is a 5, 6, 7, 8, and the left hepatec will be 1, 2, 3, 4. However, certain conditions we will do extended left or extended right, or sometimes even in a central hepatectomy or even a non-anatomical resection. So for this liver tumor, we will use this PRETEX system, which stands for pre-treatment extent of tumor. So we have PRETEX 1, 2, 3, 4. So PRETEX 1, basically the tumor is confined to 1 session only, where 3 other contiguous sessions are still free of tumor. So for PRETEX 4, unfortunately, it involves all 4 sections. So we also have these annotate factors like such as vascular, portal, extrahepatic tumor extension, whether multifocal, rupture of the tumor, coded loop involvement, lymph metastasis, and distant metastasis. Probably this one, our radiologists will tell us more about this. So something new about liver resections in children or even in adults will be the indocyanine green, or we call it ICG. It's an injectable fluorescent dye. So for this hepatectomy, usually we will use this 0.5 milligram per kilo, and we will inject patients 72 hours before the hepatectomy. And for those who come back to us with a thoracic metastasectomy, we will give this ICG 24 hours before the surgery. So this is examples of the picture. So these will be, appear for instance during the surgery, after the ICG given. So it is helpful for locating the tumors, determining the margin, and finding the small lesions with negative imaging. So preoperative chemotherapy, tumor necrosis, tumor death, and ICG administrations impact the effect of fluorescence imaging. So specifically, hepatic uptake occurs with eventual excretions into bile. So however, due to these morphologic changes of the tumor cells, these ICG excretions is decreased. So it can help us to facilitate the detection of both primary and metastatic disease. So I'm going to go through these 6 cases that so far we have in Malaysia. So 6 patients. The first one is in a public hospital. They're from Kuala Terengganu and also undergone the surgery in hospital Tunku Aziza, HKL. So she was a girl, and it's obvious that she is the only female in this series. So she was 6 years old at diagnosis, came to us with alpha-fetoprotein above 700,000. It involved the left side. So from this series, we can see that the youngest will be the 2 years old, the oldest will be the latest case, which is 7 years old. So all of them demonstrate a very high AFP, except these 2 cases, which is below 10,000. So all mainly involve the right side, only one that involve the left. So this is the tumor size at diagnosis, all right? So I will go through the 6 cases of them. So first one I mentioned, the girl, 6 years old, alpha-fetal very high, left side, segment 1, 2, 3, 4. So pretext 2, no, and she has these portal vein invasions at diagnosis, no metastasis, considered as high risk, no adjuvant given, and she underwent left hepatectomy in 2025, and there was a tumor rupture. So she undergone chemotherapy. Unfortunately, the AFP doesn't really normalize, so she received a sample of 3 eyes, modified eyes, and GMOX, and also the resections. There was no involvement. Unfortunately, there was also a lymphovascular involvement, and at the moment, her AFP increasing, continue to increase, which is, I think, latest is above 2,000 today, and there's a plan for liver transplant for her. So our second case, we have 4 cases we received treatment, chemotherapy in Sunmed Medical Center. So the second case was a 4-year-old boy, came to us with 300 and above of AFP involving the right. The tumor was huge, with involving the segment 7 and 8. He received 2 cycles of cisplatin. Unfortunately, after the chemotherapy, we noticed that actually the AFP doubled. So we repeated the CT scan immediately. So he has a pretext 2, no portal vein invasion, no metastasis, treated as high risk. So, and because of this misbehave of this tumor, so we proceeded with the right hepatectomy in July last year. So he received chemotherapy, treated with cytopenia, no clear margin, but with a lymphovascular involvement. Unfortunately, he came back. AFP was normalized. Unfortunately, it raised again subsequently, and we found that the culprit is from the lung. So he came back with a relapse of lung nodule over the left upper loop. So we did left thoracoscopy and left upper loop nodulectomy, and the AFP actually normalized but the parents, they decided to seek second opinion in Shanghai. So he is currently still in Shanghai receiving this chemotherapy of GemC and oxaliplatin. And the latest email from the mother, actually the AFP have been normalized 4.8, the latest, and the imaging showed no recurrence. So the third patient is 6-year-old boy, 6,000 of a fetal right side involving just a segment 4B, pretext 1, no portal vein invasion, no metastasis, also treated as high risk, no neoadjuvant chemotherapy given before surgery, and he just underwent a non-anatomical resection last year. And chemotherapy after that, treated with cytopenia high risk, no clear margin, no lymphovascular involvement, and he remained well with this latest of AFP of 2.3. So the 4th patients will be also receive treatment in Hospital Tunku Aziza. 4-year-old boy, 54,000 AFP, right side segment 5 and 6. So, and he came with a pretext 2, but with a portal vein thrombosis as well, portal vein invasion as well, with lung metastasis at diagnosis, and treated with high risk, and no neoadjuvant also. Proceeded with a non-anatomical resection in this January, and chemotherapy after the surgery, about 4 clear margin, and he also has this lymphovascular involvement. And because he presented with lung metastasis at the very beginning, but after surgery and chemotherapy, the latest imaging showed that these lung nodules actually reduced in size and numbers, the latest AFP around 20. So the decisions make to just continue observations for him. So the 5th patient was at our Sunmed Medical Center as well, the youngest among all 2-year-old boy. So the AFP actually below 2,000, involved a right side, 5 and 6. So no invasion, no metastasis, also treated as high risk. No neoadjuvant given, and non-anatomical resections in February. So received chemotherapy after that, about 3, high risk, no clear margin, no margin involvement, and no lymphovascular involvement, and he also remained well with the AFP of the latest of 2 in July. So the last case that we received, so we actually will be the bizarre and still ongoing treatment and observation. He is 7 years old, which is the oldest among all, male, and he came to above 1 million of AFP. So after 1 cycle of plating, we found that actually the AFP is fluctuating and increased, and there was a HV drop of 4 grams. So with that, we suspected a tumor rupture. We repeated this imaging, and proceeded with the surgery. So it evolved the right side as well. So we can see that there's a segment 4, 5, 7 and 8, and also there's another different small tumor in segment 4B. So we can compare within a short duration, actually the tumor drastically increased in size. So among all, he has this pretext 3, yes, and portal vein invasion as well, and metastasis because we went in, I will show you the CT scan after this. So we opened up the diaphragm and went into the lung as well. So we took all the biopsy and all and sent for HPE, and it came back the Pira actually, there is a metastatic nodules. So he was treated with high risk, and pre-operative treatment he received, as I mentioned, 1 cycle of cisplatin, and subsequently we suspected tumor rupture. So we proceeded with this extended right hepatectomy in just recently May, and we found this tumor rupture. So he is currently just completed therapy 4, and margin unfortunately was involved, and the HP came back as an extensive lymphovascular involvement. So he had just recently completed chemotherapy. Unfortunately, the AFP initially it showed us a very positive. It kept dropping, almost normalized, but the latest, unfortunately, earlier this week was 17.7, which slightly increased again. So I'm going to show you the pictures. This is patients 2, right? We came back with a relapsed lung nodule. Yeah. Well, okay, it doesn't really work. So this is a CT scan. We can show a very huge tumor. And this is the operative findings. We see these tumors is super huge. And this is after surgery. So this is the ICG. The picture was a big blur, unfortunately. So this is a nodule. In fact, it just wasn't that clear, right? So this is a single nodule that we found. So we did a staple, so nodulectomy done, which show us a very good outcomes, surgical outcome. And in fact, the AFP was normalized after this nodulectomy. So he is currently in Shanghai, will be back in September. So patient 5, which involved this small segment in segment 5 and 6, which where he underwent a non-anatomical resection. So this is what I meant by non-anatomical resection. This after surgery, and this is the tumor. So patient 6, our last patient, which is a bizarre tumor. So we can see these 2 images with the first one and the second one. So you can see the tumor actually is really increasing drastically and push out the right whole lung, and you can see some fluid collection in the right lung. So with this significant drop in HB and all, so without long waiting, we proceeded with the kind of like a semi-E hepatectomy on the following Monday. So this is a tumor that we found intra-op. In fact, yes, it was already ruptured, right, at a few sites, right, here, and also involved the superior border, adhere closely to the diaphragm and all, right. Then, yeah, there is also the tumor in the IVC. So we open up the IVC with the vest control and all. We try our best to remove as much as possible, but we believe that there's some small amount of residual tumor because it adheres closely to the vessel wall. So after surgery, after the repair of the diaphragm and all, yeah, this is the involvement of all, adhere closely to the diaphragm. So after the resection, and we went into the right lung and removed whatever we can and repair the diaphragm, right? Okay, so this is the lungs. Yeah, inside you can see it's very messy, and this is all the specimens that we send to our pathologists, the tumor and all the lung tissues or whatever, tumor at the surrounding, including the perirenal fat and all. Yeah, so to conclude, this HCN NOS exhibits the intermediate or combined biology or histology features of both hepatoblastoma and HCC, sometimes within distinct areas of tumor. So even a biopsy will be challenging for our radiologists and pathologists as well. And to distinguish this from hepatoblastoma and HCC still remains challenging. And we've noticed that it usually presents with high-risk clinical profile. So, but they may have a favorable outcomes with aggressive chemo and a complete surgical resection, or they may require a liver transplant. So they currently treated as high-risk hepatoblastoma, not as HCC, in ongoing studies and treatment in this clinical trial. So it is important to recognize this tumor, which may require distinct therapeutic strategies due to their aggressive nature and potential differences in treatment responsiveness. So therefore, an accurate diagnosis of this HC and NOS is essential. That's why we decided to present this topic today, so to increase the awareness among clinicians for the early recognitions and also accurate diagnosis and the timely management for this group of patients for effective treatment strategies. So early referral to a center experienced in the management of this malignant liver tumor should be considered for a local control and also for prevention of metastasis. Thank you.
Thank you, Chair, for that extensive local and international review of this interesting entity of HCN NOS. In keeping with the theme of the symposium on multidisciplinary care, we're now going to move to the second speaker, who is Dr. Marina Sofiana, who is a pediatric radiologist who had further fellowship training in Ottawa, Canada. I've had the pleasure of working with Dr. Marina as well in HTA, which is the National Women's and Children's Hospital. She will now talk on the imaging approach to pediatric liver tumors.
Assalamualaikum and a very good morning. Thank you, Dr. Zakaria, for the kind introduction. Without much further ado, I shall start my presentation. So I will be talking about imaging approach to pediatric liver tumors, focusing on hepatoblastoma. Pediatric liver tumors are rare but potentially life-threatening. Early recognition significantly impact the prognosis, and imaging is central to the detection, characterization, staging, surgical planning, treatment response assessment, and surveillance. And of course, multidisciplinary management of these children are essential. So hopefully by the end of the talk, I'll be able to list down some of the more common pediatric liver tumors. We'll be able to understand the imaging pathway of pediatric liver tumors, appreciate the role of pre-test staging in hepatoblastoma, and understand how imaging guides multidisciplinary management. So some of the more common pediatric tumors, we divide them into malignant and benign. Of course, as Dr. Chia have mentioned just now, hepatoblastoma is the most common malignant pediatric liver tumor, followed by hepatocellular carcinoma. So there's this subtype of hepatoblastoma called malignant hepatocellular neoplasm, not otherwise specified, HCN-NOS. The undifferentiated embryonal sarcoma, metastasis, and those benign tumors such as infantile hepatic hemangioma, mesenchymal hamartoma, and more rare benign tumors such as focal nodular hyperplasia and hepatic adenoma, which are usually encountered in bigger children or teens. So for diagnosis of pediatric liver tumors, age is an important clue. Imaging alone would not be able to 100% confirm the diagnosis. So in neonates and infant, the commoner tumors are the hemangioma and mesenchymal hamartoma. In slightly bigger children, less than 5 years old, we should suspect hepatoblastoma. Older children and adolescents, those with underlying liver disease such as hepatitis, think of hepatocellular carcinoma and HCN-NOS. So the clinical features of liver tumor in children, some of them include abdominal distension, palpable mass, weight loss, fever, anemia, failure to thrive, and precocious puberty. Laboratory examination is essential. As the malignant tumors, hepatoblastoma, they would have elevated AFP, they would have abnormal liver function tests, and some would have thrombocytosis.
It is important to note in children, the presentation is slightly different than adults, as many children initially present with non-specific symptoms. So imaging approach, first line of imaging for abdominal mass, of course, we start with ultrasound. Various advantages of ultrasound include it's readily available, there's no radiation, it does not require sedation, and is an excellent initial screening tool. So it enables us, as we know, we can tell whether the lesion is solid or cystic. We can ascertain the vascularity of the lesion, look for any multifocality, presence of calcification, relationship of the vessels. So here are some examples. So this is a patient presented with abdominal distension, and on examination, there's a large mass centered in the right liver lobe. So we can see this is predominantly solid with hypoechoic area indicating necrosis. And when we turn on the color Doppler, you can assess that the portal vessel is being displaced by this mass. There's minimal internal vascularity. The whole appearance suggests a malignant tumor. And for this example, it's a straightforward liver cyst. It looks anechoic, well-defined. It has posterior acoustic enhancement. And when we turn on the color Doppler, there's no internal color Doppler signal within. And in this neonate, with the incidental finding of a huge liver mass, there's a heterogeneous mass, exophytic, and on color Doppler, there's a significant internal color Doppler signal indicating that this is a vascular lesion. And of course, with correlation normal alpha-fetoprotein, we would suspect that this is hepatic hemangioma. So once you detect a mass on an ultrasound with a suspicion of malignant lesion, of course, the next step is to do cross-sectional imaging. There's two choices. We can do either the MRI with the advantage of doing multiphasic contrast enhanced imaging, or CT scan. MR provides superior soft tissue characterization. It enables us to perform multiphasic study without eliminating the risk of radiation. It gives us a better assessment of the vascular involvement. Of course, for both, we can do the pre-tech staging, and it also enables us for surgical planning and detection of multifocal disease. CT scan, the advantage is it gives a faster image acquisition time, useful when MRI is not readily available or contraindicated in emergency setting. And of course, CT is superior at assessment of pulmonary metastasis. And always bear in mind for children, radiation exposure should always be minimized, and we try as much as possible to avoid multiphasic scan in these children as compared to adult. So let's go through the hepatoblastoma imaging pearls. So as the previous speaker had mentioned, hepatoblastoma is the most common malignant liver tumor in children. It typically presents in children, smaller children less than 5 years old, with an elevated alpha-fetoprotein. The mass tend to be heterogeneous, solid mass. You can find a bit of calcification within. There's internal vascularity, and the tumor may invade the vessels. And the imaging goal is to provide pre-tech staging, to assess vascular involvement, detect metastasis, and guide for biopsy and surgery if needed. So what is pre-tech? Pre-tech stands for pre-treatment extent of disease. So the purpose is to determine resectability of the tumor for surgical planning, ascertain the need for transplantation, and for risk stratification. So it is actually a simplified concept where the liver is divided into 4 sections based on the Quinat segments. So the pre-tech staging depends on how many sections are tumor-free. So basically, there's the right posterior section, right anterior section, the left medial section, and the left lateral section. And the staging directly influences the treatment decision. So pre-tax 1 tumor, basically there are 3 contiguous sections of the liver free of tumors. So there's only the right posterior section involvement or the left lateral section involvement. For pre-tax 2 tumors, there are 2 contiguous liver sections that are tumor-free. So the tumors can be in any one of these locations. As for pre-tax 3, there's only one liver section that is tumor-free. And pretext 4, where there's basically no liver section that are tumor-free. So the tumor can be multifocal tumor involving all the sections, diffuse infiltrative tumor, or one large tumor that involves all 4 sections, though that this situation is rather rare. So why vessel assessment is critical in pretext? Because it impacts surgical resectability, transplant eligibility, and the disease prognosis. And in pretext, the important vascular structures that we assess are the portal vein, hepatic veins, and inferior vena cava. And imaging must clearly describe whether these vessels are compressed or there's invasion, whether there's tumor thrombus within, and whether these vessels are patent. So let's go through one example of this child seen here in Sunway Medical. So this child, a 3 years, 2 months old girl, presented to Sunway Medical Children's Emergency, presented with fever for 3 days, abdominal distension for 2 weeks, and on examination, the abdomen is soft, however, the liver is palpable, firm, smooth, and up to the level of the umbilicus. Otherwise, there is no intestinal obstruction symptoms, and the request came in for hepatomegaly for investigation. So upon examination, immediately we can see that there's a huge mass involving the right liver lobe. So the mass measures about 10 by 15 by 14 centimeters, and there's presence of minimal color Doppler signal within it. The portal vein is not clearly delineated, could be compressed or could be involved. And there's no ascites or focal collection. Given the appearance of this mass with internal hypoechoic area within, suspicious of central necrosis, a malignant liver tumor was suspected, and we suggest for CT assessment. CT scan, CT thorax, abdomen, pelvis staging was done following result of alpha-fetoprotein that was raised. And you can see that the CT shows a huge mass involving segment 8 of the liver. The size is about 8.5 by 14 by 14 centimeters. There are multiple hypodense area within this mass indicating necrotic component. You can see that the hepatic veins, the right and the middle hepatic veins are displayed laterally. The right and left portal vein are partially compressed posteriorly but remain visualized separately, and the main portal vein here is patent. For the rest of the annotation of the pretext, there's no caudate lobe involvement, there's no multifocality, no evidence of tumor rupture, no evidence of distant metastasis, and no evidence of nodal metastasis. So this tumor, the staging is pretext 2, V negative, P negative. So MRI was done following 4 cycles of neoadjuvant chemotherapy, and it shows moderate interval reduction in size. So as I've mentioned just now, the advantage of MRI, it gives us the ability to perform multiphasic scan. So we can do the scan in arterial, venous, delay, and the hepatobiliary phase 5 minutes delay. So you can see that the mass is heterogeneous with large area of non-enhancing component indicating central necrosis. And in this venous phase, you can see that the hepatic veins are being displayed, the middle and the right hepatic vein being displayed. And the portal vein, which was previously compressed, has now less mass effect onto it, and it appears patent. So post-tax, the size now is 9 by 6 by 8 centimeter, and previously the largest dimension was 14. So the post-tax staging in this patient is post-tax 2 with moderate size reduction of the tumor in segment 8. So the child underwent surgery, extended right hepatectomy under ICG guidance, with remaining segment left caudate segment 2 and 3, and follow-up scan shows there's no evidence of recurrence or distant metastasis, and the alpha-fetoprotein remain normalized until 1 year follow-up up to now. Well, since we talk about malignant hepatocellular neoplasm not otherwise specified, I thought my presentation would be incomplete without mentioning the imaging features of this tumor. As mentioned by Dr. Chia just now, it is a rare liver tumor diagnosis combining features of both hepatoblastoma and the pediatric HCC. It mostly affects slightly older children, and the possibility of HCN-NOS should be considered in pediatric patients with liver malignancy, especially those older age group, and they tend to have very high levels of alpha-fetoprotein. But radiologically, it typically presents as a large heterogeneous liver mass with mixed solid and necrotic areas showing variable contrast enhancement on CT or MR. But again, imaging alone cannot definitively confirm the diagnosis, and often a tissue diagnosis is required. So I have three images of our patient here in Sunway with confirmed diagnosis of HCN-NOS. So the first child is a 2 years, 10 months old child. It's a referred case from outside hospital. So the ultrasound from outside showed a suspected liver mass in segments 5 and 6. So we did CT here in Sunway Medical, and it shows a large esophageal solid, predominantly solid mass involving segment 5 and 6 with minimal central hypodensity area within it, indicating central necrosis. The tumor size was 12 by 8 by 10 centimeter, and the pretext was pretext 2, P and V negative, and there's no evidence of metastasis. This child had alpha-fetoprotein of 1,900, and as I mentioned, this is a confirmed case of HCN-NOS. This is another second case. It looks almost similar to the first case. So this is a 6-year-old boy who had an ultrasound from outside showing a liver mass. And our CT findings shows this a rather solid, heterogeneous, lobulated mass with minimal central hypodense area indicating necrosis. So the tumor involves segment 4B. Okay, so the size is about 8 by 7 by 8 centimeters. The pretext is 2, P and V negative, and there's no distant metastasis. The patient went upfront surgery of liver tumor segmentectomy involving segment 4B. It's another child who presented to us, a 4-year-old boy with persistent fever for 10 days. So again, as I mentioned, the presentation in children, they tend to be variable. So this one is fever rather than abdominal mass, but incidentally on examination noted to have hepatomegaly, and the liver was palpable 4 cm. So ultrasound shows an enlarged liver for age, measuring 13 centimeter in span, and there's a large heterogeneous mass in the right liver lobe with a few small hypoechoic area indicating necrosis of cystic component. And you can see when we turn on the color Doppler that the portal vein are being displaced by this mass. There's minimal internal color Doppler signal within indicating vascularity of the mass. And of note, there's also a sub-centimeter portal hepatis node noted on the examination. So the imaging appearance of this patient is concerning for malignant liver tumor, and given the age group with suspected hepatoblastoma. So CT staging was done for this patient, and indeed it confirms the diagnosis of a large heterogeneously enhancing mass with central hypodensity within, indicating necrosis here. So it involves segment 7 and 8. The size is 11 by 9 by 10 centimeter. You can see that the portal vein, the right side is being compressed medially but remain patent. The main portal vein is patent. There's compression to the IVC lumen at the intrahepatic segment. The right and middle hepatic vein not well visualized. And there are a few portal hepatis node with an enlarged node measuring 1 centimeter in short axis. So the features are suspicious of hepatoblastoma, pretext 2, V positive, given that the IVC lumen is compressed, P negative, pretext annotation factor N with portal lymphadenopathy, and there's no distant metastasis. So this is a child who underwent neoadjuvant chemotherapy, but the alpha-fetoprotein doubles. And the interval scan shows marginal interval increase in size of the tumor. So he immediately underwent right hepatectomy and unfortunately developed relapse in the lung, 3 mm nodule, and currently doing well, I think, in Shanghai. So of course, multidisciplinary management of pediatric liver tumor is important. For our side, the radiology, we contribute to the diagnosis, staging, if need for biopsy, of course, surgical planning, monitoring of chemotherapy response, and surveillance for recurrence. And MDT collaboration, vitals between the pediatrician, surgeons, oncologists, pathologists, interventional radiologists, nurses, and many other staff. And imaging is not just diagnosis, but it basically guides the treatment pathway. So the take-home message, ultrasound is the first-line imaging modality. MRI and CT are central for characterization and staging. Pre-test staging guides the management. Vessel involvement must be carefully assessed. Imaging findings directly influence surgery and oncology decision, and early multidisciplinary collaboration improves the outcome of these patients. With that, I thank you.
Thank you, Dr. Marina, for that excellent presentation on imaging. We'll move on to the next speaker, who is no less important in this management of polycystic liver tumors. Is Dr. Lutfi, who's a pediatric anesthetist, who had training in Auckland, New Zealand, as a fellow there. Again, I've had the pleasure of working with Dr. Lutfi. Seems that we've transferred all the HTA team to Sunway. So it's interesting that not many people look at anesthesia as an important component of this, but rest assured, for surgeons, anesthetists are very important. Dr. Lutfi?
Thank you very much, Dr. Zakaria, for the kind introduction. I'm Dr. Lutfi. I'm a pediatric anesthetist here. We have a great team for pediatric anesthetists in here. We have 3 of us. So we work together and share the burdens of the work, especially in the major surgeries in pediatrics. Okay. So I'm going to talk about the anesthesia for pediatric liver tumor resections. As pediatric liver tumor undergo liver resection is one of the complex surgery that carries significant risks. Okay, multidisciplinary team effort involving oncologists, surgeons, radiologists, pathologists, blood banks, transfusion specialists, and anesthetists and intensivists play a major role in terms of safety of the patients undergoing surgery and also the fast recovery for the patients as well. So I mentioned before for the previous speakers that the tumor pathology, hepatoblastoma and also hepatocellular carcinoma. So for the hepatoblastoma, most of the time the patients is younger patients, less than 3 years old, and hepatocellular carcinoma involve patients that are older patients, yeah? And some of these patients may have a background of metabolic disease as well. So it is important for the anesthetist to review the radiological imaging as well. It's not just thinking about my part, okay? Because we have to know in terms of the extensions of the tumors, and for example, the extent of tumor, whether it's close by to the major vessels or not, so that we can have a proper preparations, how much blood you want to prepare, whether the patient is anemic, need to be transfused preoperatively or not. So this is a very important information to review all the investigations done before. And some of these patients may have neoadjuvant chemotherapy, and some of this chemotherapy may affect certain organs, for example, cardiac, cardiomyopathy, renal dysfunctions, and also the disease itself, extension of the disease may have involved in the liver dysfunction as well. So preoperative risk assessment, like history, physical examinations, and also to review the information from the investigations. So for the respiratory part, it's very important for the anesthetist because we are handling airway, breathing, circulation. So for the respiratory part, big tumor, pushing the lungs up, okay, the lungs become smaller, this patient going to descend easily. Okay, once we induce patient can descend easily. So it's important to know whether is there any other problems with the lungs, lungs already small, is there any metastasis, is there any pleural effusions that we may optimize the condition preoperatively. So the plan for this is a rapid sequence induction. We have to induce the patient intubate immediately. Even that also will carry significant desaturations, after intubations. For the cardiac, as I mentioned, chemotherapy drugs may affect some of the cardiac functions, cardiomyopathy. So it's important to have a baseline echocardiogram prior to surgery. Hepatic reserve, the tumor may burden the liver functions, patient may have coagulopathy preoperatively. So we have to know the baseline coagulation profile, INR, fibrinogens, and also the tumor markers as well. So renal function, okay, the bloods for the renal function to evaluate baseline GFR, electrolytes, for example, calcium, magnesiums, and also other electrolyte, potassium and sodium as well. So these patients, liver patients, liver tumor patients, they may present, they are cachexic, they loss of weight. Sometimes they have significant electrolyte abnormalities that we can optimize preoperatively. So for the vascular access, the plan for vascular access, basically for us, upper extremity access only, hands and neck, okay? There's no use for the lower limbs. So very limited choice for us, okay? So we place a large bore peripheral IVs and central line strictly in the upper limbs and neck, okay? So for the central line, we're able to measure central venous pressure. So it is a bit controversial whether it's reliable or not to measure CVP in this kind of patient because of retractions, because of the ventilation application of PEEP, but we still use as a guide the trend for this. So aiming for the low CVP by restricting the fluids during parenchymal transections, which lowers the hepatic vein pressure and drastically may reduce the surgical venous oozing and bleeding. Okay, invasive arterial line, arterial blood pressure, enable us to measure beat to beats blood pressure, stroke volume assessment, and also enable us to take multiple blood samplings intraoperatively. So in certain centers, advanced hemostatic monitoring may be needed. For example, viscoelastic testing, TEG, ROTEM to guide goal-directed blood product replacement for this patient. When we anticipate blood loss, a lot of blood loss, it is good to have guidance, directed guidance for our transfusion strategies. And for anesthetists, we have to have a close communications with the surgeons, what stage of surgery they are doing now. Okay, sorry, okay. So vascular clamping is a part of it, okay, during the surgery. This is in order to assist with the liver resections, reduce the blood loss. So a few types of occlusion, vascular clamping. One is the Pringle maneuvers. So involve hepatic artery and portal vein, which is a portal triad. So what are the impact on the hemodynamics? So we are anesthetists, we like about physiology, we like about the pharmacology also. So we have to understand very deeply what happened when this procedure happening, okay? So for the Pringle maneuvers, mean arterial pressure will increase 10 to 15%, systemic vascular resistance increase to 40%, okay? And slightly reduce in the cardiac output. So patient may tolerate well in the short intervals, for example, 15 to 20 minutes of Pringle maneuvers, and but we have to be vigilant where once the occlusions is released, there will be a ischemia reperfusion where patient may develop severe hypotension. So we have to crank up our vasopressors, give a bit of volume prior to unclampings. The second one is a total vascular exclusions where they involve portal triad, supra and or intrahepatic inferior vena cava. And this may give a huge impact on the hemodynamic. Preload, blood return to the heart may reduce dramatically. Cardiac output will decrease up to 50%. There will be severe hypotension. So usually what we do is we communicate each other, can we test clamping first? Okay, we test clamping before clamp and resections. So we test clamp whether the patient can tolerate or not. So give us time to load the patient with the fluids, load the patient with the blood prior to clamping. So we will increase the inotropic support prior to clamping when we anticipate hypotension during these maneuvers. So the last one is the selective vascular occlusion, where the occlusion of the specific lobar or segmental branches, and not much of in terms of systemic impact for this clamping. All right. So we just continue with the anesthesia. So massive hemorrhage protocol. So when we anticipate, actually this is not my slide presentation actually. So for when we anticipate the bleeding, okay, what are the complications? I missed out one slide, okay. Complications for the liver resection, one is the difficulty ventilations, okay. Difficult ventilation where the patient's is abdominal distended. Once we induce it, we have difficulties in ventilation until the incision and the liver, part of the liver is out. So that's the ventilation will improve. Second is the liver resections bleeding. Okay, anticipate bleeding, especially when preoperatively there's evidence of liver ruptures, tumor ruptures, where you have little control of the blood loss, So, so massive hemorrhage protocol can be activated, or we inform the blood bank, this is what we want. We want certain numbers of red blood cells and blood products, FFP, platelets, and also cryoprecipitate. So we want we don't want to be to get this blood and blood product on time when we want it, and we don't want to be delayed. So these communications with the blood bank is very important. So the use of guided rotum and TEG to guide us when we can give other blood product, for example, cryoprecipitate or fibrinogen concentrate, to apply prothrombin complex concentrate. And the use of antifibrinolytic therapy, we can give bolus at the beginning of the surgery, prior to skin incision, and it will be followed by continuous infusions. That's evidence where it can reduce the rate of blood transfusion when the administration of a tranexamic acid. And the last one is to avoid the lethal triad. Continuously during the surgery, we try to prevent hypothermia, treat this metabolic acidosis, and also look at the electrolytes, especially the calcium, during these massive blood transfusions. There will be risk of hypocalcemia, which may affect our cardiac contractility. So we have to be alert and take the bloods regularly to see the ionized calcium. What other things to look at is the glucose regulations. Intraoperatively, patient may need maintenance of dextrose solutions intraoperatively, because not happen in other surgeries. Most of the patients are well, not needing any glucose maintenance intraoperatively. But for these patients where the liver may be dysfunctions and there is high risk of hypoglycemia due to loss of hepatic glycogens and impaired gluconeogenesis. So continuous dextrose solution is mandatory, and also frequent measurements of the glucose in order for us to manage the glucose levels. Okay, electrolyte management, as I mentioned, rapid or massive blood transfusion may cause, may chelate the ionized calcium. The calcium may be low, ionized calcium. So proactively replace the IV calcium with the IV calcium chloride or calcium gluconate to maintain the cardiac contractility. Active temperature control, because the surgery is a big wound, the open abdomen, there will be significant loss of heat, and patient may develop a hypothermia. Hypothermia is not good. It goes into a cycle where it can cause coagulopathy and cause more bleeding. So actively we need to warm the patients, underbody forced air warmers, fluid warmers, elevated ambient temperature, or operating temperature also can be done. And the last one is the acid balance, frequent ABG, taking the ABGs, looking at the lactate, tissue perfusions, base deficits, and also looking at the electrolyte, especially after reperfusion, whether you may get hyperkalemia for these patients that may cause arrhythmia. So we have to treat actively for this. Last one is, the next one is the vascular air embolism. For the risk factors for the vascular air embolism during the liver resection, one is by maintaining the low CVP and the presence of surgical tear at the cavo-hepatic junctions. And this can cause a negative pressure gradient to your heart, and there will be a suck of the air and the accumulation of air, which may cause vascular air embolisms. What are the signs? Sudden, unexplained end-tidal CO2, drop in end-tidal CO2 and profound hypotension. So if we suspect this possible vascular air embolism, so we need to inform the surgeons, because this is a crisis, and we have to flood the surgical field with the salines. If possible, position the patient at the left lateral side and head down, Treadle-Lambert position, and give 100% oxygen and aspirate the central line if you can get any aspirations of the air. And because this is a big surgery, the wound is big, okay? So we have to properly plan for the analgesia strategy, okay, multimodal analgesia. If the patient has no coagulopathy and anticipated the surgery is straightforward, we may consider thoracic epidural or caudal epidural. There's advantage for this is a superior coverage of the somatic and visceral analgesia, and to facilitate early extubations, okay? But bear in mind, when there's a massive blood loss, there will be transient post-operative coagulopathy, and this may increase the risk of spinal hematoma. So there's a strict criteria to remove our epidural catheter after 72 hours. So we need to correct the INR and correct the platelet as well to get the platelet more than 100,000. Before we can remove the catheter. So sometimes epidural is not a first choice because some of these patients have coagulopathy already contraindicated. Okay, we don't want to mess around with this. We want to get more complications. So we have other options. Okay, the next option will be a plain blocks. It is ultrasonography guided trunk blocks. We give local anesthetic to certain parts of the body to cover the wounds. And ESP is a erector spinal block, transversus abdominal plain block, and QL is the quadratus lumborum block. But these blocks, some of these blocks only cover the somatic, means the skin only, not the visceral inside. And it requires administration of huge amounts of local anesthetic. So as I mentioned, local anesthetic is metabolized by the liver. So we have to look for any toxicity, local anesthetic, systemic toxicity, if we give this epidural and also the blocks also. And the last one is IV multimodals, the use of opioids, fentanyl, morphine, low dose of ketamine, and IV paracetamol can be adjusted to the dose. We can give a lower dose with the increase in intervals. May not burden the liver, and also the IV Presidex also can be useful now. All right, and the last one is the NSAID. Try to be cautious with the NSAID. NSAID can impact our renal functions. NSAID also can cause bleeding if there is any evidence of ongoing bleeding. Okay, this is the last one. At the end of surgery, we have to evaluate whether this patient can be extubated or not. What are we looking at? One is the stability of the patient, hemodynamic, any inotropic support, any event during intraoperatively, any ongoing bleeds, whether any acid-base, metabolic acidosis, and also whether hypothermia as well, because this will affect our extubations, and sometimes may fail extubation with the patient with hypothermia also. All right, so if there is any of this, we might choose for the weaning in ICU, ventilate and weaning in ICU until we stabilize the patient, we get to all the supports to the minimum, and we wean in ICU. So continuous care in ICU to conduct serial coagulopathy screening, maintain dextrose solutions, and also surveillance of any ongoing bleeding. And later on, we can start with looking at the liver regeneration markers and looking for any late complications, for example, biliary leaks, ascites formations, and also we'll start feeding when the patient is able to. And the last one is the catheter safety, as I mentioned before. Try to optimize or normalize the coagulation factors, coagulation profile, before removing any epidural catheter if there is any. And that's all for my presentations. Thank you very much.
Thank you, Dr. Lutfi, for that excellent presentation. We move on to the next member of the team, Dr. Sia Hui Hui, who's a pediatric pathologist, and I believe she's the first pathologist in Malaysia to make this diagnosis of HCN NOS. I mean, from the time I started doing this work till last year, I don't think we've ever made this diagnosis. And I know that it's been diagnosed many times in overseas, but the first case that Dr. Chia mentioned, the case from Terengganu, was the first time ever it was done here. Chia? Dr. Sia, again, is a member of the team in HKL, HTA, and I've had the pleasure of working with her for a long time.
Good morning, everyone. Okay, let me move on to this. Okay, so today I'm going to talk about continuing from the presentation by Dr. Chia and Dr. Marina. So I'm going to continue about the pathology of HCN NOS. So between hepatoblastoma and HCC in pediatric, so now we are trying to navigate the diagnostic gray zone of what we call a HCN NOS, okay? So as we all know, pediatric liver tumor is very, very rare. And among the rare liver tumor, hepatoblastoma is the commonest, followed by pediatric HCC. So I will not elaborate more on this because it has been previously said by Dr. Chia. So we all know about all this epidemiology of hepatoblastoma. So what I'm going to show you now is a basic introduction to how hepatoblastoma looks like under the microscope. Because essentially, the diagnosis has to come from the histology of the cell, okay? Now this is the Bible that is used by all pathologists. We have the WHO Blue Book, and in a very recent progress in the realm of pediatric is that finally, after so many decades of WHO Blue Book, finally there is one Blue Book that is titled Pediatric Tumor. And because it is so massive, because pediatric is defined by age, not by organ, and therefore this book actually has 2 volumes, and which is part A and part B, encompassing about 1,000 pages and detailing about all the tumors that can happen in a pediatric age group. So in this, we can see that for hepatoblastoma itself, the range of, it's very heterogeneous. So when you look under the microscope, we can actually see 10 types of different morphology in hepatoblastoma. And it is also because of the heterogeneity of this morphology that we can give a diagnosis. When we see that there's so many different types of cells in one single tumor, we can call it hepatoblastoma. So namely, the most common is fetal type. We have this pure fetal type, well-differentiated cell, crowded fetal cell, pleomorphic cell, embryonal cell, small cell undifferentiated cholangioblastic mixed epithelial type, as well as they have a mesenchymal component, right? So I'm going to show you now what we see under the microscope. So I think this is very rare for all of you because you don't deal with this, okay? So bear with me, we'll have a lot of pink and purple in my presentation. So basically in a hepatoblastoma, you see that there are a progression of tumor cells. So they have a very immature component called the embryonal cells that does not look at all like hepatocytes. So as in the same tumor, this is from one single same patient. In that liver tumor, you see one area that looks like this, which is embryonal. And then you see another one that from this embryonal is slowly transitioned to become slightly like a fetal type of hepatocytes. And as they progress further, they become more matured. They become the well-differentiated fetal cell. So when we see this kind of a constellation of histology, we call it hepatoblastoma. especially when the children is less than 2 years old and the main tumor bulk is within the liver. So there's no problem in calling this a hepatoblastoma. And the bonus would be if the tumor also had a mesenchymal component. So mesenchymal means it's derived from the, so for embryology, we have cells that develop from the ectoderm, mesoderm, and endoderm. So from the mesoderm part of the embryology, they develop into soft tissue, bone, cartilage, and all that. And if we see bone and cartilage in the tumor, this is 100% hepatoblastoma, all right? Okay. So that is the introduction for hepatoblastoma. If I see cartilage and bone, no problem, hepatoblastoma, okay? Now what about HCN-NOS? So in WHO, the definition is actually a provisional category. That means the name is given provisionally because not enough is being known about this tumor. So for now, it's called not otherwise specified because it sits in the gray zone between hepatoblastoma and pediatric HCC. Why? Because under the microscope, this tumor cannot fit neatly into either hepatoblastoma or HCC, all right? So in the olden days, it's called transitional cell liver tumor. That is by morphology itself. So for the past 10 years, we have now come up to an era of medicine where next generation sequencing now is playing a huge role in identifying tumor and making it more specific so that they can have targeted therapy, all right? So with the advent of this next generation sequencing, we get to know more, and therefore we now know that there is a group of liver tumor in pediatric that is not really hepatoblastoma, and that is also not really HCC, but in fact sits in between. So I'm going to elaborate more. Now, what is the histology of HCN-NOS? So this picture comes from one same patient. This is a patient in HTA. So she has one liver tumor. But in that liver tumor, you see that one part of it has that a lot of histology that I show you about hepatoblastoma. There is this embryonal feature. Beside the embryonal cell, there is this crowded fetal hepatocytes. And in another area, there is this well-differentiated hepatocytes. Yet, in another area in the tumor, you see that the tumor cell now has morphed into looking quite like a matured liver cells. So you see that they are already forming a sinusoid. Sinusoids are small capillaries in between the liver cell plate, and also they have canaliculi. So canaliculi is where a draining of a bile that is synthesized by the liver, and you even see bile pigment. So these are things that we don't see in hepatoblastoma because hepatoblastoma is an embryonal type of tumor. They are not matured enough normal liver function, all right? So in this same tumor, we see this kind of HCC-like area and a HB-like area. And the most important is, usually these cases, there is no mesenchymal component. So these are the cases that will make life more difficult for me because without the bone and the cartilage and with this kind of varied morphology, is this HCN-NOS? All right, so in pathology, I rely now more on ancillary testing like this. This is called immunohistochemical stains. So for a straightforward outright hepatoblastoma, we do not need IHC. But in the case that if I'm suspecting HCN-NOS, I would have to do a lot of stain. So these stains actually are used to see what protein is being manifested on the cell of the tumor. So now in the same tumor, you can see that this panel on your right is the morphology of hepatoblastoma-like area, whereas the left is the HCC-like area. You can see that in the same patient with the same tumor, there's actually two distinct types of staining pattern for the same kind of IHC. You see beta-catenin, so hepatoblastoma and HCN-NOS has a mutation in the gene called CTNNB1. So when you have that mutation, it will manifest in this protein called beta-catenin.
and it should be positive. But in this tumor, there's one area positive and another is negative. And so is ATRX and glypican 3. So this is another picture to show that in the same tumor, we have a very embryonal area on the left and a more well differentiated area on the right, which looks like HCC. Okay. Yeah, so this is what I've said before. And again, this is a second patient from Sunway. And you can see that the same tumor actually has a very distinctly different kind of immunostain, although it's the same tumor, okay? All right. This is a special stain of reticulin, which is green in color here. Now, when it becomes more differentiated, like hepatocellular carcinoma, the reticulin will pick up the sinusoids. So when you see this, you can see that, oh, there is sinusoid in between the hepatocytes. Whereas for the HB-like area, there's no sinusoid formation at all. So you do see a distinct two population of cell in the same tumor. Okay, so IHC is really a very essential adjunct in delineating the HB-like and HCC-like components, and therefore facilitating the diagnosis of HCC and NOS. Of course, before we do IHC, morphology is still the most important, all right? So when to consider for me, in my part of my job, is that I consider using all the IHC, especially when it's just pure epithelial type of tumor cell without cartilage, without bone, okay? Now, previously I mentioned that I did the IHC of this ATRX. So it's very fortunate that here in Sunway as well as in HTA, we have this stain called ATRX. There is not enough, there's actually no published paper at all about the utility of ATRX stain, but I find it useful that for HCC and NOS, it often shows retained nuclear staining in the HB-like area and loss in the HCC-like area. So if you read up about the molecular pathology of hepatocellular carcinoma, there's a lot of mutation. And one of the mutation is this mutation in the gene of ATRX. However, does the mutation in the gene of ATRX translate into expression of the protein on the cell? We do not know yet because there's no published data on this. But sometimes I use this when I'm in a dilemma, and sometimes if it gives me this kind of very contrasting negative and positive in the same tumor, it helped me to err more towards HC and NOS, okay? So this one is a paper that I believe was also shared by Dr. Chia. So it is just a guide, it is done in Korea involving about 148 patients in the span of 33 years. So this paper is good because now, as I said, next generation sequencing is the fashion now in medicine. And so Korea, they fish out all the old cases of hepatoblastoma in the past 33 years, and they run genetic sequencing in all the tumors. So they found that there are 21 patients that they can categorize it as HC and NOS because of the different molecular profile, okay? So what is the molecular profiling of HC and NOS? So HC and NOS actually share a genetic alteration similar to hepatoblastoma, which is the CTNNB1 mutation. So suggesting that both these tumor actually is a WNT pathway-driven tumor. So WNT is a pathway in our cell that regulates the differentiation of cells into various different organs, all right? But they also found that from the sequencing that HC and NOS, this tumor, actually besides the the CTNNB1 mutation, it also has additional mutation
more than hepatoblastoma. And this includes the third promoter mutation, BRAF, NRAS, and KMT2D mutation, which is only exclusively found in HCN NOS. So summary is, as a pathologist, when do I consider to put in this diagnosis of HCN NOS? Because it is a very new entity. It is new because now we have more next generation sequencing that is made more available and cheaper, and therefore most research hospitals get to have this machine. And so with more people running it in research hospital, the more they found out about abnormal mutation, and therefore they come up with this provisional diagnosis, because I think the cases are not enough now to call it outright what this truly is, okay? So when do I consider a diagnosis of HCN NOS is, especially when the age of the patient does not fit into hepatoblastoma, which is more than 5 years of age, and serum AFP level has to be raised, because, more markedly raised compared to a HCC in a pediatric, because it shares a similar age group as HCC. And also no underlying liver diseases, because most pediatric HCC has underlying liver diseases such as biliary atresia, Alagille syndrome, also some metabolic liver diseases, and quite a lot has hepatocellular adenoma in the liver as well. So if they don't have this underlying liver disease, then we can consider a diagnosis of HCN NOS. And by HPE, so once I've considered all the age, the AFP level, the liver, the background liver condition of the patient, by histopathological examination, I have to see two distinct areas of the same tumor, which is the HB light area and the HCC light area. And kind of tumor would essentially need immunohistochemical staining. We do not have NGS here yet in Malaysia for pediatric, unfortunately, and which is why I rely a lot on IHCs, okay? So of course, ideally, in the world of medicine, it would be best to have molecular testing, because HCN NOS is found to have it's a very unstable tumor, has many type of mutations, as well as copy number alterations. So that's the end of my presentation, a bit about that. And so these are the three main papers that I refer to for this presentation, and you can have a look if you're interested. So thank you.
Thank you, Dr. Sia, for the presentation. I'm sure we've not heard the end of this pathology for HCN NOS. As mentioned, is something that is in evolution. So I'll invite the next speaker, Dr. Yap Xiao Yi, who's a pediatric hematologist oncologist, and she's American boarded in both pediatrics and sub-boarded in hematology and oncology. And she's had extensive training in Cleveland Clinic in the US. And arguably, pediatric oncologists would be central to the treatment of these pediatric liver tumors. May I invite Dr. Yap to deliver a talk?
Thank you, Dato Zakaria, for the introduction. I think he was very generous to say that pediatric oncologist is central, because I think this case, as you can see, I'm the 5th speaker, and there's another speaker after me, which is the 6th speaker. So for one topic, we have 6 speakers, and we have to condense everything to 15 minutes, which is not easy. So this really, truly highlights how important multidisciplinary care is in patients. And I must say, we're very lucky here in Sunway, because without the preceding speakers, really we can't treat the patient. Every component is just as important. And as I will highlight in my talk, the next speaker is also very important, liver transplant in the management of these patients. So I would truly want to thank all of you for spending a Sunday morning with all of us here talking about liver tumors. And I'm going to talk a little bit about treatment of HCN-NOS. So as Dr. Sia mentioned earlier, so we know that this is actually a very new entity. And it was first described in 2002 by Dr. Prokurat in Poland, in Warsaw, where he noticed and reported 7 cases of very highly aggressive liver tumor in older children. So older children, adolescent children, and at that time he reported it as a new entity and called it transitional liver cell tumor. At the time, there was some controversies because 3 out of the 7 patients had pre-chemo biopsy. The rest of them did not. And it's not unusual for us to treat the patients without a biopsy, particularly if you have raised AFP, even in the current protocols, because hepatoblastoma is the most common childhood liver tumor, despite it being a rare disease. So in 2011, the Children's Oncology Group, a large conglomerate of oncologists in the US, what they did was they sponsored an international pathology symposium in Los Angeles. And they had multiple different consortiums. So the German group, the European group, the American group, the Japanese group, they put all the pathologists in one room, review more than 50 cases, and then come up with a unified classification, for which I can only imagine, all the pink purple slides that they have to review. And then the first publication came out in 2014. So that's the first international pediatric liver tumor consensus classification. And at that time, they changed the name from transitional liver cell tumor to what we know today as HCN-NOS. And of course, given better classification, then now we can study a little bit more about the tumor. So the FIT trial, the Pediatric Hepatic International Tumor Trial, then launched international trials looking at these groups of patients, the HCN-NOS, treating them with more aggressive hepatoblastoma like chemotherapy. And as also Dr. Sia mentioned, and she showed you the 2 volumes. So this was only put in the WHO classification 4 years ago. So you can see how new this diagnosis is. And we have heard from all the previous speakers, we know that HCN-NOS kind of lies in between hepatoblastoma and hepatocellular carcinoma. One of the earlier, so there aren't many description of these tumors. So many of them are just case series, and a lot of them are just retrospective case series. So this was one reported in Children's Hospital Los Angeles, where Dr. Zhou looked at their series of liver tumors, for which they found 11 patients with HCN-NOS. And if you look at this group of patients, they have raised AFP. They tend to have higher pretext tumors. And this series reflects our very small series of 4 in the last 12 months. 1 female among all males, all right? But this is not reflected in the Korean population, as I will show you. So this is the Korean paper that's been previously shared with you by Dr. Xia and Dr. Sia. You can see that it's about 50-50. It's not, generally it's slight male predominance, but they have 47% of patients who are females. And they all have elevated AFP. They generally tend to have larger tumors, and most of these are very aggressive, so there will be portal vein invasion and, metastases at the time of diagnosis. All right. What about molecular profiling? It's always nice to talk after the pathologist, because then I don't have to explain anything about molecular profiling, which flies above my head, right? So what we know is on IHC, they tend to have nuclear staining of beta-catenin, similar to the hepatoblastomas, right? And as Dr. Sia mentioned earlier, they also tend to harbor mutation that's similar to hepatoblastoma, which is the Wnt pathway as you see in the IHC, so the CTNNB1 mutation, but they tend to also have, similar to HCC type, So very aggressive mutation. So they kind of like in between. They have both the mutations. And they have a lot of chromosomal number alterations. These are very, very unstable tumors. And if you look at the tumor mutational burden, in fact, actually you see that HCN-NOS is higher even compared to HCC in this cohort. So what we know that they behave somewhat like, morphologically, they look somewhat like more closer to HBB, but they also have hepatoblastoma, but they also have genomic features that show that they are very, very aggressive, highly unstable tumors. So in terms of treatment, generally, I would say the mainstay of most solid tumor is a combination of surgery and chemotherapy. And surgery plays a huge role in these solid tumors. If you remember my timeline earlier, the FIT consortium came up with a trial to look at these patients. And that was done in 2017. So last year, they published their recommendations, so a global consensus to help oncologists around the world treat these patients. And their recommendations for HCN-NOS is to treat these patients with one of the high-risk hepatoblastoma chemotherapy protocol. You'll see that they will recommend the SIOPEL-3, which is the standard risk hepatoblastoma, but the high risk arm. So it's using super Plato, so cisplatin, carbodoxorubicin, 5 cycles of these chemotherapy, or the American arm, which is the C5VD, so cisplatin, 5-fluorouracil, vincristine, doxorubicin, 6 cycles of this chemotherapy, or the high-risk SIOPEL-4 chemotherapy, which is Plato, cisplatin, doxorubicin, followed by carbodoxorubicin, if the patient has complete total resection, including pulmonary metastectomy or any other metastectomy. So you have to remove all the metastatic sites. If you can't, and if you have incomplete resection, the jury is still out there. What's the best treatment for these patients? Because generally, their survival is actually very, very poor. So looking back at the Korean data, what happens to these patients pre and post chemotherapy, right? We always like to think, we're giving them chemotherapy, it's going to shrink the tumor. Yeah, not so much in this one, okay? So what we see is that about 60% of patients have tumor shrinkage. If you look next to it, the hepatoblastoma data, yes, you'll see that 90%, close to 90% of these patients have shrinkage of tumor, right? The pretext doesn't really change very much, so pretext, post-text, it doesn't change. The liver involvement is the same. And what is very worrying, especially for oncologists, is that when you look at the histology of the tumor, after chemotherapy, more than 50% of them are still viable. So you are looking at cells that basically laughed at our chemotherapy, right? They're just, nothing killed me, all right? So those are very, very scary tumors for oncologists, okay? If we look back at the CHILA, so the Children's Hospital LA group, you'll see that even at the time, before the recommendations, they were already using high-risk hepatoblastoma treatment protocol for these patients. So similar to our SMC patients, so the 4 patients here, we used high-risk hepatoblastoma chemotherapy for these patients. Interestingly, one of our patients is actually very young, so 2.5 years of age. And, so he is a young patient with, if you remember all the previous slides from the previous speakers, his alpha-fetoprotein is actually not very high. It's only 7,000. Okay, so he is a little bit of an outlier there. And then if you look at these patients, they're all managed with surgery. Most of them will have hepatectomies, trisegmentectomies, and in the LA group, 5 out of the 11 patients actually underwent liver transplant. All of the patients at the time of the publication of the LA group were in remission, no disease detected. And our patients, 2 of them are still undergoing therapy. The other 2 don't show any disease at the moment. So, whoops. Okay, if we look at the Korean group, you will notice that 60% of the patients underwent transplant as part of their surgery of choice, okay? And they publish their data comparing the mode of surgery in these patients. So whether it's the blue line, which is upfront resection, the red line, which is delayed resection, so with neoadjuvant following neoadjuvant chemotherapy, or the green line, which is liver transplant, you'll see that the survival of the patients with liver transplant is the highest. And a recently published paper by the Western Australian group, they reported a case of a pretext 4. This is a pretext 4 metastatic HCN-NOS, where they treated very aggressively with the AHOT, so the COG type chemotherapy. So they gave the patient 6 cycles of chemotherapy before resection of the metastatic lesions in the lung, followed by additional cycle of chemotherapy, then liver transplant, 2 additional cycles of chemotherapy, followed by, interestingly, sorafenib, which is a medication that we use for hepatocellular carcinoma patients. So they gave 6 months of maintenance therapy with sorafenib in this patient with very extensive disease, and this patient remained disease-free to date, right? My sort of final thoughts in this very short 15 minutes is that HCN-NOS, as we know it, is a very new entity. We're learning more and more about this tumor because of more molecular testing, next generation sequencing to understand that this is actually maybe a new entity, and the treatment of these tumors are not as straightforward as we'd like to think, because they respond to chemotherapy, but most of it is the hepatoblastoma component. But remember, they also have another component where they show hepatocellular carcinoma features. Those tumors generally don't respond very well to chemotherapy. So as treating doctors, we have to be very aware and anticipate resistance. So if the patient show blunted response, in which a lot of these cases that were reported, even in our institution, the AFP maybe, starts to dip, and then after that they raise, that's when you have to start thinking we have to change strategy and treat the patient a little bit differently. We prioritize surgery because mainly this is a surgical disease, and we should have a low threshold for liver transplant, given the data that I've shown you. And moving forwards, there are institutions coming up with new studies on how to treat these patients, because as we see and as we know, the current chemotherapy regimens that we have are not very effective against these tumors. So moving forward, treatment involving immunotherapy like PD-L1 inhibitors, VEGF inhibitors, or sorafenib targeted therapy to try to treat these tumors a little bit differently and target the HCC component to try to improve survival. And so with that, I end my talk, and I thank you for your attention.
Thank you, Yap, for that presentation. Our final speaker of the day will be Dr. Ampaipan Buntai, who's basically a liver transplant surgeon from Ramatibodi Hospital in Bangkok. It'd be interesting to listen to the talk because we've actually done a pediatric liver transplant for a tumor recently as well.
No.
So we're now just starting to go into the game. So I'm curious to know the experience in Thailand. Obviously, as mentioned by Dr. Xiao Yi, there's quite a number of publications now on the usage of, I suppose, primary liver transplant rather than a salvage liver transplant, which is slightly different for HCN-NOS. Dr. Ampaipan, floor is yours.
Well, thank you, Dr. Zakaria, for a very kind introduction. First of all, thank you for having me here, and thank you organizing people who are for the fantastic work to bring me here. Actually, I'm honored to share our experience in liver transplant. So this morning we have learned a lot, starting from the diagnosis, flow, and pathology, and also how the medics treated our cancer patient and why it's not working. So I'm here to share our experience with transplant in oncology patient where nothing's work. I mean, no surgical option, no more surgical option, no more chemotherapy to be offered. And well, I don't want to disappoint you, but sometimes liver transplant is not possible as well. But mind you, sometimes it's you don't even need a transplant because with all the technology, we can be, have other options, as I may say. But before that, I want to just mention this is my hospital that you're all welcome if you want to visit me someday. I'm from Bangkok, the boring city, I know. Yeah. So my hospital is close to the Victory Monument here. I think most of you guys have been to Bangkok before. So this is Victory Monument. Children's Hospital is somewhere around here, and this is the area. And this is the palace. So we're close to the royal family in terms of where they live. Yeah. So it's a small hospital. This is the father of liver transplant, Tom Stasso. Liver transplant was first success in 1967. I wasn't even born yet, but way ahead, 7 to 10 years before the heart transplant became possible. But then, because liver transplant wasn't really promising with the result at the moment, and the transplant surgeons always get the liver graft from a deceased donor, that's mean from dead people. So we always called a body snatcher. And liver transplant sometimes was named as the last torture patient ever gets before they eventually died. You see, the first result wasn't really promising. Tom Stasso didn't stop, so he flew all over the country, get the organ himself, and then went back to the theater waiting for the anesthesis procedure before he began the transplantation. Liver transplantation in terms of surgical technique hasn't changed ever since. We might do a bit of adjustment in the term of vascular anastomosis, but nothing major has ever changed. But what truly changed the prognosis of the transplant is the immunosuppressive that can make liver transplant become possible. But then, but you wanna start the program. Of course, you're gonna have a bad days. 80% of my days were bad. But then you just ignore the bullets. You do what you wanna do. You give the patients hope, and this thing will return someday. So what about in Asia? So transplant creeping the way to our Asia country in 1984, just after I was born. And Japan apparently and Korea, it's apparently the first nation that adopt liver transplant into the services. In Malaysia was reported the first transplant in 1993 in the private sector. And because of many reasons, things are slowing down also in Korea and China. Our experience, so we just celebrated our 60th birthday from my hospital last year. So after 60 years, transplantation program start somewhere between this. This is our first team. So I show you, not because they're my teacher, but also they're one of the pioneers who didn't stop. They ignored the bullets together. So this is a pediatric surgeon, my master. We have 2 pediatric surgeons, and she's a pediatric anesthetist, and there are vascular surgeon, and this is a GI pediatrics. So this is a cornerstone of liver transplant. You're gonna need them, convince them to join the team first, because without these people, transplant wouldn't be possible. So we started the program in 1987, and we perform, of course, first adult, and then the program evolved over year. And recently we have just done our second cases of robotic liver hepatectomy to, minimize the mortality to the donor. But then we are not stopping. And also other centers begin to encounter the program as well. So she was one of the first liver transplant. Was her. And I think she's one of the first few cases of our success in transplant, and now she's doing the PhD in the US. And one of them are actually a dentist now. So let's see the future. I believe that transplantation, well, it's not a cheap operation, but we are investing in the next generation. And this is priceless. So look at the number. We began the program in 1997, yeah? But then the program actually stopped because one of the first results during the first year wasn't really promising. We have like 90% of mortality, and it will decrease over time, I promise. If you don't stop, it will decrease over time. But during the first year, we just did, in 5 years, we just did 3 cases, and then we begin to do it regularly. So this was around the COVID area, so 2021, where the hospital tried to limit the resources because we have no blood. And then we try to maintain the program, but this is this year. We just did our 9th case this year. The problem is, of course, resources, because transplant consume a lot of resources, and we don't even know how to answer the director if they ask the question, why is it so expensive? Because it's a life, and life are priceless. We just say this. So most of our patients are BA patients, so nearly 80% are failed Kasai that were transferred from another center and the list for transplantation. We're doing mostly living donor. That means we have double the mortality. We have a healthy people who have kind heart to donate the organ. So we need to make everything as safe as possible. A primary liver disease have some, and you will see we did some of the hepatoblastoma transplant, which I will show you later if it's working or not. Our team currently is big. We have 5 surgeons with vascular surgeon, and also we include the plastic surgeons to the team, and also the intensivist and alliance. We would say alliance because there are a lot of them. I can say so we are still learning. Of course, it was me. You might not remember from I got bigger as I got older. So there was me. We visited the NCCSG in Tokyo, that is apparently the biggest liver transplant in Japan. And they offer, I think, regular transplant. I think they do it every day. And they have a very strong team. So we were fostered by an experienced center. And also, this is Professor Morio Kasahara. He's very good and he's very kind. So in the theater, so this is a Rama drape. We call this Rama drape because we designed it, and apparently cannot sell it elsewhere because no one does transplant anymore. So what happened in the theater? So we include the plastic surgeon. They work under the microscope in 99% of atrial anastomosis, because atrial anastomosis is one of the most common vascular complication that can determine life and death between, after transplantation. So we have a very impressive result in terms of vascular anastomosis. So that's why plastic surgeon can help. So hepatic artery reconstruction, usually we use We don't use the recipient vein graft since it's too small. So it's quite impressive when you look closely at the way they work under microscope. So this is a graft here, this is target, and this is the first anastomosis that you have seen in the previous slides, and this should be the inflow that we're gonna anastomose to the recipient artery. So so this is a final. This is one of the case, and you see when the anastomosis is complete, this is the graft, and this is liver graft, and this is the vascular graft, and this is the inflow. So you can use clip, and be careful if you use the vein graft from the lower limb, that it might have the valve that can obstruct and cause the thrombosis later. So that's how to cope with the artery. So bleeding, of course. Transplantation is no joke. We just complained with, I just complained with Hui Shang, my friend, that, yeah, I got a lot of bleeding during the hepatectomy for like 2 liters. I mean, like, well, 2 liters, it's nothing compared to this. It's nothing, but then you need to explain. So if you want to start the program, make sure that you have a very strong blood bank, that you have blood available at all time. In some good cases, and in most of the cases, the bleeding would be just 400-500. It's not a very much bleeding operation, but in some cases, especially the redo or a patient who had history of, recurrence of cholangitis or SBP, that adhesion would kill you in the theater, of course. So vascular complication has, I'll show you the statistic later. So in this very patient, I will show you that's the demarcation line here, and this is the normal perfusion. So we did 2 arterial anastomosis in this case, and 1 got thrombosed. And this is one of the urgency. And patient eventually need the second transplant from the deceased donor. So HIT is no joke. So I present this, my research in the mortality from vascular thrombosis is early detection and early treatment, early action. So in our center, we do every 4 hour Doppler ultrasound by the surgical team. And when we detect or suspected the thrombosis in the vessel, the action would be done within the day, immediately. So the graft swab was quite impressive. But then, venous thrombosis is another story. So this patient, initially, he has portal vein thrombosis. Stenosis, let's say, stenosis seen at the end of the first month after transplant, but then no one did anything about it. Before we can know that, the portal vein become obviously thrombosed. And patient developed portal hypertension soon after a liver transplantation. So we have to do a surgical shunt. In this case, we did the splenorenal shunt just to mimic, mitigate the portal hypertension. So this is the graph, this is renal vein, and this is kidney and the spleen. So we did the splenorenal using the cryopreserved vein graft. So I don't know about the Red Cross vascular graft. Is it available here or not? But in Thailand or in a country that they have a regular transplant program, when we have a deceased donor, when we procure all the organ, there will be a vascular graft that is left. So we keep it for these things. So hepatic vein and IVC is the first vessel that we anastomose during the transplant. From the Doppler ultrasound, this is the graph, IVC, this is the hepatic vein here. The IVC is like tiny circle here. So we know the stenosis, and then we confirm it with the CT scan. This is the IVC, this is hepatic vein. That we probably heard about it yesterday by the intervention. So this is IVC, this is a heart, this is the graft, and we place a stent across the stenosis part. Of course, patient was fine for a while until the patient grow, because the stent, it doesn't grow with patient. So we have a lot of problem, and we need to do a second transplant for this patient with the vascular reconstruction with the help of cardiac surgeon. Do the open heart, stop the heart, recon the suprahepatic IVC. That's one of the cases that teach us so much lesson. And we stopped using the stent ever because of this. Also, you have to consider about the infection. CMV is quite common in Asia. I don't know why, but it's reactivated in the patient after the initiation of the immunosuppressive. And it doesn't cause only infection. It's troublesome for the surgical aspect as well. So this is a perforation site caused by the CMV. This patient we had to reoperate for 7 times because of the perforation that caused by infection. So treating CMV is also expensive. Survival in our center is not reaching the standard just yet. So 5 years, like 88%. But the most mortality occur in the first year after transplant. So that is the list of the cause of the mortality, like infection and recurrence of the tumor, which I will show you later. For what about the bigger center, the graft survival is quite impressive, 90%, 95% in some center. And when you want to do a transplant, you have to benchmark with the registry, right? UNOS split registry. So now transplantation reaching 98, 94% in 1 in 5 years. Very impressive. Well, compared to what Starster had at that time, we were passed through all of the struggle. So look at the pathway that he led us. I mean, he created a lot of hope, and well, hopefully we can continue. But we create miracle, right? Miracle has cost, of course. So during our program, we spent around $7 billion US dollar. Yeah, it's during the program from 1997. So what do we get from? Well, thank you all the donors from the foundation. We still open even from the international donation. Are welcome. And of course, our health security system and also the public health. But operative cost is like 11%. So operation itself is not expensive. But we spend a lot of money on what? On this, So this is like an advertisement from the foundation. They use our patient as, donate and then, make their life better. So the money usually goes to medical expense, that is to treat infection, and also the immunosuppressive, and also ventilator, ICU, and imaging, and also it belongs to admission time. So the total cost in one admission would be this one, so 35,000 US dollar in like mean. But for the surgeon type, it's just, a cost of the Birkin bag, if you can buy it from the shop. But then for the second hand, it could be double. Anyway, the total cost, well, with longer admission time, that means the patients battle with something like infection or sort of complications. Of course, they consume more money. The mean age of admission in my center is, around 30 days. 30 to 45 days. But in some cases, we might have, 3 months of admission for complication. So if you want to start the program, my suggestion would be choose the right patient. Choose the easy one first, the one with healthy background, and the one who wouldn't actually disappoint you. So this, we host the like a thank you party, like conference every year to educate families and alliance, and also educate all the healthcare provider elsewhere to transfer patients. I'm lucky to work among the strong team with, this is our nurse coordination who gonna help all the make appointment with patients, contact patients, and help with the transfer system. So I will spend maybe 5 minutes just to show you the workflow. How can transplantation be involved in oncology setting? So we have a 1-year-old boy, pretext 3 with IVC invasion at the first diagnosis, as you might see. The weight now is 7 kilo. You see the Dr. Marina also explained us, right? This is the heterogeneous mass, this is calcification, and Dr. CF pathology, no doubt this is hepatoblastoma, and this is huge. And we got notified from the onco team that patient might have a transplant, might need a transplant at the end because the mass is so huge. But fortunately, liver hepatoblastoma is highly responsive to the chemo, so do not lose hope just yet. Because sometimes a complete tumor resection is not even that important. Yeah, there's a lot of reasons, like FIT trial, try to avoid liver transplant, but then for the liver transplant team, when you are a hammer, everything is a nail, right? You always have an idea that transplantation can cure everything. So, vascular malformation, just do transplant, liver hepatoblastoma, irresectable, just do transplant, things like that. But sometimes it doesn't really necessary. And you have to think about patient as well. So, all in all, tumor resection, a complete resection is not even the gold standard. Because in pathology, well, R1 resection definition is still debating. Whether it is like the tumor present at the inline or the tumor-free less than 1 millimeter, still consider R1 in some centers. So it's no consensus in terms of, definition of the R1 resection. So extreme liver resection has been introduced lately, like Hui Chang mentioned it late in the earlier presentation. Extreme liver resection contains risk of future liver remnant that might be not that sufficient, but then this is the associating, basically it's a stage hepatectomy. The first stage, you perform a portoid ligation and the disease or affected liver lobe and hope that you increase the portal flow to the remaining liver and hopefully it gets bigger, faster. Fast within 14 days. So you can do safely hepatectomy with the sufficient liver remaining. So they have to do 2 stages. So this FIT trial accept a positive margin and also ALLPS is a measure to avoid liver transplant. So sometimes transplant is not indicated, but sometimes it does. It have indications for liver transplant as well. So as you may see, large tumor or the risk of relapse or a vascular involvement. Because if you have vascular involvement, you need to remove the tumor with the liver en bloc and also the vessels. So you need a vascular reconstruction in that. So this patient, after the 3 cycle of chemotherapy. So you might ask me, why 3, right? Because we usually start at 6 cycle is the maximum. But then you've got to allow some time for the transplant team to arrange the preoperative evaluation, because we need donor, we need recipient, we need, time to evaluate. And, if you have a patient who might need a transplant later in the day, you should decide it at the very beginning of the treatment, not after 6 cycle, because the tumor itself will develop resistance and patient will recur after transplantation. So after 3 cycle, you ran another CT scan. My center still use mostly a CT scan. MRI is reserved for a patient with, do not look like a normal hepatoblastoma, or you want to evaluate the remaining future liver remnant, whether if it will be enough for patient or not. So after 3 cycle, impressive. So highly respond, because from the statistic, hepatoblastoma have a highest response rate during 1 to 4 cycle. So it's very high. So after 4 cycle, there's rarely a difference between in terms of volume or anything. So if it respond, it will respond in 4 cycle. So decided before 6 cycle, there'll be, as I mentioned, as consider transplant after the 4th cycle, because after this 4 cycle, you're gonna need at least 1 week to evaluate both, recipient and the donor. So in this very patient, you see the markedly decreasing size and number of the tumor, but we have the right hepatic vein ablation and IVC thrombus cannot be ruled out. So there's a vascular involvement. If you do only extensive resection, patient have a very high chance to recur because of the vascular involvement. So we decided to do the pre-liver transplant evaluation. So is living donor possible? That depends on how big is the patient. So left hepatectomy is the safest way to donate liver. And I think the weight of the recipient should not exceed 40 kilo, just to minimize, because from my experience, Asian always ladies, I don't know why, moms usually donate the liver. So Asian lady left lobe liver would weigh roughly around 300 to 400 grams, while the left lateral segment would be around 200, 180 sometime. So, well, you need to consider, is the living donor possible, or does your patient need a deceased donor? Was he or she is compatible for the ABO compatibility? Sometimes the blood group is not that difficult, is to understand, but yeah. And the donor suitability and risk, and also the variation, and also we need to evaluate the MRCP for the donor, to evaluate the evaluation of the bioduct. The portal vein is quite straightforward, but the bioduct is different story. And the liver steatosis, of course, because in this urgency liver transplant for the uncurable, unresectable hepatoblastoma, we have like less time to evaluate. So the left lobe of the donor was 300 something, with the lateral segment of 170. So we performed the reconstruction technique. We need to remove the IVC in this case, so the choice would be we use the graft. We have you can use Gore-Tex. The SVG, the saphenous vein graft is for the arterial reconstruction if you need to remove the artery. And then this is the iliac vein graft from the cryopreserve from the Red Cross that need to be defrosted from the nitrogen preservation, so that you need to plan in advance. And then when you defrost it, I always use the defrost words. When you defrost, it cannot be returned, so that patient has to pay for that. Well, we did the reconstruction. So this is a super IVC clumping, and then this is not the real that tumor patient. But this is just to show you that we have a bunch of exposed IVC here with this hepatic vein opening. This is to be tied up all that small, short hepatic veins. So this is before the reconstruction. Anyway, for the liver donor, for the deceased donor, we use different technique. For the tumor remove transplant for the hepatoblastoma, we usually use the anterior approach. That means we go from the anterior to the posterior side with the benefits of untouched tumor and try to control the vessel before. In this case, I already mentioned the vascular recon. So this is our patient 2 weeks after transplant. But unfortunately, did you see the liver graft here? And this is anastomosis. We have sort of stenosis. Unfortunately, our patient recurred because the chemotherapy was, patient developed a resistance to the chemotherapy and then eventually developed a recurrence. So outcome wasn't, well, it's good for the primary liver transplant. So if you decide to do transplant, please do it before the 4th cycle. Southwest liver transplant yield only, 70% in a very good center. And in my center, it's like less than 50%, unfortunately. So this is a bunch of people who give a call quite often. I would say often that I call my husband. But yeah, because we work together. And I would like to also promote my conference. We are hosting the World Congress of Pediatric Surgery, not this year, but in 2028 in Bangkok. So it's 2-hour flight. I will be happy to have you. But before that, this year, I'm hosting the hypospadias masterclass since we might have the urologist with us today. So I will leave the information with my friends and then to circulate to you guys. And hopefully I see you again in November. Thank you.
Thank you, Dr. Ampaipan, for that extensive review on liver transplant and the experience in this. Can I now invite all the speakers for a Q&A session? I think we are eating into tea time, but I suppose we should have about 5 minutes for questions and answers. 15 minutes. Well, the organizers have given us 15 minutes. Okay, this is the Q&A session. Can we start off with questions from the floor? Yes. There are also some questions online, so we will take all of them as they come.
Thank you for the talks. I learned a lot. Actually, when I was in America, I happened to talk, sorry, I got a bit of sore throat. I talked to a pediatrician from Philadelphia Children's Hospital. We had a long talk, and I think Philadelphia Children's Hospital is probably one of the best hospitals in the world. Even the Children's Hospital in London, Grand Osborne Hospital, when they have a problem, they refer to Philadelphia Hospital. And Philadelphia Hospital do very good frontier medicine research. And recently, they treated a urocycle case with CRISPR and was very successful. I also learned that Jude Hospital in America is probably one of the most outstanding cancer center for children. I read, and I saw a video that a Nobel Prize winner who worked in Gladstone Research Center in California.
Sorry, can I?
I'll ask this question, am I coming? He found that ApoBac is associated with cancer liver in mice. Can you explain that? ApoBac is associated with cancer, liver cancer in mice. Can you kindly explain?
Sorry, who are you directing the question to? And I don't think any of us are in a position to answer that question at all. I mean, we're not basically research scientists.
Oh, okay. But never mind. I think you know it's ApoBac. Huh?
No, I don't.
Okay. Thank you.
Yeah, okay. Any other questions that we can answer? That's a bit more relevant to what we have talk about. Okay, if there's none, or you all want time to take, I'll go through the online questions. The first question is for Dr. Marina. Is there a role of PET CT scan for pediatric, I suppose, liver tumor imaging?
Okay. PET CT is under a different subspecialty. It's actually under nuclear medicine. But here in Sunway, we do perform PET CT for our cancer patient and even in hepatoblastoma to look at distant metastasis elsewhere, for example, like the bones, which sometimes we might not be able to pick up on the normal CT.
Okay, next question is for Dr. Yap. What is your approach if a young child has an aggressive liver tumor with a low AFP?
So I think, as pediatric oncologists, we often encounter such situation. It's not very common. One of the things that I didn't have much time to talk about is that in these patients where they come in with a large liver tumor and they appear atypical, meaning they have low alpha-fetoprotein levels, generally, if feasible, we will perform a biopsy. And as you can see with the various presentations today, that often these tumor involvements are not uniform. Meaning, when you do a true cut biopsy, we're actually targeting a very small area. And the involvement of these tumors are not very uniform. And so, often when we look at the data pre and post treatment, so pre and post chemotherapy, so biopsy prior to chemotherapy and the histology of the tumor after chemotherapy following surgery can show drastically different histological appearances. And so, particularly in patients where they are a little bit atypical, if upfront resection can be performed, it's something that we often discuss, with the radiology team, with the surgical team, to see if that is something feasible. Because in atypical tumors, I think histology is very, very important.
Okay, in the past, we used to routinely do pre-op biopsy for all these liver tumors, even though with a high EFP. And as you can imagine, there is a risk of bleeding. And once they bleed, it can sometimes be very difficult to handle them, and they may need an emergency surgery. So the question to Dr. Sia is that, especially for HCN NOS, how good is a true cut biopsy in diagnosing it with a small sample?
Thank you for the question, Dato'. So as you can see from my previous presentation, in just that one single tumor in one child, there is a lot of variation in the morphology. So I would say if you give me a true cut biopsy, I will not be confident at all. I would say almost impossible to diagnose HC and NOS. And I would put a comment that you still need a very close clinical correlation with all the age, serum alpha fetoprotein and radiological imaging, because it's just too small to, this like a tumor that they excise and show to me, I have to gross like over 20 slides, and each slide actually show different morphology. So I have each slide is about 2 cm big of a tissue. 20 slides would be about 40 cm worth of a tumor. And then I see the variation in all the morphology. Yeah. Thank you.
Next question to, I presume, must be Chia. What's the commonest presentation of liver tumor in pediatric age group?
Yeah, for this, if based on the series that we have, actually most of them presented with abdominal distension. So unfortunately, because the child is small and sometimes they just appear a bit chubby, so it's not that easy. So that's why when they come to us, they always already have that huge liver tumor. So from a series we have, most of them abdominal distension with poor appetite, and some will have these already like secondary effects like anemia, poor weight gain, failure to thrive, things like that. Yeah.
Suppose most of them present with asymptomatic mass picked up by a member of the family. The next question is on HCC. I'm not sure who will answer this. For HCC, what's the prevalent rate? What is the prognosis after surgery, chemo, and radio? How long can patient live after completed treatment? Very difficult questions to answer. Pediatric HCC is not as common as you can imagine, and but the most important take-home message is that pediatric HCCs are not the same disease as adult HCC. They actually behave slightly differently, and there's been talks on this in the past, and what we do not really understand is do the adult criteria in terms of the liver transplant, which probably will be more in HCC compared to hepatoblastoma, are the criteria the same as adults? Adults have very, very strict criteria for transplants in HCC, which at the moment, I think many of the children, especially in the Eastern series, have off-label criteria. That means you're doing them not within those mentioned criteria. Anybody else want to comment on HCC?
I think, I agree with what Dato' Zakaria mentioned. HCC, thankfully, is not very common in the pediatric population, but it is a very difficult to treat disease. I think with the advent of next generation sequencing and more molecular evaluation of these tumors, it will help us understand a little bit more, because conventional chemotherapy really doesn't have a role, I feel personally, in HCC. They really don't respond very well. Although we still treat, based on the current trials, even based on the FIT trial, they do recommend giving chemotherapy to these patients, but generally these patients don't really respond very well to chemotherapy. And at present, I think if the patient does have localized disease, surgery remains the mainstay of treatment with a little bit of neoadjuvant chemotherapy. But I would say chemotherapy in general doesn't help very much. We're looking more towards like targeted therapy, immunotherapy in these patients. But before we start doing that, we need to understand the molecular background of these tumors, understand, NGS, and be able to get more information to treat these patients better.
I suppose one of the problems with HCC in Malaysia is that if you look at the public system, we only treat children up to the age of 12. And when you go to a private sector, the age goes up to about 16 to 18, depending on the hospitals. So the ones that we see and are actually being treated by adult HPV surgeon or adult oncologist. And as I mentioned before, I think the behavior of many of these are different. And we've had some, not all, response to chemotherapy in the same regime as what you would use for high-risk hepatoblastoma. So the resectability in a child, in an adolescent, is very different from an adult who usually have cirrhotic liver. And many of these adolescent HCC basically present on a normal liver as compared to an adult who is either Hep B or Hep C positive as well. Okay, next question is to Chia. Is fibrolamellar carcinoma part of HCN-NOS? Or I suppose Chia can answer that as well.
Yeah, in fact, this fibrolamellar is very, very rare, I think. Yeah, so based on the histology, I think very later Dr. Sia will explain further. From a journal, it says that, yeah, certain cases that the pediatric HCC, they may have these features of this fibrolamellar. Yeah, probably Dr.
Yeah, so fibrolamellar HCC is not HCN-NOS. It is quite a well-established diagnosis. It is a subtype of HCC with a very distinct histomorphology, that they have a lot of sclerosis and fibrosis within the tumor, and that is how it comes. And I think the prognosis is a bit different as well, but it is not HCN-NOS. It is part of HCC.
Okay, next question. What are the major causes of children hepatic cancers? Sorry?
I think every parent that I see that comes to me, whether it's liver tumor or any tumor, one of the questions they always ask is, what is the cause of their child's cancer? And, I wish we knew. I wish we knew. I think there's a lot of advances in the way we understand tumors with, as I mentioned before, more of these molecular testing and, genetic testing to understand, the genetic changes, the drivers of the mutations, the mutations that result in, mutated tumor suppressors. The more we understand about these things, the more we will learn about the causes of cancer. But at the moment, what we know is that, there are certain mutations that causes the cancer. Why these mutation happens remains a mystery.
Okay, in the interest of time, the last question is to Dr. Lutfi. May I know what are the post-op immediate ICU care for post-liver transplantation protocol for first 24, 48 hours as take-home message? Maybe Ampaipan can answer this as well. The first 24 to 48 hours.
After transplant?
Yes.
What is
for
it?
post-liver transplantation protocol?
Well, I'll focusing on the vascular complication and bleeding. You have to balance between protection of the vessel anastomosis versus severe bleeding caused by the coagulopathy of the patient. So while the patient has just passed through an enormous physiologic change during operation with a massive blood loss and also the transfusion, that you need to focusing on, make sure that your patient do not have coagulopathy and do not give the platelet and the FFP and also cryo at the same time, ever. You correct one by one, or else you're gonna have an acute vascular thrombosis.
Okay, thank you. So we finished the symposium on this HCN-NOS and the updates on that. Please express our appreciation to all the speakers in the usual way. Thank you.
Okay, thank you so much, distinguished speakers, and Dr. Zakaria. Would greatly appreciate if you can come to the side to collect your token of appreciation. And thank you everyone for sharing your insights and also facilitating such an enriching discussion. We will now have a very short tea break. Greatly apologize as the tea break will be cut a bit short as we are running short on time. Would greatly appreciate if everyone could be back in the hall by 11:40 for the next session. Until session, our moderator will be Dr. Yao Kian-men, a consultant pediatrician and pediatric nephrologist at Sunway Medical Center, Sunway City. He completed his specialist training in pediatrics at University Kebangsaan Malaysia, followed by a fellowship in pediatric nephrology in Australia. His clinical scope include congenital and acquired kidney disorders, pediatric urology, and the management of children requiring advanced renal care, including renal replacement therapy. Without further ado, please let us welcome Dr. Yao.
Thanks for the kind introduction. So I'll be chairing the session for the urology. Our first speaker will be Dr. Sri Hari Singaravil, who will be talking about the utility of urodynamic in children. Yeah, so basically, Dr. Sri Hari Singaravil obtained his basic degree from Sri Ramachandra Institute of Higher Education in 2001. Then later on, being the first pediatric surgeon, graduate from a master degree from University of Malaya. Yeah, he's a highly accomplished senior consultant, ped surgeon, and pediatric urologist. They're based in the Sunway Medical Center. He specialized in treating complex neonatal childhood urinary and bladder condition. And over the years, he has been a fellow in robotic surgery in children. Yeah. And so without further ado, I would like to invite Dr. Sri Hari to deliver the first talk. Thank you.
Hi, good morning, everyone. Thank you, Dr. Yao, for the introduction. So we see a lot of children who wet in our clinic, and I think that today I want to sort of demystify it a little bit to see how we can manage these children with urodynamics. So urodynamics describes function during storage and emptying. This term includes non-invasive assessment, such as frequency volume chart and uroflowmetry, as well as the invasive video urodynamics. So continuous and intermittent wetting are different diagnostic pathways. A continuously damp child needs anatomical evaluation. Daytime incontinence refers to intermittent leakage, while awake and enuresis refers to leakage during sleep. Now, in this situation, what would you actually order first? An ultrasound, a uroflow, an invasive testing, or a bladder diary? So in an uncomplicated child with storage symptoms and no red flags, the diary is the most useful next step. The examination is targeted. We look for a palpable bladder or a fecal mass, genital meatal abnormalities, lumbosacral signs, abnormal gait, or lower limb neurological findings when relevant. Bladder and bowel dysfunction commonly coexist. Treating constipation is part of bladder management and not an optional extra. I would call this the organizing slide. We escalate only when the answer may alter treatment, surveillance, or surgery. most children with uncomplicated daytime urgency or wetting can be managed using the first step, with Euroflow or post-void residue be added when the emptying is a concern. And if we want to know what pressure and anatomy show together, we escalate to video urodynamics, which is invasive, and when the assessment is justified. So, bladder diary turns symptoms into a pattern. Use 2 ordinary days when possible. The diary records intake, voiding times and volumes, urgency, wetting, and bowel activity. It separates true frequency from high urine output and exposes holding or positional patterns that may not emerge in the clinic. So this is an example. I have combined the urgency with the pattern in the same slide to keep it simple. So as you can see, the column provides separate, there's separate columns provided for urge, wetting, stream observations, and fluids, and a more detailed assessment is required. Here you can see over 2 days the pattern is reproducible. Most voids are small, urgency accompanies 12 out of the 14 voids, and wetting or dampness occurs about 8 times. This chart supports an urgency-linked storage symptom pattern and provides a baseline for urotherapy. It does not prove detrusor overactivity. The diary suggests a phenotype and the first management step. It does not prove detrusor overactivity or obstruction. If intake and output are both high, consider polyuria before prescribing bladder medication. So this is, I'll explain to you a little bit about what standard urotherapy entails. It entails education, regular voiding, sensible fluid intake, sound posture, bowel care, symptom recording, and follow-up. A credible treatment trial is also diagnostic. An expected response supports the working clinical pattern, and failure prompts reassessment and possibly the next test. Now, uroflowmetry is a non-invasive recording of urinary flow over time. Post-void residue is measured promptly after voiding, usually by ultrasound. The curve becomes meaningful when voided volume, the child's usual symptoms, and the residual are known. A bell-shaped curve is usually reassuring. Staccato, interrupted, or plateau patterns are clues that need repetition and clinical correlation. The curved shape alone does not diagnose dysfunctional voiding and anatomical obstruction. Now, forced voiding in a very small volume produces misleading curves, so it's ideal to obtain more than one representative flow. Measure the post-void residue promptly. Delay and hydration after the curve can produce a highly false residual. So when invasive assessment is required, video urodynamics is the preferred study because it synchronizes pressure, flow, and imaging. It can show bladder contour, bladder neck, and urethral behavior, and the volume and pressure at which reflux occurs. Use radiation thoughtfully and only for a focused clinical question. Now, referral to a specialist does not automatically mean video urodynamics. The specialist should define the management changing question first. Video urodynamics has particularly high value in neurogenic bladder, complex anatomy, reflux associated with abnormal bladder dynamics, or suspected obstruction. Now, a useful request should contain a question, not merely label wetting. The study should link findings to a decision, for example, medication, catheterization, surveillance, endoscopy, or reconstruction. Now, these signals suggest an anatomical disease, neurological dysfunction, impaired emptying, recurrent infection, or upper urinary tract risk. They justify early specialist review, and we still decide whether imaging, uroflow, or urodynamics is the appropriate next step. So, in reviewing the opening case, the diary described an overactive bladder symptom and provided a baseline for treatment response. There was no management changing invasive question, so BUDS was not indicated in this trial. So let me close with this 3-step ladder. You go with the diary, Uroflow, and video urodynamics. The aim is not to avoid urodynamics, but it is to use the right test at the right time for clear management question. Thank you.
Thanks for the short and sweet lecture. Yeah. So our next second speaker will be Dr. Bonggodi Nagapan. She'll be what first? So she'll be speaking about surgical options in neurogenic bladder in spina bifida. So she's one of the few female urologists in the country, and she obtained his BC degree from University of Malaya. Then subsequently, being a board certified urologist, went on to secure a fellow in a fellowship in from the Royal College of Physicians and Surgeons of Glasgow, and later on pursued in a fellowship in pediatric urology in the Royal Manchester Children's Hospital. She specialized in managing both women and children urological conditions. Thanks.
Can start the slide. All right. Good morning. Thank you to Dr. Ng and Sunway Medical Center for this opportunity to talk to you. So we're going to be talking about optimizing quality of life in children with spina bifida and what are the surgical options that are available for these patients. So neurogenic bladder is a type of bladder dysfunction caused by a neurological defect, either in the spinal cord or the brain. Spina bifida is one birth defect, but there are other causes of neurogenic bladder which may be acquired, like spinal cord injury, or even a tumor, and the patient had a surgery for that particular tumor. And there are also non-neurogenic conditions such as bladder exstrophy, posterior urethral valve, that mimic neurogenic bladder dysfunction, but there's no neurological, underlying neurological cause. Now, the most important message here is that a lot of times neurogenic bladder and spina bifida can be prevented. So if any of you have friends or relatives who are planning to have a child or conceive, just remind them that the commonest reason for spina bifida and caudal regression syndrome is folate deficiency in the mom and poorly controlled gestational diabetes. So please advise them or encourage them to have folic acid at least 400 micrograms once a day for 1 month before conception, and also make sure that their diabetes is very tightly controlled before and during pregnancy. So moving on, now let's think about a school-aged girl with spina bifida. 8 years old in standard 2, she's still leaking despite catheterization and medications. She uses diapers, she's worried her friends will find out. Her constipation has worsened, and she leaks, she has fecal soiling. She keeps getting admitted for urinary tract infections. And for this entire routine of emptying her bladder, she's dependent on her parents. So what does successful treatment mean for this particular child? And they're often overlooked, okay? So what are the outcomes that are important? First, protect the kidneys. Number 2, ensure that the bladder emptying is reliable in a method that is suitable for this particular child's mobility, hand function, their understanding, and their school routine. And also achieve meaningful continence. And at the same time, we build independence for adulthood, ensuring that we have a young person who can manage their bladder and bowel safely, confidently, with the least possible dependence. So we don't want to make the bowel and the bladder the center of their lives, but we want to help them manage it in a way that they can carry on with the rest of their life. Have relationships, go to university, get a job. So the first issue is that the symptoms cannot predict bladder safety. So a lot of times we think that a level of lesion, whether it's low down or higher up, the neurological deficit, some people say, oh, the child can walk, therefore the bladder would be safe, or the voiding habits. People keep coming and saying that I can pee,
okay? But they're not reliable indicators of bladder safety. What we need to look for is there recurrent febrile UTIs? When we say febrile UTIs, we worry about pyelonephritis, especially if the temperature is more than 38, there's vomiting, because recurrent pyelonephritis or kidney infections can cause scarring. And with scarring, you have a reduction in kidney function. The next thing you look for is the serum creatinine and the eGFR trend. Okay, if you find that a trend is going up, then this child needs to be looked into further. A worsening upper tract dilatation on ultrasound. Poor compliance to CIC is a red flag, and it's especially difficult for girls and for children on wheelchairs and children who are obese to do CIC carefully. Worsening bowel dysfunction is another sign. So all these symptoms need to be correlated with urodynamics, as Dr. Srihari pointed out earlier. And when we do urodynamics, we're trying to decide, is this a high-risk bladder or a low-risk bladder? And these are some of the parameters that we look for when we do the urodynamics. But then you see, it is not just symptoms. The complexity in spina bifida is basically the interaction between the symptoms, the investigation results, and the urodynamics. And in addition, you also have to look at whether the functional capacity of the bladder, on whether it is a small bladder. And then some patients have got an incompetent bladder outlet that causes leakage in spite of you enlarging the bladder. And we have to decide, is there a fit between the treatment regimen and the child's ability and the family circumstances? Because this is a disease of the low and middle income group, okay? And you have children from various backgrounds who may not have support. And the kind of surgical options that we offer them really depends on their ability to cope. So before any major reconstruction, the first thing to do is to assess renal reserve. So in our practice, we see a lot of patients who come to us when their renal reserve has already deteriorated. When they come to us with good renal reserve, we're pretty active in managing them. But when they come with a chronic kidney disease stage 3 and stage 4, the options to treat these patients becomes even more limited. And then we evaluate the efficacy and the compliance to previous treatment, whether the anticholinergic medicine and the beta-adrenergic medications were optimized, were there side effects. Then we come to the fact that how are they managing their bowel? And especially when parents have to put a finger in and remove the poo, that's not a good sign, because you can't spend your rest of your life having someone digitally evacuate stool. And then we want to know whether they have had endoscopic Botox injections before. And most important, especially now when we have children with various level of neurodivergence, ADHD and autism, it's really important to know the child and the parents' understanding and their compliance to post-operative care. So my approach to reconstructive surgery has been to address first the bladder storage, then access to bladder emptying, management of the bowel, and then only the bladder outlet. And the kind of options that I've been offering patients in my practice for the past 10 years really depend on the type of bladders they have. Some patients come with very hostile bladders, and you know that by leaving these children alone, they're going to go into chronic kidney disease. Now, if it is a very small child with a very poor understanding of what major reconstruction entails, we do a simple vesicostomy. But on the other hand, when you have a child who is well informed, going to school, wishes to be independent, then we can offer bladder augmentation. A conduit is for selected patients who say that, look, I can't cope with all this bladder washouts and this catheterization. And if, say, the patient is already in CKD 3 and 4 with no support, then I would advise a suprapubic catheter. And we'll go through each of these treatment options in a bit more detail. Now, some patients may not have a hostile bladder. The urodynamics and the symptoms may show that the bladder cannot expand to accommodate urine, and therefore its capacity is reduced. So in these patients, if they don't have a very severe pressure at the end of filling the bladder, we can offer them Botox. But in severe cases, in an older child, we can still offer them an option of enlarging the bladder with augmentation. Some patients have a normal bladder, but they can't insert the catheter to drain their bladder. And in these cases, there are catheterizable channels. You can use the appendix, you can use a small bowel, But if the patients are not ready, there's a simple gastrostomy button called a Mickey button, which can be temporarily inserted, and it can be closed and opened as needed to allow the child to drain the bladder. But this is a short to mid-term options, because long-term use of the Mickey button, for one, you don't empty the bladder completely. So in patients with severe bowel dysfunction who have not been able to be managed with all the other options, I offer the antegrade continent enema. And right at the end, when you've done all these options and they still have a weak bladder outlet, the options are a pubovaginal sling so that they are still continent. So this is in just a minute to show you what a bladder augmentation surgery looks like. So it may be a big operation, but it is done with a small incision and an extraperitoneal approach. That means you don't have to go into the bowel, the abdominal cavity to do these operations. So the bladder is mobilized. A bowel segment is about a 20 centimeter or more than 20 centimeter bowel segment is opened, and then it's configured into a U shape. All right. Okay, it's configured into a U shape, and then finally it is attached to a bladder that has been split into half. So it's not just about increasing the bladder capacity, but it's also about ensuring that this bladder has compliance and low pressures, which will mean that the upper tract, the kidneys, are protected. So this is the bowel segment being attached to a bivalve bladder. All right, so that's just part of that operation. So the post-operative care, most of them are on antibiotics. They're allowed to eat after a few days. The catheters are kept for a minimum of 3 weeks. They get IV paracetamol, and the patient's parents are taught how to flush. But more importantly, there are long-term implications of doing these kind of surgeries. So, and major reconstructive surgery does ask something of the child. So what we have to remind them is you still need to catheterize your bladder. It doesn't mean that you don't have to do catheterization. And you need to do weekly bladder washouts. Okay, there will be the commonest complication I get is stenosis at the skin level. So the skin tends to close off. And now I put what we call an L stent, a catheter to plug in that skin so that it doesn't stenose off. And then, of course, sometimes over time, over years, this may require revision surgery. And then there are long-term risks, stones, UTIs, metabolic problems, and most of the time they're associated with poor compliance to CIC. You see, the youngest child that I've done was 4 years old 10 years ago. And over the period of follow-up, she has been amazing in catheterizing herself right till now when she's 14 and she's a teenager, and the compliance has gone haywire. So that is the problem we see. You can do wonderful work, the patients can be really good, but by the time they come into their teens, they become rebellious and the compliance reduces. So these are some of the problems that we see, and that is why some of these complications happen much, much later. And of course, there's a small risk of cancer when bowel is attached to the bladder, and after 10 years, these patients do need an annual cystoscope. So say they're not ready for these kind of reconstruction. What are the other options that we have? We have botulinum toxin injections. But these injections, they work for about 9 months, and then you need repeat injections. And when you have a bladder that is very hostile, you wouldn't find much improvement by giving Botox injections into the bladder. But it is suitable for patients with poor compliance. This is what a Mickey button looks like. It's a button that can be closed so the child can still go swimming and do their day-to-day activities, but it's a medium to short-term option because it still doesn't fully drain the bladder. A vesicostomy is another option. It's especially good for young children who are on diapers and they just leak continuously. But unfortunately, as they grow older, the diapers don't fit and they need bigger diapers and the leakage becomes worse. But it's good to protect the kidneys when they're very young. So there are other options for those who don't want any of these, especially if they've got chronic kidney disease, a suprapubic catheter, which can be plugged and removed, and it's easily changed, or a conduit, which means there's a bag. Okay. So what is a catheterizable channel? So these are patients who have bladders that are small with high pressure, and the bladder is enlarged to reduce the pressure and increase the capacity. But there are also patients who who may or may not have a good bladder, but they are unable to insert a catheter into their penis or urethra to drain urine. So in these situations, sometimes we can use the appendix. Okay, this is what it's called a Mitrofanoff procedure. And these procedures have been here since the 1970s. They've been here for ages. Okay, there are reports that are very, very old about how these procedures have been done, but they have endured. So in this situation, the appendix that is long is used to create a channel between the bladder and the skin. So that instead of looking down there to empty the bladder, the child can just stand upright or sit in the chair and empty the bladder. So that shows how the appendix is inserted into the bladder wall. Okay. And sutured into the bladder wall. All right. But sometimes when we do the operations, we find that the appendix is less than 6 centimeters. It is very high up behind the cecum, or the child is really big, especially older children, obese, where the appendix will never reach the skin. So in those situations, then the option is a procedure called spiral Monty. It's called a Monty procedure, but what I frequently do is a spiral Monty. So in this case, a small segment of small bowel is used to create a longer channel that will attach to the bladder as well as the skin. So this skin level opening, it can be placed near the belly button if the child is small, or it can even be placed at the left or right iliac fossa. So these operations take a long time, and they do stress you out. The augmentation takes you 2 to 3 hours, and then to follow up with this Monty, it takes me another 1 to 1.5 hours. But thankfully, most of the time, I have a lot of urology trainees who are there who are keen to do. So we have to be very sure that this catheter can be used 4 times a day for 10 years, 15 years. All right. So this is a catheter, a channel that has been formed, and then it is brought out at the skin level. Okay, so this is what a bowel that has been tubularized looks like. And even though the operations look like major operations, they can be done with a small incision. And sometimes patients don't want this skin, this disfiguring scar, but it takes a little bit more time, but we can create skin level reconstruction that makes it look hidden. Okay, but eventually this catheter will be removed, and the patients can catheterize when they need. All right, so this is to make the skin level opening look a little bit more hidden. So then we come to the bladder, the bowel aspect of management. So the problem with neurogenic bowel is that there's slow transit time, and when poo is there in the sigmoid colon for a very long time, water gets absorbed, and this becomes rock hard. So patients have had enemas, they've had enemas, they've had bowel washouts, they've had oral laxatives, and then when all these doesn't work and they end up soiling or they require digital evacuation. So when we do this bladder augmentation, we still offer our patients an antegrade continent enema. Now, an antegrade continent enema is commonly done on the right side using the appendix. But in some patients, you would like to use the appendix to drain the bladder, or the appendix may not be suitable. But the problem with doing it on the right side is that the patient has to sit in the toilet for hours to drain the entire large bowel. So what we do is we've modified the technique to use the sigmoid colon on the left side. By doing this, you just have to have the child sit in the toilet for about half an hour and to flush and irrigate, and all that poo just drains out into the toilet bowl, and then they can carry on with their lives. Okay, so what is the benefit? It provides access for you to flush poo out, okay? It offers more predictable bowel emptying. It reduces fecal accidents and soiling. It shortens your bowel routine, and therefore the child becomes more confident. They improve school attendance and travel. So I don't have a picture of the rectus fascia sling for a patient with neurogenic bladder, but this is something I do. for patients who have a weak bladder outlet. So it involves using rectus fascia, which is actually the outer layer that is covering your abdominal wall, and sling it around the bladder neck so that there is some outlet resistance for this child, so that when the bladder is full, they don't leak. Okay, so to kind of come to a conclusion, you see, in Malaysia, up to 1/5, 1 in 5 patients who need dialysis are less than 45 years old. And while diabetes is the leading recorded cause of end-stage kidney disease, it's up to half the patients, there are other reasons: glomerulonephritis, lupus, hereditary and congenital kidney disease, reflux, obstruction, neurogenic bladder. So kidney failure in young Malaysian adults is a serious problem, and there are many causes. But renal damage from an unsafe neurogenic bladder, especially when they're born with normal kidney function, is a small and potentially preventable component of this. So to some extent, you're able to reduce the number of patients who in the end, you prevent them from ending up needing dialysis and going into end-stage kidney disease. All right? So the take-home message is, a dry child may still have an unsafe bladder. And a child who's walking with neurogenic bladder may still have an unsafe bladder. And a lot of times, symptoms of end-stage kidney disease are silent until a lot of renal reserve is gone. All right? Kidney protection comes before continence. Bladder and bowel need to be treated together. And the surgery should be used by the patients, not just technically successful. And the end point here is lifelong health, participation in everything that all of us, the rest of us, have access to, and independence. Thank you. Yeah. So you can see it's all hidden. All right.
Thanks for the enlightening lecture about various options in managing neurogenic bladder. I think in short, safe bladder, safe kidney. I got less job. Yeah. So our next discussion speaker is from India. Is Dr. Venka Ramani Sripati. Is a consultant peds urologist from Apollo Children Hospital in Chennai. He is a very famous surgeon, basically with 25 years of experience, both managing pediatric urology and also of a variety of peds-surgical disease. He actually obtained his basic medical degree from Stanley Medical College, and subsequently obtained his fellowship training from a European Board of Pediatric Urology, from University of Chicago. And he is the director of a pediatric urology fellowship program and also former assistant professor at the Institute of Child Health, Chennai. Yeah, the floor is yours.
Thank you very much. At the outset, thank you very much for this opportunity. This is a wonderful hospital. In Chennai, we neither have the space nor the resources to build something as big as this. It is magnificent. And not all the time do we get a pediatric nephrologist actually sitting as a chairperson for a pediatric urology talk. So that's a privilege. So we are one of 3 dedicated children's hospitals in the city in Chennai. And our tertiary pediatric urology division does about 1,000 procedures every year. But we are the only unit which offers robotic surgery in children. So why robotic surgery? So for an audience of a mixed audience like this, I think we need to put this in perspective. The problems in pediatric urology are unique, and they require a dedicated team with the skill to operate in small spaces. Robotics offers extreme precision with outstanding outcomes. Postoperative pain is minimal. Feeding is early. Discharge is within 48 hours, even after major procedures. And caregivers need to take minimal time off work. It's a mistake to think that if children, they don't really need to rush to school, so why are we even offering robotic surgery for children? The parents are the ones who participate in the activity along with the children. And robotic port entry scars are 8mm points, and they are practically invisible. So my journey started in 2012. In 2011, during a During an annual performance review, we have to justify why we exist to the management. During an annual performance review, they said, we've got something called the robo. Can you look at it and can you see whether you can use it in children? So at that time, I was given the task of starting something which I knew nothing about. So I searched around and found that Stanford Lucille Packard Children's Hospital and Dr. Mike Shea he was kind enough to say, please come over. So I spent about 2 or 3 days with him. And he taught me the basics of the machine, how to run the machine. He was kind enough to bring the machine outside the OR, make me sit on it, and he taught me all the basics that I needed to know. And after that, I followed that up with a robotic fellowship at Comer Children's Hospital in Chicago with Dr. Mohan Gundetti. We sort of went through more complex procedures and discussions, sat on the robotic console, common procedures, do's and don'ts, complications, how to avoid, how to handle small babies, and practicing what was taught on a pig model, on a wet lab. So, but beyond all that, the whole responsibility was on me, coming back and starting that completely on my own. So we started in August 2012. The first child we got was from Africa, from Tanzania. This child, I'll tell you a little more about this child, but in 2026, we are the most experienced robotic unit in South India. We have done 400 procedures, 200 in children less than 5 years, 41 in children less than 1 year. The smallest baby in our series is 50 days old and 3.5 kilograms in weight. This was the first case that we had, a 5-year-old who came from Tanzania, involved in a motor vehicle accident, and her urethra had been completely sheared off. She had developed an inability to pass urine. A suprapubic cystostomy was done in Africa. An unsuccessful attempt was made to repair the urethra. You can see the midline scar there. But when she came, she had an SPC in situ for almost a year. So the first thing that we did was we recycled the bladder because the bladder became very small. So we filled and emptied it for about 2 weeks, and we increased the capacity from 50 mils to 200 mils. We'd fill it till she had a discomfort, and then we'd stop. And in June 2011, we fashioned a tube from the anterior wall of the bladder to replace the urethra that she had lost. So that was the flipped bladder tube that we did. She started passing urine, so we sent her back to Tanzania. 1 year later, she came back with recurrent urinary infections, and we found that she had a reflux on the left side, mainly because of a small bladder, probably increased bladder pressures. So we opted for a robotic extravesical reimplant because the anterior part of the bladder was impossible to access. We would destroy the urethra that we had created. So we went behind the bladder and did an extravesical reimplant. And this was the first case, and the press meet that we had on that occasion. This was the first robotic surgery that we had done. Subsequently, this is our experience. So I have listed out all the procedures that we do: pyeloplasty, pyelolithotomy, not many cases, heminephrectomy. We have a large number of heminephrectomies, partial nephrectomies, post-transplant native kidney nephrectomies, pyelopylostomies, chalecial diverticulum, adrenalectomies, and all sorts of anomalies, mixed multicystic dysplasia, either in a single system or cross-fused ectopia, ureterocalicostomy, and then so this is a child who's about 7.5 kgs. That's the IVP showing the left kidney. That's a DTPA, an F+15 study showing that the left kidney is huge. The calyces are dilated. The child is positioned at the edge of the table. Here are the robotic port sites marked out. The robotic ports are in situ. And here the robo is docked. And then we start the procedure. So what we are doing right now is we have got the colon freed. So it's a retrocolic approach. That is the gonadal vessels which we are pushing away. We are freeing the gonadal vessels. You can see the renal pelvis is down below. You can use the robotic camera to slowly pan round from top to bottom. Small bleeders like this are not really, they're inconsequential because remember, this is 8 to 10 times magnification. The renal pelvis is now coming into view. You can see the acute kink at the PUJ. So we grasp the renal pelvis. We pull it up, we free it. Remember, the renal vessels are coming into the hilum above. So we make sure we don't handle it. And here is the PUJ. That is the kidney. We haven't handled the kidney at all. Then we take a stitch from above. That's a stitch which comes in from the roof. And this stitch is used to anchor the pelvis and sling the pelvis onto the abdominal wall. So what happens is in renal surgery, this is a big advantage. You get a fixed point around which you can operate. Here we have identified the PUJ, we have freed the PUJ. And then what we do is we free the ureter also down below to where we can find normal dimension of the ureter. Then now we are dismembering the PUJ. We are disconnecting the pelvis and the ureter. And once we have disconnected the pelvis and the ureter, in the same sitting, we expand the ureter. We sort of incise the ureter till we come to very normal dimensions. And since we have a long gap between the pelvis and the ureter, we have taken a flap from the pelvis to bridge the gap. And I've speeded this up. Then it's a question of putting sutures, bringing the ureter and the pelvis into alignment. That's the posterior wall that is being done. It is sequentially done with running sutures from below upwards. And you can see the extraordinary vision that you get, the precision, and it's a pleasure to do robotic surgery. And then we start the anterior wall. Once we start the anterior wall and we run a few sutures on the anterior wall, then we put a stent across. So that's the pelvis and the ureter being brought into alignment. Then we put a stent across. We leave the stent for about 8 weeks till all the suture lines completely heal. Then we excise the excess pelvis that we have, because floppy pelvises don't drain well. Once we have done that, it's a simple question of just closing the hole in the pelvis and the procedure is done. This is the only video that I'm going to show in some detail because it's one of the commonest procedures that we do, that the procedure is done. It takes about 60 minutes for us to do the procedure. Everything falls back to where it was. We took more than 200 of our cases, followed them up for about 10 years, and we published our results. We have 98.4% success. The reason why I'm saying that is, you can see my white hair. I belong to the older generation. I'm a little unhappy with people doing a procedure in the morning and posting it on YouTube in the afternoon. When you follow them up for long enough, you find that cases that you thought were extremely good as far as the technical aspect of the procedure were concerned come up with unexpected complications. With his mother behind him. He's actually ready to go. But most of the time, the parents say that we have taken 2 or 3 days off from our office and from our work. Would you just permit us to sleep here, eat, and watch TV? So we say that's also fine. So what sort of scars can we expect? Here is an open pyeloplasty scar. It's a tiny scar. It's got a little hypertrophy there. It's a loin scar, and these are the sort of scars that you would get from a robotic pyeloplasty. Essentially, one at the umbilicus where we put the camera, 2 working ports above and below, and 1 port here. So, as far as the ureter is concerned, there are lots of procedures that we do on the ureter, retrocaval ureter, a uretero-ureterostomy at any level in the ureter. As far as the lower tract is concerned, extravesical reimplant for vesicureteric reflux is one of the commonest procedures that we do. Uretero-ureterostomy close to the bladder. Uretrovesical reimplant, anastomosis for obstructed reimplants. Obstructed megaureter, we detach the ureter, reattach it, reimplant. We also excise very large ureters, paraureteric diverticulum excision, appendico-vesicostomy, like what Dr. Pongodi showed you. I'm going to show you the robotic version of that. Prostatic utricles, these are all a little more complicated procedures. We have excised tumors like sacrococcygeal teratomas, neuroblastomas, adrenal adenomas, renal cell carcinomas, and angiomyolipomas. Those are all a little more difficult to do. And here are a few quick videos that I'm going to show you if I can work it. Okay, so this is a robotic correction of a retrocaval ureter. A retrocaval ureter is where the ureter takes a turn under the IVC and the IVC obstructs the ureter. Here we are handling the inferior vena cava. You can see how delicate we are. That is the ureter which is lying between the inferior vena cava and the aorta. We are handling it by the adventitial tissue that is surrounding it. There is no physical holding of the IVC and pulling it up. We're just handling the adventitial tissue. You can see the part of the ureter that is going under the IVC there. That segment to the IVC is very dangerous because you have lumbar vessels going directly backwards. So if you make a mistake there, then you will have a torrential bleeding, which will be very hard to correct. So this is the aorta caval window. You can see the aorta pulsating here. And then the ureter is, once you divide it, then the ureter comes in front of the IVC. And now it's a question of bringing the two together. To bring the two together, now we have a discrepancy in size. You have to make the lower, smaller ureter a little bigger and then spatulate the upper ureter so you get a oblique anastomosis. Once you get an oblique anastomosis, you generally don't have a problem. The reason why robotic surgery is very good for this is you are not pulling the ureter out of its bed too much. Whenever you handle the ureter and pull it out of its bed, there is a very good chance that you can get ischemic stenosis or stricture of the ureter. So that's the posterior wall that's being sutured. Once the posterior wall is sutured, you have a continuous suture, and then like the way you would do, you would sort of tighten a purse, you just pull the two ends and the posterior wall is done. Then you turn it around. The other wall you trim, we already have stented it, and then we suture this one closed also. And the procedure is done. So it took us about 80 minutes. A pyeloplasty takes about 60 minutes on an average. This takes about 80 minutes and the procedure is done. We are freeing. We are not handling the ureter. We are not touching it at all. We are just handling it with a tape. We put the ureter on the stretch at the PUJ. Remember, we are looking deep into the pelvis. That is the bladder that you see there. We have divided the detrusor, made the mucosa bulge, and then we close the detrusor around the ureter, effectively burying the ureter. Says. The next of the procedures I'm going to show you is so this is an obstructed megaureter. Sometimes what happens is you have an obstruction of the ureter at the lower end. You can see the peristalsis coming up, but it is not progressing. So in this case, you have to detach the ureter from the bladder, excise the segment that is aperistaltic, reconnect that ureter again to the bladder. Do both the posterior wall and the anterior wall. In this case, we are putting a stent. For a normal reimplant, we don't put a stent. Then you finish the anterior wall of the anastomosis, and then you do an extravesical reimplant. And now you can see peristalsis is going right across. So in these cases, if the ureter is very large, we can trim them and bring them to a normal size also. So the next of the cases is the robotic appendicovesicostomy. What Dr. Pungudi showed you in open, this is robotic. First, we assess the length of the appendix. It has to be somewhere between 6 to 8 centimeters. It has to have a robust blood supply, reach the abdominal wall. Once it does that, then we take a stitch at the tip of the appendix, and then we tie off the base of the appendix like what you would normally do in an appendicectomy. And once we do that, then we get control of the lower end also. So the appendix at both ends is now controlled by sutures. Then we drop the bladder from the abdominal wall. We decide where the appendix is going to be fixed. We decide the angle at which the appendix is going to come. This is a neurogenic bladder. And then we make a detrusor tunnel, like what we did for a ureteric reimplant. We are dividing the detrusor, we are allowing the mucosa to bulge. This is anywhere between 2.5 to 3 centimeters. We have a 1 centimeter marking umbilical tape, which we use. And then we bring the appendix down to that and see whether it will sit comfortably without becoming ischemic. We fix the appendix onto the detrusor first. Then we incise the tip of the appendix, make a concomitant hole in the bladder mucosa, and then we start the process of joining the appendix to the bladder mucosa, effectively creating an opening between the appendix and the bladder. So that's the posterior wall that's been completed. Then we pass a feeding tube across, and with the feeding tube as a guide, then we finish the other wall also. So the appendix and the bladder have been brought together. Now we wrap the detrusor muscle on top of the appendix. This is in order to prevent the appendix from leaking when the bladder is full. So now we have a channel that the child can use for painless catheterization. And this is a very, very standard procedure that we do. It has revolutionized our management of neurogenic bladders, as Dr. Pungudi so well put it. And remember, this is a living, growing organ. So because the appendix has got a blood supply, it will continue to grow with the child, and the child can painlessly access the bladder without any issue. So what are the unique challenges in pediatric robotics? The first of these is the movement from very small to very big. This is a very small baby at the edge of the bed. You can see how we have positioned it. We have taken care of all the pressure points. We have taken care of the head. All this is very important. To somebody who's as big as this, with the Cushing syndrome, where we are going to do a left adrenalectomy with a huge pannus on the abdominal wall, which we are actually using as a counterweight for our positioning. So the movement from this to that is the most challenging part of pediatric robotics. And in smaller babies, space constraint becomes a very big problem. Then again, different positions for different parts of the urinary system. Generally for kidney, adrenal, ureter, we position like this at the edge of the bed. For pelvic procedures, if you're going to operate deep in the pelvis, like what I showed you for a ureteric reimplant, or we're going behind the bladder into the pelvis, then what we do is we abduct the legs on stirrups, and then the robo comes between the legs, and the child is now put in a steep 23-degree head down. Here, the protection of the head is even more important. You have to protect the eyes also in order to make sure that they are not congested because of the steep head down. So this is a lot of the time is spent in doing this. Again, suppose you want to operate you want to do a coloidal cyst, in which case the robo will come from above the shoulder. So that's a different type of procedure. A procedure where you're doing a combined abdominal and thoracic procedure, the positioning will be different. So it is very important to sit with the OT staff, discuss with them, with the OT technician on what you're going to do. These small babies, I've just taken this from the net. You can do in babies as small as this, but we haven't done. This is a newborn. So we do have the management called us. Remember, management is very powerful, especially in places like Sunway. They called us and said, "You're doing a lot of urology. Can you do a little bit of pediatric surgery also?" So we forayed into coloidal cyst and coloidal duodenostomy. We did about 15. We have excised a liver cyst. In gynecology, we excised an obstructive uterine horn and obstructed salpinx with endometriosis. We have done other procedures in gynecology. In the thorax, we have removed a duplication cyst. We have done diaphragmatic hernia repairs. In the pelvis, we have done anorectal anomaly. But essentially, our focus is only on pediatric urology. So this is something that's very important. Whenever you're adopting a new technology, it has to be incremental progress, especially if you are a pioneer. You have to have incremental progress. For the first 50, we mastered the skills. After 50, we started doing children less than 5. After 100, less than 1. After 200, babies less than 6 months. Because when you come down below 5 kilos, the space is extremely small. After 200, we did marketing and teaching, not after the first case. Okay? Then we did awareness campaigns. After 65, So this was repeated it in 2021. And nowadays, of course, budget constraints, they are saying, no way. So training surgeons in India, then the Da Vinci asked us, would you be happy to be enrolled as a proctor? So this is in Coimbatore, in KG Hospital, in PSG Hospital, then CMC Vellore called us to proctor both their urologists and their pediatric surgeons. And then we demonstrated in JIPMER, this is at the national conference in JIPMER and also in PSG. So some of the sort of a journey like this over 14 years, you do get a lot of very memorable moments. This was from the US when they called us to give the pediatric keynote lecture at Las Vegas in 2022 at the wonderful Bellagio Hotel. And then we got the first prize for the best video in 2019 in the ESPU meeting in Lyon, France. I don't know if do we have time? Do you want to see this video? Yes? Time is there. Robotic approach to a renal artery aneurysm in an 8-year-old child. A presentation from Apollo Children's Hospital. So this was an 8-year-old female child who had with severe can we cut off the audio and neck stiffness to the neurology outpatients. She was thought to have neuromyelitis optica. So this was a child who was shifting from neurology. She couldn't see. She had severe papilledema. She needed 5 drugs for control of hypertension. It was the nephrologist who first noted a bruit over the renal area, asked for a PRA. No way, because the child is so hypertensive. And here is the saccular aneurysm, which is below the renal artery next to the IVC. And here is the aneurysm. We had about a 2 centimeter segment of the renal artery that we had to bring under control. Here is the robo that is docked, and we went inside. That is we are handling the gonadal vessels there. We still haven't come to the aneurysm. We were absolutely scared because if you have a torrential bleed from an aneurysm on a child who's on 5 antihypertensives, you can as well write off. So that is the aneurysm coming into view. It's plastered on both the IVC and coming up to the aorta. We tried to preserve the gonadal vessels. We couldn't, so we cut the gonadal vessels. And then we have got the IVC completely cleared. We tried to separate it gently. We used blunt dissection with the scissors. We also used a sucker. We just couldn't manage. And so now what we decided was, after all this, we thought the best way to handle this particular child was to lift the IVC off the abdominal wall. So there we are exposing the IVC. We've got the base of the IVC there. We went in the aorta cable window and we lifted the IVC off the abdominal wall. As we were lifting the IVC off the abdominal wall, we came across the 2 lumbar arteries that I told you, which can have torrential bleeding. We created a space and then we slung the IVC up, and one person held the IVC, and there are the 2 the lumbar veins that are going behind. So we clipped them and divided the lumbar veins. So once the lumbar veins were divided, then the IVC could be lifted clean off the abdominal wall without a problem. The moment that was done, then you can see the aorta pulsating, one small vessel that was clipped. And now we came across that and after that we just completed the nephrectomy. So this was the video that won us the best prize for the in the European Society in 2019. So after we did the procedure, it's not that the child immediately went off the hypertensives. From 5, it came down to 2. But within I think 2 years, child was completely off antihypertensives, and the whole thing was just was done without any issue. Once the specimen was out, it was put in a bag and it was removed. So also, because we started pediatric robotic surgery in India, we got the Lifetime Achievement Award for that. Why I'm saying all this is not, technically do it, but I was not happy. So I went back to Comer Children's Hospital in 2023, went back to the animal lab for advanced procedure training. So I the pig and did their own procedures in order to do. We haven't stopped with that. I was talking to the CEO yesterday, and now we are learning how to navigate the Medtronic Hubo, which is another robo. I'm just trying to tell you that whatever be your age, learning never stops. You can't say, I have done everything, I'm going to keep quiet. No, you always have to keep progressing all the time. And remember, success is a team effort. It's anesthesia, it's nurses, it's biomedical team, it's technicians, it is the OT manager, the scheduling team. So she also has to be kept happy. That's very important. So you're happy with you. We celebrated 8,000 robotic surgeries at Apollo. I was very conscious of the fact that pediatrics was only 10% of adult robotic surgeons. I'm sitting next to the vice chairperson and chairperson, but that doesn't make me a great person. I think it's only because of the white hair that they said, don't fall down, come and sit. But and complications, have we had complications? Of course we have. Urinary tract infections, one omental prolapse through the port site. We cut the renal vein in the, I think at about 65 or 70th procedure in a 15-month-old baby. It was a partial cut, we repaired it. But every one of these complications, we have turned it into a success by presenting it to national conferences. Remember, nobody wants to hear about your success. Everybody wants to hear about your complications. So you say my worst complication, I don't know why I did this. There are special sessions for that. And the whole hall will be full. So 3 instances where we lost the needle during transfer, we changed it from a 5mm to an 8mm port and sorted it out, and we have made it an international practice where we had a very stenosed appendix. We needed to mobilize the bladder to complete the Mitrofanov. And so now we are going on to a center of excellence in robotic surgery. We are having a dedicated robo. We already have 6. We're going to get a 7th one at the Women and Children's Hospital. We're going to do advanced procedures, including Wilms tumor. We're going to foray into robotic thoracic, not me, my colleagues, gastrointestinal, hepatobiliary, and overseas collaboration, especially Southeast Asia, which is the reason why I'm here. To start pediatric robotics in order to promote Dr. Srihari, who is going to be our pediatric robotic surgeon in Kuala Lumpur. And I wish him very well. We have done 3 procedures, and all of them were very challenging, but very successful due to the enormous cooperation that Sunway provided to us. You have to care for those who can't afford. Less than 30% have insurance. Therefore, those who most of our patients pay by cash. Even a poor patient can want advanced procedures. There's nothing wrong in wanting it. Therefore, we sort of make subsidized packages and we try to operate on Sundays in order to reduce the cost even further for those who can't afford. Finally, this collage was prepared by my colleague, Dr. Vidya, who is not here. All these children, you can see how much innocence there is in their face and how much they look up to you. I was an examiner for 4 years in University Malaya, and during one of the exams, this girl got on to me. She insisted on being carried around for the entire examination process.
Okay, thank you very much, Dr. Sripati. Can you kindly remain on stage for the panel discussion? And we also would like to invite our previous speakers and also our moderator, Dr. Yao Kian Man.
Hello, hi. Thanks for all the impressive talk. First, any question from the floor? No? All right, okay. If not, I will just go to some of the question posed on the Slido. I think first question will be to Sri Hari. Yeah. So I think the floor want to know what's the age limit for the urodynamic study, and what's the younger age that we can do a urodynamic study? Yeah.
Yeah, so there's no age limit for urodynamic study. The youngest child that I have done before is about 6 weeks. A 6-week-old child.
Sure.
Sorry,
Yeah.
6 months old.
6 months old.
6
Yeah.
months old,
Thanks.
not 6 weeks.
Yeah. Of course. This will go on to the second question, which I think is relevant to both Sri Hari and also Pongodi. I think the floor wanted to know, in the sense that for those patients with spinal bifida, is CIC compulsory from the time they were born? You know, even on the ultrasound, there is no features such as the overtaken bladder wall or any upper tract dilatation.
Okay, so when you have a newborn, there are papers that say that, yes, the bladder empties by reflex detrusor contraction, but most of the time it is incomplete. But of course, many parents are reluctant to do intermittent catheterization. So I think as long as you have someone who has wet nappies, who doesn't have an upper tract dilatation on the ultrasound, whose approach this would be to teach them CIC and ask them to monitor the residuals. So if the residuals are very minimal, instead of doing 4 times a day, they can do it twice a day, once a day. But as long as the residuals are minimal, then they know that they can hold on.
I think I always find it difficult to pursue a parents, with a child with spinal bifida. They came to me after the child already start walking to do CIC. Yeah, because how to say, they're just not getting used to it. Safe, we can still always omit that procedure later on. But it's always difficult to initiate and when the child is start walking. Yeah. So I think there's quite a lot of questions circulate on the CIC thing. The question will be for three speakers. Where would you consider anticholinergic versus a pediatric agonist in pediatric neurogenic bladder? And also again, just reaffirm what you spoke earlier about the botulinum injection.
The choice of anticholinergic really depends on the preparations and the child's weight. So if you have a child that is very young, oxybutynin and propivarin, they're both medications that you can adjust the dose according to the child's weight. While in an older child who's more than 35, you have many more options. It is okay to start early because there are studies that show that by starting anticholinergics and medications early, you can reduce the risk of this child's bladder deteriorating. But on the other hand, all these medications come with side effects. Anticholinergics tend to cause dry mouth, dry eyes, and also anticholinergics long-term in adults, we find that there's also a slightly higher risk of dementia. So you would like to balance the benefits of these medications with the side effects of the medication. So if they have symptoms of infections and high bladder pressure, then they absolutely need it. Now, as for Botox, I think all our limiting factors here are cost. Okay, cost and side effects. Now, for Botox, it is available. It can be given, but here we tend to give it under anesthesia, and the effect tends to wear off after about 6 to 9 months, and they need repeat doses. So now if you have a patient who cannot tolerate anticholinergics due to side effects, then Botox is an option.
Yeah, thanks for the answer. Wow, really, I wonder. About the management of small bladder capacity with high bladder pressure, but the patient just refused bladder augmentation. And so in such cases, and also again, CIC was difficult in this young child. So what kind of management option do you have?
As with the previous question, you got a small capacity bladder proven with the urodynamics to have high pressures, you can put the child on anticholinergics, but putting them on it mandates that you have CIC on board. Now, if the child has a sensate urethra and they're not able to catheterize, you can offer them a mitrofenov or a vesicostomy, to cycle the bladder. But they have to undergo a sort of So it just boils down to patient education, telling them this has to be done before we lose the kidneys.
I think in parents who are very sure that they don't want anything done, but yet they come back with recurrent pyelonephritis and their kidneys are deteriorating, I put them on a urethral catheter. And I make them carry a bag just until they just to protect the kidneys.
Next question, can the suprapubic catheter be left in indefinitely?
Yes, it can be inserted, and after about 3 weeks, it can be changed as an outpatient. Yes, it can.
Yes, I do. But if again, it depends on the patient's choice.
Yeah, I believe a suprapubic catheter is much better than vesicostomy in terms of the care of the wound. Yeah. So, of course, the next question for Dr. Srihari. For young patient how do we monitor the post-wear residual volume since they won't be able to tell you when they will PU?
No, the post-void residue monitoring is usually done in our clinics, and when they come as an outpatient, we have bedside ultrasounds. You can do a bedside ultrasound to look at post-void immediately. If we don't have access to it, then a post-void CIC, if the child has got a neurogenic bladder.
Aneurysm is like watching a thriller. All right. But I suppose the main question I have is cost. I think all of us would want to use a robot.
The management at Sunway. Now, I think I personally feel it's only a mental block. Essentially, the cost is something that you have to talk to the management and ask them to subsidize you. What we do very simply is pediatrics in pediatric robotics is subsidized because of what the adults are doing. The adults are the main income generator, especially in urology, with their radical prostatectomies, with their partial nephrectomies, with their cystectomies. They are the ones, because we have done about 8,000, we do 5 robotics per day. So they are the ones who subsidize the cost for pediatrics. But even then, what really happens is, I used to think that people are unhappy, but today, given the extent to which the publicity and everything and awareness is going on, people are really not worried too much about cost. What you can do is you can give them a little, a little concession. But I think we have to get over that mental feeling that, oh, it is too expensive. Don't stop your robotic training because you feel it's expensive, because robots are evolving constantly. Laparoscopy is slowly fading out. Robotics has come in. So you have to get your training in order, and you will find that people will come for the technology without an issue. We used to think like that, but nowadays we don't really find a problem with people accepting robotics. People are actually coming across asking us, can you do this robotically? Even the patient whom you think can't afford says, we don't mind, but we want our child to have the best of whatever is available.
That's fine. Yeah, I suppose at this point, I think the private factories, they are encouraging the robot. In the public side, we have limited funding. And so laparoscopy is still very, very established here at this point.
But having said that, we have on the public side and in Chennai also, we have a robo in the government, and they are asking us to train them in pediatric robotics. So there is obviously a huge patient population there who's coming and asking them for it. And there is a segment of that patient who are willing to pay some money for the robotics. I think basically there has to be a very, a very hard nosed view or an item breakdown of the cost of robotics, and you can make it eminently affordable without too much of an issue.
Yeah, thanks for the good answer. Being a nephrologist and not a surgeon, of course, I also have some burning question for you. Just wondering that because the robotic surgery is coming. In the sense that open surgery and so on. Yeah, if you focus.
So, and he told me that since laparoscopic appendix them how to do open. So this is what you're saying is a very big problem. Now with robotics coming in, it is even worse. enough in open surgery. Now, the problem is, as long as everything goes on well, it's perfectly all right. No problem at all. I mean, you can come out and say that I've done robotics, I'm fantastic. The moment you have a complication, let us say you have a severe bleeding, you have to open. The first requirement is you must know your anatomy. And that requires years and years and years and years of open surgery. But the problem, sir, is not that. I think we can't stop the pace of progress. It is just going to happen. I mean, I grew up in an era where there was no internet. The TV came only when I was, close to finishing my school. But now it's impossible to move around without a mobile phone. It's impossible not to belong to some WhatsApp group, not to mention so many other groups, most of which are meaningless. But the point is, this is something that we have to contend with. But what you're saying is a real problem. The number of trainees now who have exposure to open surgery, who know how to handle a patient in open surgery is not much. But that is something I think we have to deal with. That's where places like what Pungudi is working, in the government sector, they are so important because they're still doing a lot of open surgery. So I think, it's quite, I think there has to be probably people in the private sector have to spend some time there also to see how it is going on and get reoriented. Because when everything is going fine, it's all right. In complications only, you'll get into trouble.
Yeah, but to clarify, Dr. Sripadi, I work in the public hospital that bought the first robot here in Malaysia 20 years ago. So robotic surgery, robot has been there for us for the past 20 years in Kuala Lumpur Hospital. But it's mainly used for prostatectomies, mainly because we have a limited budget. So when you have a limited budget of say 1 to 2 million per year, you're going to prioritize deep pelvic work and all the nephrectomies, the pyeloplasties, we all have to do them laparoscopically.
Perfect.
Yeah.
All right, thanks for the answer. Just a last question, okay, for Dr. Srihari. It's very practical for the local context. In children with a spinal bifida, when should the first urodynamic study be performed? Should we proactively do it for everyone or wait until the clinical symptoms surface? And subsequently, how frequent should we monitor, the progress with the urodynamic study? Yeah.
Okay, so in a child with spina bifida, the initial workup is after the child has had the back surgery. I wait for 3 months for the neuropraxia to settle down. The first urodynamic study is done 3 months after. As the standard for the past 14 years. So that would be the first study that's done. Subsequently, before that, what we do is we do a ultrasound KUB to look at after the back is closed, we start the child on CIC straight away. There's no investigation. CIC started straight away. A month later, we do an ultrasound to look at the bladder thickness and whether there's any hydroureteronephrosis. If there is, we add on anticholinergics. Then subsequently, the first video urodynamics is done. After that, it's usually followed by 3-monthly bedside ultrasound, which I have access to look at how the bladder is and whether there is hydronephrosis or hydroureter, and then we take it from there.
Yeah. Anything to add on, Rungani? Yeah. So thanks for the crowd. Yeah. Okay.
Thank you.
Thank you.
Okay, thank you very much, Dr. Yao, and our distinguished speakers for sharing your insights on such an innovative topic. We would invite you to step aside just to get your token of appreciation. After this panel discussion, we will now be having our lunch. We invite all our speakers, moderators, and distinguished guests to head on outside to get some food. Please note that our lunch symposium will commence in about 20 minutes by Dr. Koo Bo Ek on the art of communication. See you soon. with everyone having their lunch now, we would like to start our lunch symposium. So let us introduce Dr. Kubo A on stage, a consultant pediatrician and neonatologist at Sunway Medical Center, Sunway City. He completed his medical degree from the National University of Malaya and obtained his postgraduate membership from the Royal College of Pediatric and Child Health in Glasgow. He continued his neonatal subspecialty fellowship training at Liverpool Hospital and the Royal Hospital for Women, Sydney, Australia. In 2009, he was accredited as a consultant pediatrician and neonatologist under the National Specialist Register, Malaysia. Currently, he also holds a part-time lecturer post at Jeffrey Chia School of Medicine and Health Sciences, Monash University, Sunway Campus since 2019. Let us welcome Dr. Koh.
Okay, thank you, Farah, for the kind introduction. Very good afternoon to all of you. Okay, basically, we have a very short lunch symposium just to justify our lunch. You know, this one supposed to be sponsored by Philip, but when you ask Philip, you know, what topic to present, they said anything. So imagine you happily want to go and have dinner, right, with your family. Then you ask your children what to eat, anything. So that will be the headache, right? So I was thinking, let us switch gear a bit from all the very high scientific kind of presentation and also very highly subspecialized topic. Just take a very slow cruise on this lunch symposium, something that very rarely we talk about, okay? So we are covering the art of communication in neonatology, pediatric, adolescent, and even beyond. Beyond mean maybe we touch a bit on parenthood, and also maybe very slippery slope, uncharted territory about spouse. So I look at it, I have two disclosures here. One is this is sponsored by Philip, but we are not talking anything about Philips. We just want to learn what is the art of communication here. And my disclaimer is basically, I'm no near an expert, an expert in the communication. Still learning, and certainly far from a perfect parent. So let us learn together. If you go to med school, right, how many of us being taught of communication skill? Is seriously almost none. And when you go to maybe in your training, I think we probably being expected to be a effective communicator to our patients like overnight. And almost like we are also almost like to be expected to be overnight a very perfect parents, right? None of us are prepared to be a parents, and suddenly we are so-called to be a perfect parents. So I think we have to really look into this communication skill, and it's supposed to be a lifelong learning, how to communicate, and also it is in fact, to me, after I gone through some experience, we probably take altogether a new language. We have to retake our driving license, almost like that. So we are dealing with Gen Z, Gen Alpha, is totally different ballgame. They use all the word that you can't even, can hear? Can hear, huh? They use all the word that sometimes you also crack your head. They like you to use the word, you are cook lah, GG. And then there are many others that, online gaming they are using. So I think we are learning that kind of new language. And we need really change our mindset of how we approach, especially to patient, especially demanding patient nowadays, especially in private practice. We have to relook into the the heart, because we know that out of the desires of the heart, right? Out of the desires of the heart, the mouth speak. So actually it's going through our inner motive and process through the brain, then whatever we want to come out from the mouth. So before we move on, right, let us relook at the one that we have taken the oath, the Hippocratic oath, to have a little bit more compassion on how we communicate. We always being taught do no harm, but I think say no harm is equally important. And also, we always say cure sometime, heal often, comfort always. What do we mean by comfort? Comfort through verbal as well as non-verbal. So we know about IQ, EQ, all of you know. How about AQ? AQ? You all know about AQ? Nowadays, people see how well you adapt to the new world, how well you adapt to a new generation, how well you adapt to the AI. So it's called adaptability quotient. That's important, right? How about SQ? SQ, social quotient, right? Social, if you can really become a good, excellent doctor, and yet your social skill is zero, I think you will struggle. You seriously struggle. So I think these are all important, but the mother of all quotient is CQ, communication quotient. I look at it, how you talk, how you present, you know, the art of asking, how individual A asked the same question, didn't get the answer, and how individual B asked the same question and got the answer. How we asked the lumbar puncture consent, didn't get. The other doctor asked the same lumbar puncture consent, managed to get. This is the beauty of the art. So we look at the definition of the art of communication. I'm sure you all know where it come from, right? It come from ChatGPT. So it is not that bad. It's not that bad altogether. You look at how it involves some listening. You really need to listen. And I want you to put emphasis on the word empathy. Empathy. And also, of course, right time, right tone, and things like that. But to me, the art is about balancing. How you balance between how much information you want to convey and how much potential risk and complication you want to convey. Because if you are not careful, you actually paint a very, very disastrous picture and you scared everybody. You even scared the patient, even when the complication is not there. So are we really instill correct information, or we instill fear into our patient? We really have to come out again from our heart. Out of the desires of the heart, the mouth speak. And do we convey using medical jargon? Like some question is full of, we can't even answer that question, right? So, or are you really want to know what the parents, the patient feel? And then I think this is very important. After 30 years to become a doctor, sometimes we can really immune to patient problem. I confess like that, but you really need to really put yourself back to their shoe. Seriously, put yourself back to their shoe and see and feel for them and see whether whatever we tell them, is it really want to alleviate their suffering or want to comfort them, or just we do our duty. There's a lot of difference. That make a lot of difference. So the Australian family physician come up with some core element of clinical communication. Again, I want to emphasize on listening. And something like you can explain in a very simple and relatable explanation, not jargon, not something like, you want to show that your knowledge is good. No. The word empathy and validation is so important here. Later, we will go a little bit more detail on all these words. Hopefully, we can finish by 20 minutes. And of course, the Australian Medical Council Code of Conduct, they come with all these 9 elements, which are all very, very important. Involve, again, listening, understanding, update the progress of the patient, and I think we really need to have empathy and validation. So why it matters? Why all this matters? So we know what is the art of communication. Now we want to know why. Why is so important? Because I think studies have shown that it actually increase compliance on the patient towards the medication, increase patient understanding, and that lower patient anxiety. And most importantly, right, we want to prevent misunderstanding. A lot of time, right, you look at medical legal issue, actually it's involved a lot of misunderstanding, miscommunication. And why it matters? Actually, good communication is almost equivalent to a good clinical knowledge and good procedural skill. So just now you all saw the excellent video from the procedure that Dr. Sripati showed, right? That was really excellent, right? And if your communication skill is as good as that, you actually can bring healing as well through communication. They are being put in the same position like your procedure skill. And of course, I think caring, compassionate, healing doctor can't be replaced by AI. If you think AI can replace us, we no need to sit here and come for CME already. We can all go back, bye-bye already. I think that is really important. And of course, provide comfort. I want to emphasize here, this is our local articles by UKM. It just published this year, saying that from the meta-analysis of the 360 studies on how medical legal claims come about, right? They actually noted that 50% is due to communication failure and a lot of miscommunication. And I'm sure all of you have been long enough a doctor. How many times you receive so-called letter of complaint, lawyer letter, hopefully not. It's all stem from miscommunication. And then you want to know why parents are so fussy, right? Why parents want to complain so much? You have to look beyond their behavior. So underneath the behavior is actually full icebergs. That's just the tips of the iceberg that they show us. If they complain, I think that is a good thing, because at least they voice out their needs. If not, they go to social media and complain. That's it, that's the end, right? So we look at beneath the complaint, beneath the behavior. May it be parents, difficult parents, may it be difficult teenagers. I think beneath that have a lot of grudges, a lot of values and attitude that's not happy. And in regards to clinical, I think a lot of fear, a lot of anxiety, a lot of denial, a lot of frustration. That's for sure, right? So we look at the how. So we know what is art, what is why we do that, why we want to improve in the skill. We look at how. How is, okay, we look at the neonatology point of view. From my practice, I think antenatal counseling for prematurity, for any sick baby is so important. A lot of time, right, when you go to eat, right, you go to eat outside restaurant. Famous restaurant, I went to Sepetang. You know Sepetang is in Ipoh, right? We went for this firefly chao kway teow. When they fried all the fire flow out like a firefly. So we went there, we know, okay, how long we need to wait? Okay, we need to wait about half an hour. End up, we waited for 1.5 hours. Even the best char kway teow also doesn't taste good, lah. Right? No, that is horrible because you didn't meet the expectation. So why we want to do antenatal counseling is actually to meet the expectation of the parents. We want to tell them from the beginning what to expect for prematurity of 26 weeks, what to expect premature at 27 weeks, 30 weeks, 32 weeks. And then you pin the expectation maybe slightly lower, you know. If you think, oh, 100% my survival rate for 1 kg and above, who can guarantee 100%? Maybe you just take 90% good enough. If it become 100% survival, that is, wow, this doctor is good. So it's how we communicate. And of course, dealing with sick neonates, right, who suddenly deteriorated. Any baby, if you have handled before, they can deteriorate in front of you like that, just within one hour. Now, okay, the next 1 hour, downhill, and even death also. So during that time, I think how you need to do is, from my experience, I need to be transparent and honest as much as I can. We give hope. Of course, we don't give a lot of false hope. And you really show genuine care and concern. Update patient from time to time. I have worked long enough that we have some mortality in an ICU. And even the parents have the eye to see how you care for them, how much you update the parents about the child condition. Eventually, they know that you have tried your best, and if the baby didn't make it, they accepted it. And you know that you are doing well if the baby even died, the next pregnancy, they still bring your child to come and see you. I think you know you are doing well, you know. So I think we really need to be genuinely care for them. How to break bad news like chromosomal abnormalities. I think empathy is so important, and we do not want to instill this guilt among the parents whose fault is that. That's nobody's fault. Chromosome abnormality is chromosome abnormalities. So we also take times to go through with them what is this, what to expect, and things like that. And for dying baby, as I mentioned just now, show empathy, spend time with the parents, let them, if you know there is almost no hope, let them have the last moment that they have with the parents. So let the parents hold the baby, go through the process of bereavement together with them. And when to prepare patient for DIL, DNR, and all that, we really need to spend time with them, bring along your nurses, the team of nurses, and also document it. Documentation is so important. Every process, document it well. So the principle here is, we owe the parents every information from the step their baby are born, or all the way to recovery, or if they are very, very ill, we stay through with them. Do not hide any information, genuine care, and be honest. And of course, parents, they can see how much effort we put in to save their baby. So even though they know that we are not God, but we try our best to save their baby. So for pediatric, as I mentioned just now, right, Dr. A cannot get the consent, Dr. B can get the consent. Why? Why? Because I think what we do, right, is have to do with our communication skill. So we want to explain firmly about the importance of it and give time for them to think and show them why it's so important to get the lumbar puncture, for example. And of course, if you can get consent, is good. If you think this consent is so important, right, and if they don't want to give consent, I will always consider consent for refusal of the procedure. So that now I give this responsibility back to the parents, so that they also take the responsibility that at one time, if the child has any issue, we look back, at least I have gone through the whole consent and you refuse it. So document it, because these are all potential medical legal. And we all pediatricians, we do in and out vaccination, right? We do in and out vaccination. So sometimes I really think like the adolescent age group, especially the boy, The girls are quite steady. The boy, they can really kick a fuss on it. So what I do is, I try to psycho them, Psycho them means, you are a boy, you're supposed to be a macho boy, you're supposed to be brave. Sometimes you become impatient, then you say, wow, you are so big already, you still cannot listen. How is it? You're supposed to just, this is good for you. But I think that is, and then so someone say, don't worry, this is just a needle. I think that is also no empathy at all. What is empathy? Empathy is we relate the feeling back to them. I said, we understand you are worried. We understand you worried about the needle. Everybody worried because it's painful, but this is important for you to prevent the infection and make you stronger, especially when you go back to your class, go back to society, go back to community, things like that. So assure them. I think for very sick baby or a very sick child, dying child, I think our PICU colleague can do better. I am not in the position to tell this. Okay, we are going into almost finish area. Finish? 5 minutes. We go into this quite uncharted adolescent. Adolescent, I think we have deal with a lot of values, issue, gaming, and things like that. And I think last time we said, oh, I actually eat. My mom used to tell me I eat what? Salt more than you eat rice, right? And we accepted it. Now you say like that and see. You say like that. Cut you off. So that is the problem. But looking at it, I think we really want to look at principle of listen, empathy, validation, affirmation, and solution. Always remember this. Listen, adolescent age group, again, all these behavioral issue. Of course, I think the art is, if you can, the art of communication skill is, if you can, don't fight. Win without fighting. That is Sun Tzu. Sun Tzu is a very best general. Win without fighting in court. Don't go for medical legal. If possible, do not go in medical legal. If possible, settle out of court or damage control. That's the best. So I actually want to go through this, maybe give me 5 minutes. This is a new language of how we approach our adolescent. I'm sure all of us are parents here. If not, you are having a grandchildren also. They will grow up to be a teenagers. So I look at it, I think this is a new language we really, for example, gaming. A lot of time they are in the room all the time. So what is our reaction? What is our reaction normally? You are lazy, undisciplined, always hide in the room, gaming, you are addicted. So I think the moment you say like that, Zoom, cut it off already, cut you off. So instead of doing that, you just say, I look at it, I'm very concerned about you spend a lot of time in your room on the gadget. And I get it, because even though you probably want to release your mind, but it's a bit too long already. And you just say, again, do not offer any advice. The moment you offer advice, boom. We all gear up to offer advice, right? Especially doctors, parents, we like to offer advice. No advice. Just listen, empathize with them, validate. Validate means validate why they feel like that. And then, of course, affirm that we love them, we really want to get through with them together. So in the interest of time, I think this also equally important. You just say, try not to say, you make me worried. You make me worried because you spend too much time on the gadget. You just say, I feel worried because I feel that you spend too much time on gadget, and I love you. And I really want to know how we can actually come about to reduce the time together. So that kind of non-violent communication rather than you make me worried, you are addicted, you are undisciplined, that kind of shaming, or worse still, we like to create a lot of guilt. So anyway, I'm not the expert here. I just relate some form of communication skill. This is our last slide, I think. Parents and doctors, I think, in order for us to be an effective communicator, right, we sometimes we have to look within ourselves. We also need some self-compassion. I mean, we need to be actually very calm ourselves and look after ourselves. And the more calm you are, the more peaceful you are, the parents, the patient will feel it, your children will feel it. And a small change in our language every day, I think make a lot of difference. A small change, no need a big change. So take away message. Think of sandwich. We just have lunch. Think of sandwich. You want to correct someone, you want to give feedback, or parents which is very fussy, parents are very, very anxious, drive you crazy. I think look at the positive feedback first. Just tell them, I know you're very worried about your child, which is good. You're very anxious about your children. Everybody is anxious about your children. High fever, we noted, high fever, which is dangerous, sometimes can cause fit. So you already acknowledge their feeling. And then you fill in all the empathy, all the validation, and no correction. Try not to correct. And maybe what you can do is empathize with them, then you only come the back another sandwich, the solution of it, affirm them that you are there for them. The nurse is checking the temperature closely. We are already giving antibiotic. Take some time for the fever to come down and things like that. Rather than, oh, this mother is so anxious, this is super anxious parents, then the moment you have that kind of thoughts, they are super anxious, I think the way we approach is different. The moment you look at them, oh, their needs is actually want their children, the fever to be under control. Then the whole mindset change. So I hope with such a, in between the break, we learned a little bit on communication skill just before the next scientific program. Thank you very much for your attention. No question.
Thank you, Dr. Koo, for the insightful presentation. Special thank you to our sponsor, CVS, for the lunch symposium. Ladies and gentlemen, you may take this short time before our next symposium topic to continue your conversations over lunch. We kindly invite everyone to be prepared for our next symposium topic by 2 o'clock. Thank you very much. Good afternoon, everyone. We hope you've had a wonderful lunch. Our next topic, symposium, will be chronic constipation in children when medical meets surgical care. It is my honor to introduce our moderator to kickstart the session, Dr. Ong Sik Yong, who is a consultant pediatrician and pediatric gastroenterologist and hepatologist at Sunway Medical Center, Sunway City. With expertise in advanced pediatric gastroenterology procedures, including endoscopic interventions, he has extensive experience in caring for children with complex digestive, liver, and nutritional conditions. His subspecialty fellowship training was completed at Birmingham Children's Hospital, United Kingdom. Let us welcome Dr. Ong Sik Yong.
Hi, a very good afternoon, ladies and gentlemen. Hope you can actually take a seat. And then thanks, Farah, for the very kind introduction. So we are going to come to the next session that actually the organizing committee quite nicely put it after lunch and not before. We're going to talk about constipation. So actually, for many of us, actually, eating and the exit plan when the bowel open actually can happen seamlessly. But we know not all is the same for children, because we have children who are actually troubled by constipation. From reports, about 2 to 3 out of 10 children being troubled by constipation. It's a very relevant topic, and I'm sure in our clinical practice to see children in constipation. Some actually even require surgical intervention. So which is why we have a lineup of 3 distinguished speakers today. So the 3 of them actually going to tell us their insights into constipation from medical and also surgical point of view. They will have their presentation for 30 minutes each, and then only towards the end, we have a 20 minutes Q&A session. So to kickstart, actually, we have Dr. Fu Hiwei. People call him Dr. Simon Fu, a good friend of mine. So he's a general pediatrician and pediatric gastroenterologist, currently practicing at Sunway Medical Center, Velocity, the other side of Klang Valley. He has served and trained at various public and teaching hospitals in general pediatrics and completed advanced training in pediatric gastroenterology, hepatology in both Malaysia and Australia. So he's going to enlighten us about his insight into the fundamentals of constipation in children. So the floor is yours, Dr. Simon.
Thank you, CEO. Hi. Thanks for staying. I know it's 2 o'clock on the Sunday afternoon. My topic today is about constipation management, and the title of my presentation is The Fundamentals. So I will not discuss about refractory constipation. I will refer to Dr. Champon, and she will probably talk in more detail about it. Yeah, it's 2 o'clock, so I start off with take-home message first. So functional constipation is common. So what's pathophysiology of constipation is multifactorial. Withholding behavior actually plays a major role. Education, demystification, lifestyle advice, toilet training is actually very important in the management of functional constipation. Pharmacological therapy includes disinfection, maintenance, and also weaning. And polyethylene glycol is probably one of the drug of choice in the management of constipation. Second comes the lactose. And stimulant laxative actually is an adjunct or alternative treatments for functional constipation. Thank you. Again, thanks for staying. So is there a paradigm shift in the management of constipation in children? So when we look back in the guidelines back in year 2014 and comparing to 2023 up to 2026, I think many of us agree that there's actually not much of changes in the management of constipation. So what's the definition of constipation? Infrequent bowel movement, 2 or fewer times per week, associated with painful defecation, passing large calibers to hard stool, and may require excessive straining. I think in our office training, we do encounter, we'll ask parents, how's your the child's bowel habit. And many of them will say, oh, they have this problem, but they think it's okay. And they are actually kind of like take this thing lightly. And eventually what happened was, and many months later, the child developed chronic constipation, whereby eventually they end up with functional constipation or chronic constipation, whereby the symptoms actually last more than 3 months. So how do we manage this problem? So I'll start off with clinical assessment. So first thing come first, we get the history, we ask about symptoms, and we do simple physical examination. So what's important about this physical examination and history taking is that we want to know whether are we dealing with a functional constipation or we are dealing with some other organic causes. So I'll give you some scenario. So I have this, the first scenario is Miss A, I call Miss A, 2-year, 4-month-old girl. She has autistic spectrum disorder. Actually, the parents came to us because of no bowel opening for 5 days with reduced oral intake. And also the child progressively becoming more malaise and lethargic. So upon questioning, the symptom actually started many months ago. It was actually more profound after a febrile illness, whereby the child was hospitalized for simple febrile fit. And the other thing is that the care of the child, the parents actually not too sure about the exact bowel opening because they only pick the child after work, and babysitters actually does most of the thing. And this child, because of the autistic spectrum disorder, she's actually picky eater. So on exam, she's more for age. There's no stigmata of any chronic illnesses except for the size. And as usual, this child was very fretful upon examination. And you can see from the chest abdominal X-ray there, he's actually fecal loaded. And also the child, because of the crying, there's a little bit of distended stomach, there's a little bit of erophagia. So the second scenario that we often see is also where the parents actually came to us with the concern of diarrhea rather than a constipation problem. This is a set of identical twins, they are Caucasians. So mom actually reports that the child requires polyethylene glycol back in the UK. And then the issue was more on accidents, overflow incontinence, and there's some urgency after meal. And there is a selected diet whereby when the child is taking high gluten diets, the child actually have more symptoms, or same goes with the dairy products. Examination was unremarkable, but otherwise I managed to assess one of the twin because the other twin was actually a bit fretful, and we did investigate to gluten sensitivity or gluten allergy. It was actually negative, but otherwise inflammatory markers were all normal. So this is another scenario whereby the child presented actually with a constipation issue rather than diarrhea. Another scenario that I want to share is about 11-year-old boy. This child actually presented with the mother. I was not so sure what was the chief complaint because the mother said there's a little bit of abdominal problem. So I tried to get a lot of history, but when he walked into the room, the boy actually appeared quite cachectic. And at the first glance, I thought I'm dealing with an inflammatory bowel disease. But otherwise, on examination-wise, there was a fecal loaded mass on the left side abdomen. During the examination of the digital examination of the rectum, the child was actually having a sanitary pad on the undergarment, and there was evidence of fecal soiling on the sanitary pad. So due to the presentation, I proceeded with endoscopy, and it was showing some distal corrective changes, but otherwise they were otherwise normal. So this is the child with a constipation whereby he was having fecal incontinence. So the child does not present with a clear complaint of constipation. They usually have other constitutional symptoms. So when most often they come with abdominal pain, where they behave like irritable bowel syndrome, they may have some incontinence problem or they have some bloatedness. So, and also they also may present with some other complications such as rectal prolapse. And parents only come to us when they see some more warning symptoms such as blood in the stool, or where they suspect whether or not the child having hemorrhoid or not. So what's the causes of constipation? 95% of constipation is due to functional issue, and whereas 5% are organic causes. According to Rome 5 criteria, if we have 2 or fewer defecation per week, or fecal incontinence, retentive posturing, painful heart or bowel stool, large vast fecal mesh, and large diameter stool, where if you have two or more of those criteria, you are, and you exclude other organic causes on your assessment, the child might be having functional constipation. But importantly, we have to rule out other organic causes as well. So what's the contributing factors for functional constipation? Usually during the phases of life whereby they were exposed to toilet training too early, or when they have having adjustment at school, or when they have some life event, example holiday, painful defecation, or febrile illnesses. So stool withholding is one of the most common cause of constipation. Where they have this kind of vicious cycle whereby they have painful defecation and they start to withhold, and eventually the constipation got worse, and this cycle goes on and on. Toilet training is actually one of the cause of the main contributing factor for constipation as well. Many of time parents expose the child to toilet training too early, whereby the child is actually not prepared for toilet training as yet. Usually, and the other thing is that when the child is put on toilet training, they are actually being exposed to more painful defecation. So it's advisable to assess the child whether or not they are actually prepared for toilet training by assessing the daily bowel habits and the stool pattern and so on. Coronary dysmotility is also one of the pathophysiology where there's chronic constipation. It actually impacts the neurons in the colon, and this also causing the constipation to get worse. Dietary factors and family history, those are the contributing factors, but this not so much of proven concept, but there are evidence that some allergy patient with cow's milk protein allergy may have constipation issues. And importantly, the gut microbiome is actually also important in the cause of constipation. And also in the ill patients where they have electrolyte imbalance and sepsis and all those things, they may cause the constipation to get worse. Cases of constipation may not be as easy as what we thought. Some of patients, they behave like they're having functional constipation, but actually they are not functional constipation. So I share some of the causes scenario. I have this Miss D, she's a 13-year-old young lady with background history of functional constipation. So she was actually treated by a GP for abdominal pain. The pain actually over the left iliac fossa. And there was actually tenderness over the iliac fossa, but the tenderness actually much improved after this infection. But the pain did not disappear. Ultrasound actually shows evidence of hydrosulfing, whereby this case was actually referred to the gynae, but due to the persistent pain, the CT scan was performed, and that she actually was having a torsion of the left fallopian tube. Another scenario that I want to share is about a boy, a 12-year-old boy with constipation, And he actually presented with recurrent constipation for past 2 years, but this time around he presented with severe abdominal pain, and we could not explain why the abdominal pain was that severe, where she required recurrent admission to the ward. And the disinfection actually did not help the abdominal pain symptoms. And subsequently, we proceed with some other investigation whereby stool for calprotectin was significantly elevated. And on top of that, he also has eczema as well. So a scope was done, and it shows some loss of eosinophil cells in the coronary biopsy, whereby this child actually was diagnosed with eosinophilic gastrointestinal disease. And another scenario is Miss F. She's a 5-year-old girl with abdominal pain, and again she went to a GP and also to a public hospital, and there was evidence of fecal loaded on the abdominal X-ray. Due to the persistent pain, she was actually presented to the hospital, and subsequently on examination-wise, she also has some rashes seen over the distal leg, foot, and also over the ears. Ultrasound abdomen at that point of time was normal, but showed some fecal loaded. So she actually have this HSP, with Hernes Corine purpura, where constipation is actually quite common amongst them. So again, it's important to rule out some other organic causes before we commit our diagnosis to functional constipation. Most of the functional constipation does not need investigation, but otherwise, if there's a suspicion of organic causes, yes, we do proceed with some basic investigation to get to a diagnosis. So how do we manage constipation? So I'm going to discuss about functional constipation management. This requires team effort, whereby we need to team effort, meaning that the patient, the caregiver, and ourselves, the medical provider. Education is actually most important in the management of constipation, whereby firstly, we need to explain to the parents what is the pathophysiology of that, and how do we deal with how does this pathophysiology actually helping us to come to a strategy on the management of constipation. And also, importantly, we need to advise about prevention, and also by prevention or recurrence of constipation, by educating them about the medication strategies and so on. So firstly, we use non-pharmacological management, whereby we advise parents on increasing a little bit on liquid or fluids. The parents also been told that they need a bit of balanced fiber intake, and also we educate on the toilet training of the child as well. Behavioral modification actually does help, whereby we get the parents about informing or reminding the child that they need a bit of toilet sitting, about 20 or 30 minutes after each meal per day, and they should be staying on the WC for about 5 to 10 minutes each time. This may actually initiate the desire for them to defecate. And some of the parents also may give them, the child, some reward system, whereby they can do the star chart and all those things to encourage them, the child, to participate in defecation process. I think we are aware that the correct posture of defecation is important, whereby there is a little bit of stooping forward, squatting position. This may actually ease the pubic rectus muscle or the tendon, where it actually is the fecal matter to be excreted out through the anus. So what is the main purpose of treatment of the constipation is that ideally our KPI includes, number one, we have a soft stool, and ideally defecation about once a day. This process includes number one, disinfection. Number two, we have to maintain. Number three, we try to withdraw or weaning the medication. This is the table showing list of medications. The group includes osmotic laxative, stimulant laxative, pro-secretory laxative, and also pro-kinetics. So firstly, disinfection is actually important. Firstly, I think we need to clear off the hard old stool sitting in the large bowel. So what we use is polyethylene glycol, high dose, and this should be given for about 3 to 6 days. And sometimes in the patient where they are not cooperative or they're not compliant to polyethylene glycol, what we can do is that we can use enema as part of the disinfection process. So maintenance dose, firstly, number one is that the drug of choice is polyethylene glycol, but we can use lactose if we do have a polyethylene glycol in our clinic or in the pharmacy. And subsequently, we have to assess the patient 2 weeks later about the treatment performance. And subsequently, we have to continue this treatment for at least 2 months. And if the child is not toilet trained yet, we have to make sure that the medication or the response of the treatment is actually good before we commence on toilet training. So for weaning of the medication, again, we have to maintain this medication for at least 2 months. Sometimes we can go on to about 2 to 6 months or longer in the more complicated cases. And number one is that we have to make sure that the child actually defecates about 3 times a week, and where the stool is around Bristol 3 or 4, where they are not too hard or ideal for us to start on the weaning process. And we need the help from the parents or the caregiver about the compliance of the medication. So there are a few laxatives available in the market. Osmotic and stimulants are the most common laxative that we use. Osmotic laxative actually stimulates the retention of fluids and soften the stool and also increase the peristalsis. Lactose is actually one of the old laxatives that we use, but now we are actually moving on to polyethylene glycol. And we know that there are few polyethylene glycol available in the market. Those are with electrolytes or without electrolytes. And they're actually quite safe. They can be used 6 months and older. And those with electrolytes, actually, they are a bit saltier, so hence they are actually not that palatable. And when you mix into the juices of cordial, actually, it's actually not, it doesn't taste that good. But otherwise, those medications actually quite safe, and occasionally they may cause a bit of flatulence problem or abdominal discomfort. A lot of questions asked about, should we use polyethylene glycol 3,000, 350, 3350, or 4,000? So far in our Malaysia, we have 4,000 easily available in the market, whereas 3350 is actually not that commonly available. But there's actually not much of difference in terms of efficacy of these two medications and also in terms of their safety profile. But again, 3350 actually tastes not as good as 4,000, hence the compliance is better with 4,000. And the other thing is that 3350, because of the electrolyte content, they may cause a little bit of electrolyte imbalance occasionally. Lactose is another osmotic agent that we use. It has some benefit as compared to polyethylene glycol, whereby it causes a little bit of increased peristaltic movement. But due to their palatability and their volume, they may not be a drug of choice. And study has shown that polyethylene glycol is actually more efficacy the reticulus. Magnesium hydroxide is another osmotic agent. It actually favored in some of the country in Asia, but in adults, yes, it's used as a disinfection agent, but otherwise in this part of the world, it's actually quite seldom used, and it's safe, but it's not palatable, but otherwise it may cause a little bit of side effect whereby in kidney failure patient, it may cause hypermagnesemia. Stimulant laxative is actually one of second choice that we use in the management of constipation in children. The most common stimulant that we use is bisacodyl. I think we are quite familiar with bisacodyl. And the other alternative is senna. We don't use this quite regularly because of the dependent issue, but stimulant usually we use as an alternative or adjunct to our polyethylene glycol or osmotic agent. It can be used as young as 2 years and above, and otherwise it's rather safe to be used. Another older medication that is in the market, but again is getting obsolete, is mineral oil or liquid paraffin. This is actually not so much advised in the child younger than 3 years old due to the complications where there will be a risk of aspiration pneumonia or typhoid pneumonia. Enema is actually one of the common treatment we use in the daily practice. And in Malaysia, we use glycerin enema. And this is actually good in the sense where we try to clear off the distal end of the hard stool in the rectum. And this enema actually can be used once or twice a day for about 3 or 4 days if you want to clear off the distal end of the rectum. I'll touch a bit on the newer agents available. There are a few available newer agents such as prosecretory agent, ceratogenic agent, and this medication we actually being used in the adult setting or the teenage setting, but not so much in the pediatric setting. In pediatric setting, usually polyethylene glycol or enema or stimulant, actually they are quite good enough. And new kid on the block is about this pro-secretory agent or linaclotide. This being approved by FDA for 2 years and above. The efficacy is as good as the polyethylene glycol for refractory constipation, but otherwise it's very expensive. So I'm not be talking much about refractory constipation. Refractory constipation is defined as when you already try numerous types of pharmacological agent, but yet there's no good response for a minimum of 3 months. And this constipation actually leading the child to have a poor quality of life. So then you move on to some other constipation management. This includes surgical and also some other biofeedback kind of treatment. So not all refractory constipation are truly resistant to treatment. This is probably my last scenario. I have Mr. F here. He's a 14-year-old gentleman. He was bright and smart. He presented to me with irritable bowel syndrome, with constipation, but he keeps on having this persistent pain, altered bowel habits, but otherwise the blood couple protecting and GI endoscopy histology were all pristine, they're normal. And I tried him on osmotic agents, stimulants. They were actually quite negative response. He would just report, they're okay, not good, not helping, same, those kind of negative response. So a bit of social history, the parents actually separated many years ago. He was staying with the father, and he was actually not a happy young boy, and only had a few friends. So actually what happened was he wasn't taking the medication well, and then he actually don't want to get better. He's happy, he kind of like torturing himself or torturing the parents, where he wants the symptom to be there at most time. There's also many questions about whether or not probiotic does help. There's no strong evidence to say that probiotic helps in the management of constipation, but I believe that probiotic, it may have some roles in maintaining a good microbiota and also maintaining a good short-chain fatty acid levels in the bowel, but otherwise it may be used as an adjunctive treatment. So most importantly, we need to prevent this by having a good lifestyle education and good or timely prevention, whereby we try to prevent the child getting on to chronic constipation issues. The outcome of chronic constipation is actually quite good, but about 1/4 of them will require continuation of care into adulthood. I think that's all about my constipation topic.
Thank you, Dr. Fu, for the very comprehensive overview and also the case illustration. I'm sure actually everyone learned a bit more from the case illustration. But we know actually sometimes actually constipation is not actually that straightforward. At times we run out of idea actually what else to do apart from offering lifestyle changes, medication. We then have to think about or think out of the box whether any other things that we can do to help these kind of children with so-called refractory constipation. And we are very fortunate today that actually we have this expert come all the way from Thailand. She's none other than Dr. Acharya Chatpong. She's from the Faculty of Medicine, Prince of Songkhla University, Songkhla, Thailand. She's a practicing consultant pediatric gastroenterologist. So she completed her medical training in Thailand, then she furthered her studies in the pediatric gastroenterology in Mahidol University, and went on some more to actually do her further studies in pediatric gastroenterology in University College of London in Great Ormond Street Hospital. Then she traveled from the other part of the world to Australia, went on to actually get her PhD in pediatric neurogastroenterology. It's a field that we really need, but we don't have in Malaysia. I would say actually she's probably a rare breed in Southeast Asia, or someone who specialized in neurogastroenterology. So she was gonna deliver this talk to us about decoding anorectal function, the diagnostic and therapeutic role of manometry and biofeedback. So now the floor is yours.
Good afternoon, everyone. Thank you, the organizing committee, for the invitation and the opportunity to speak today. So we're going to talk about manometry and biofeedback. By the end of the session, I hope you will have a practical understanding of colonic and anorectal function test for the evaluation of children with constipation. And we will focus on the normal anorectal physiology and the interpretation of anorectal manometry. We will also discuss about dysgenetic defecation and anorectal biofeedback therapy. Let me start with the case. This is a child, 9-year-old boy, presented with 8-year history of constipation. He had bowel movement only once per week, despite treatment with high-dose oral laxative and rectal enemas. The patient also had daily fecal soiling and nocturnal stoolings. Meconium was part within 24 hours of life. On examination, the abdomen was soft and non-tender, with a palpable fecal mass. The neurological examination was unremarkable, and the perianal examination showed tight sphincter with fecal staining around the anus. As we heard from the previous speaker about constipation, the one who do not respond to maximum and combination therapy should prompt referral to pediatric gastroenterologist. We refer this group as the one having refractory or therapy-resistant constipation, which means having maximum dose of more than 2 laxatives for a minimum of 3 months. For this group of patients, we're going to consider investigation, for example, barium enema, anorectal manometry, and chronic transit study using radiopaque marker or ROM to understand underlying pathophysiology. In children with constipation, further investigation should be guided by the suspected underlying mechanism. We are already familiar with the indication for abdominal X-ray and the contrast enema. So today we're going to focus more on motility and functional studies. A chronic transit study using ROM can be used to differentiate between slow transit constipation and rectal outlet obstruction. With the anorectal manometry, we can understand more about anorectal function. And chronic manometry should be reserved for selected patients, particularly the one who needs surgery. With the chronic transit study, we perform it after bowel cleansing, so it depends on the protocol. The child can eat either a capsule containing 20 markers every day for 3 days, or a single day protocol with the 24 markers. And then we follow up the X-ray on day 4 and day 5, depending on the protocol. And also day 7, if the marker is still in the bowel. A chronic transit time of more than 54 means slow transit constipation. And for the single day capsule, if the marker left in the colon for more than 20%, it means slow transit. And then the location of the marker also tell you something. If the marker spread out throughout the colon, then it means there is a slow transit constipation, like this. The colon looked lumpy and it didn't work. And, if the marker still sit in the rectosigmoid colon, then it would compatible with rectal outlet obstruction. Let's see with the slow transit constipation first. This patient may require further evaluation with chronic manometry to determine whether the abnormality involves the enteric nerve or chronic muscle, and also to understand the location and extent of the affected bowel. At our center, colonic manometry is performed using a solid-state catheter, placing under endoscopy or fluoroscopy. Under normal condition, there should be a high amplitude propagated contraction, or HAPC, started from the proximal colon and propagating down to the rectum. And there should be many HAPC, but in this patient, we need to give him many dose of bisacodyl just to induce one single propagated contraction here, if you can notice. And the contraction started from low amplitude contraction to a high amplitude contraction with the red zone here. And it starts at the mid colon, so it's around transverse colon and propagated only to the descending colon. It cannot propagate to the rectosigmoid colon. So this is abnormal, and it tells you that there's a colonic neuromuscular dysfunction. So this patient may need surgery. That's what an example of complex case of slow transit constipation. Now we're going to move to the image on the right, where the marker are retained in the rectum, representing rectal outlet obstruction, like these photos. In some countries, the evaluation of refractory constipation begins with anorectal manometry and balloon expulsion test, not explosion here. And before proceeding to transit time study. So it's good to rule out Hirschsprung disease to identify whether there's an anorectal problem or defecatory disorder, such as dyssynergia. So with this group of patients, they can have anorectal biofeedback therapy. Before we discuss anorectal manometry, let's first review the basic anorectal anatomy. The anorectum has 3 main functions: continence, storage, and defecation. The rectum acts as a reservoir, while the internal anal sphincter and external anal sphincter maintain the continence. The puborectalis muscle also maintain the angle between anorectum. So it's also help with the continence as well. And we can have successful defecation when these muscles are coordinated. If there is a failure of this coordination, then it could lead to rectal outlet obstruction and dyssynergia. When the stool enters the rectum like this, there will be rectal distension, and it activated the sensory pathway through the spinal cord, and it will generate the urge to defecate and initiate the rectal anal inhibitory reflex. It causes relaxation of internal anal sphincter. But we still have continence. So the continence maintained through the coordination function of the pelvic floor muscle, including internal anal sphincter, external anal sphincter, and puborectoris muscle. And internal sphincter provide most of the resting anal pressure, while the external anal sphincter is voluntary. So it allows you to postpone defecation when necessary. Like if you feel like you need to go to the toilet now, but you still maintain the continence in the room. But during defecation, then there will be the relaxation of all these muscles, and the anorectal angle becomes straightened, and then the stool can pass successfully. This diagram explains more on how the body holds stool and control bowel movement. First, we have storage, mean continence, stool kept in the rectum. Continence is maintained by the pelvic floor muscles. And then rectal filling. When the rectal fill, there's a mechanoreceptor in the rectal wall that detects the increasing volume, so we are able to report first sensation and the urge to defecate. Then we have the defecation reflex. So when we have more stool in the rectum, it will trigger the rectal anal inhibitory reflex to inhibit the tonic contraction of the internal anal sphincter. This will create sensation that we need to pass the stool. The fourth one is the voluntary defecation. When it is appropriate, like when we go to the toilet, we relax the external anal sphincter and puborectoris muscle. The rectal anal angle becomes straightened, and we have the abdominal contraction to expel the stool. Lastly, after the defecation, then we come back to the continence. Now that we understand normal process of continence and defecation, then we can better understand what anorectal manometry measures. It is a functional test that evaluates how well the rectum and anal sphincter work during these different stages. It measures the resting pressure, mean internal anal sphincter tonic contraction, and measure the rectal anal inhibitory reflex when the rectum is distended. It also measures squeeze pressure, mean the function of the external anal sphincter, and the successful defecation manual with the push technique. To perform anorectal manometry, we use a specialized catheter with a pressure sensing along the catheter connected to the anorectal machine. The catheter can be either water perfused or solid state catheter with the balloon at the tips, but at our center we use the solid state. The child will be asked to lie down on the left lateral while we insert the catheter and also perform the procedure. Now, who should undergo anorectal manometry? It is widely accepted as a screening tool to exclude Hirschsprung disease with a high sensitivity and specificity. It also used for children with persistent anorectal symptoms unresponsive to standard management, like chronic constipation, fecal incontinence, fecal urgency, to understand in patients with disorder of neuromuscular origin or pre and post surgery for Hirschsprung disease, anorectal malformation, or spinal cord lesions. We can also test in the one with suspected anal sphincter damage, like post-surgery or post-trauma. And importantly, to identify dysgenetic defecation. Also, we can perform the test before and after intervention, like Botox injection and biofeedback therapy. Moving on to the examination protocol, the National Anorectal Physiology Working Group recommends started with at least 3 minutes of familiarization. So it's a period where we ask the child to be familiar with the catheter, just wait while the catheter is sitting inside the rectum. They won't squeeze anymore, won't cry anymore, and then it followed by 30 seconds of resting pressure measurement. The actual protocol will tell you that you should do the squeeze, push, and cough, and then rectal sensation. But at our center and also other motility center in the world, we feel like we need to test for the rectal anal inhibitory reflex first. So we start with the balloon test to identify whether the child has rectal anal inhibitory reflex. This is the resting pressure. So there's a high pressure zone of the internal anal sphincter. And then we do the balloon test to see if there's an increasing of the volume. Can the anorectal sphincter relax? And then we ask the child to squeeze, so the pressure will become higher. And then do the push maneuver. During the push, there should be like an increasing abdominal pressure and relaxing of the sphincter, like this. And then cough reflex. Following the manometry, we remove the catheter and then we perform the balloon expulsion test. It is a simple assessment of the patient's ability to evacuate stools. The procedure begins with insertion of catheter, different one, with a balloon at the tips as well, and insert it in the rectum for about 5 centimeters. And then we inflate the balloon with a 60 ml of air or 50 ml of water. Then the child will sit on a commode and we ask them to expel the balloon. Normal test means successful expulsion within 1 minute, but acceptable within 5 minutes. It is a reliable test to screen for dyssynergia in adults, specificity of 80 to 90% and sensitivity of 50%. However, it is not routinely performed in young children, particularly the one less than 5 years old, because it requires a high level of patient cooperation and also an understanding of the procedure. In children, anorectal manometry can perform either while the child is awake or under sedation. In a cooperative children, the awake protocol allows a comprehensive assessment of anorectal function. So we can measure motor function by measure resting anal pressure, squeeze pressure, endurance squeeze, push effort during push maneuver. The reflex about rectal anal inhibitory reflex, cough reflex. We can also test sensation. So we can record first sensation, urge to defecate, and maximum tolerated volume, which means rectal compliance. And then we can test coordination during the push maneuver to identify whether the child has dyssynergic pattern. And after that, if available, we perform balloon expulsion test. In the one who is incooperative and the younger children, we perform it under sedation. At our center, we sedate the child with ketamine and midazolam because it doesn't affect the sphincter pressure. If you use other medication, you need to be careful because it could affect the sphincter pressure. With the sedation, we can only measure resting anal pressure and rectal anal inhibitory reflex. But is this enough for the one we would like to exclude Hirschsprung disease? This study compared anorectal manometry performed while children were awake and under general anesthesia. They found that general anesthesia reduced resting anal sphincter pressure, but allowed detection of the rectal anal inhibitory reflex in some children who did not demonstrate it while they are awake. So they said that a repeat ARM under anesthesia may be helpful when the rectal anal inhibitory reflex is not identified during the awake study. Returning to our case, the child underwent anorectal manometry years before colonic manometry. During the balloon inflation test, the rectal-anal inhibitory reflex was present. As you can see here, there's a balloon inflation, the red zone at the top, and then the change in the color from red to blue means the relaxation of the anal sphincter. But with the push maneuver, the child can generate abdominal pressure with the red zone here at the top, but there are also paradoxical contraction of the anal sphincter while he do the push maneuver. Normally with the push maneuver, as I showed you previously, when there's an abdominal contraction, there should be a relaxation of the anal sphincter here at the picture on the right bottom. So is this compatible with dysenergic defecation? What is dysenergic defecation? It refers to inability to coordinate the abdominal and pelvic floor muscle to evacuate stool because there's paradoxical anal contraction or inadequate anal relaxation. And in some subtype, there is inadequate abdominal pushing effect as well. In adult, there are many different terms which mean the same thing, such as anismuth, pelvic floor dyssynergia, or outlet obstruction, for example. Based on the adult literature, dysenergic defecation is classified into 4 different subtypes according to patient push effort and anorectal sphincter response to the push maneuver. The upper tracing is the abdomen pressure, and the lower one is the sphincter pressure. So with type 1, there's an adequate pushing effort, but there's a paradoxical contraction of the anal sphincter. Type 2, inadequate abdominal pushing and paradoxical contraction of the anal sphincter. Type 3, adequate pushing effort, but inadequate relaxation of the anal sphincter. And the 4th one is inadequate of everything. So there's no pushing effort and also no relaxation of the anal sphincter. Why we have to classify into different types? Because it helps identify the underlying pattern of dysfunction and may guide management, particularly the biofeedback therapy. So return to our case, I supposed to ask, but there's an answer here. So this is compatible with type 1 dysenergic defecation. The diagnosis of dysenergia actually in adult requires 3 components. Of course, there should be symptom of constipation and feature of dysenergia on ARM, and 1 additional test, balloon expulsion test, difficography, or transit study. But we have to keep in mind that the pathophysiology of dysenergia in children and adults may be different. In children, it often starts with withholding behavior. So it is a voluntary process because the child has a bad experience by defecate, for example, frightening or painful experience, so they withhold the stool. But in adolescent and adult, the process is less voluntary, less conscious. So there's only like a paradoxical contraction of the anal sphincter. Now we move on to the biofeedback therapy. The main goal is to teach children how to coordinate muscle relaxation with the use of anorectal monitoring instrument to make them understand the process and also recognize what they are doing during the defecation. To improve the dysenergic defecation, and because dysenergic defecation thought to be secondary to stool withholding, then we have to understand and also treat other components. So let's talk about biofeedback just a little bit. There are 4 steps. The first is evaluation. So we have to assess symptoms and stool diary, and then we do the education, teach them about the normal defecation process, and what about dysenergia. Teach them how to relax the muscle, do the diaphragmatic breathing, and also time toilet turning. And then there's an active phase of biofeedback. So there will be many sessions, about 30 to 60 minutes, to learn how to do the push maneuver. After that, we have to have reinforcement, so follow up them after the biofeedback therapy. So one of the important components of biofeedback training is diaphragmatic breathing. The child is first taught to breathe in slowly while imagining that there's a balloon inflating inside the abdomen, followed by breathing out while imagining that the balloon deflating. Once the child is comfortable with this breathing pattern, the child is taught to hold the breath briefly and gently push by making the stomach balloon expanded. The push should be about 20 seconds, and during this maneuver, the child is encouraged to focus only on the expanding of the abdominal balloon so that they won't squeeze the anal muscle. There are different systems available for performing biofeedback therapy. Traditionally, like in the old day, we have this machine with a flexible pressure sensor catheter. This catheter allows the child to sit on a commode and looking at the screen to see what happens when they do the push maneuver. They will be taught to learn how to push with the increasing abdominal pressure but relaxing the anal sphincter. And it's also important to use the suitable commode, like a smaller one for younger children, and also with the footstool to promote a good position for toilet training. After the first machine became unavailable, there was a period that we performed anorectal biofeedback by using anorectal manometry. And with this machine, we wouldn't like to use the catheter while the child is sitting on the commode because the catheter is quite stiff, solid state. So we concerned that the catheter will bend and damage while the child is sitting on a commode. So then they was asked to lie down on the bed. But it's also good, although it is less physiologic, because it still allows the child to visualize the pressure change and understand the process of defecation, particularly the generation of abdominal pressure while relaxing the anal sphincter. Finally, we use the EMG or electromyography biofeedback. So with this technique is avoid catheter insertion, so the child like it as well. And using surface EMG electrodes to monitor abdominal and pelvic floor muscle activity. The child receives like a real-time feedback through an interactive game-based system, making the training more engaging and enjoyable. The screen and game can also be adapted to suit the child age and also preference. So like this young woman, she liked this game in pink color, and she tried to push the tracing up to get her rewards. This slide demonstrates EMG electrode placement with electrode pressing on the abdomen and around the anus, and the reference electrode placed on the both legs. So, in 2 minutes, we're going to look at the evidence for biofeedback therapy in children with dysenergic defecation. So a recent meta-analysis, including 3 studies that compare conventional treatment alone with conventional combined with biofeedback therapy. The analysis shows significant heterogeneity and also found that there are no significant additional benefits associated with biofeedback therapy. It's quite disappointing because in adults, there are a lot of evidence that biofeedback is working in adults. The difference in outcome between children and adults may rely on difference in the pathophysiology underlying pediatric and adult constipation. This table, I would like to tell you that there's a difference in the biofeedback protocol between study and center. And it also depends on the child age as well. Another recent meta-analysis also reported the similar finding. Again, no significant benefit of biofeedback therapy in children. However, this systematic review in 2021, including 4 randomized control trial with like total 600 children, and about 300 children were randomly assigned to different treatment methods. So biofeedback, anorectal manometry, physiotherapy, plus standard medical care. The primary outcome was absence of constipation without laxative. And overall, all treatment approaches show potential benefit. But biofeedback combined with standard medical care had the highest probability of being the most important, most effective treatment, with 52% probability of ranking first compared to the others. So there's some evidence. And in summary, children with refractory constipation may require further evaluation with anorectal manometry and or colonic transit study to identify the underlying pathophysiology. Anorectal manometry is valuable too to assess Hirschsprung disease, anorectal disorder, including sphincter dysfunction, dysynergia, and dysynergic defecation. Is characterized by impaired coordination between defecation with paradoxical contraction or inadequate anal relaxation, and it often related to stool withholding behavior. Biofeedback therapy aims to retrain coordinated defecation by teaching appropriate pelvic floor relaxation using a real-time anorectal feedback. So, thank you for your attention.
Thank you so much, Acharya. Next up, actually, we have this topic that's going to be delivered by a pediatric surgeon. So that's when actually a physician don't know what to do, then we have to get help from the surgeon. So the expert that's going to talk to us actually is none other than Dr. Tan Yu Wei. Dr. Tan is a consultant pediatric surgeon and the head of pediatric surgery at University of Leah Medical Center. So he had a vast training in various different hospitals back in United Kingdom for near 20 years before he decided to come back to Malaysia in 2023. So he has been with Malaysia for the past 3 years. So in these 3 years, then he continued his service in the field of pediatric surgery. So the topic that he's going to tell us today is actually the role of surgery in optimizing constipation management in children. So I'll pass the floor to Dr. Tan. Thank you.
Thank you very much, Chairman, and the organizers, Sunway, and also colleagues for giving me the opportunity to share my experience. I see that I was given the topic of the role of surgery in optimizing constipation management, and clearly I'm singled out here because I have to defend surgery in managing constipations when there's so many experts in the floor who is seeing more than 90% of these patients. But 8 years of colorectal pediatric practice has taught me that there is still some role where surgeons can add to the armamentarium, and we're here to be part of the team. So, oh, you've got it. I've got a disclosure. So I am the founder of Care Passport, which has a booth in this conference. This has been very nicely covered by my good colleague Simon, and it has now become Room 5 when we talk about constipations, but the fundamentals of the diagnosis remains unchanged. The problems with constipation, that it is a frowning problem to the patients, but also to the clinicians, because for the patients, they suffer UTI, quality of life issues, schooling problems, and psychosocial issues. And a lot of our patients, because they tend to be referred at the end of the spectrum, they have this, undoubtedly. But to the clinicians, it's a bit of a puzzle as well, because there are so many patients with constipations within the community at any given time, and they can present themselves to the pediatricians, the gastroenterologists, and they basically just flood many of the clinics. So how do we then sieve out who needs what? Can be a real difficulty. So I'm hoping to be able to shed some light, and clearly I can't talk about our roles in within 30 minutes. But I think there are some cases where we can actually demonstrate how surgery can facilitate. So this does not require too much descriptions. This motility and impaired evacuation has been highlighted by Dr. Acharya in relation to how constipation may develop. But that could be just one form of presentations. Another form is incontinence, whereby incontinence happens when there's overflow diarrhea in constipation patients. But we also see the other spectrums of patients who are incontinent because they don't have motor control, sensation is a problem, and colonic motility could be impaired. So again, it is a difficult place to sometimes very clearly know what is going on unless you do good investigations. So the causes from a surgical simple-mindedness point of view is generally divided into non-neurogenic and neurogenic. And for the non-neurogenic, the vast majority of the patients out there are functional constipation, but we see a disproportionate amount of patients with anal rectal malformation and Hirschsprung's. And we also, in our practice in lots of spina bifida patients who have a neurogenic bowel and bladder. So our bowel management program started about 6 years ago. It has grown quite a bit. From every year we're seeing about 150 to about 400 patients. And it is pretty much consultant-led, but it is heavily supported by our specialist nurses. And we are very grateful to have this because sometimes when it comes to managing really complex constipation patients that we have, having more hands to really take over that is really helpful. Without the nurses, we would be next to nothing. But our aim was to provide comprehensive bowel care for anorectal malformations, Hirschsprung's, functional constipation, as well as spinal dysraphism. All these patients can present with constipations. So this is a rough setup, and we are very much protocol-driven. So the question is, when should the surgeons be involved? I think in a sort of simple way of looking at it, we either get in after the patient has seen the pediatrician, the pediatrics gastroenterologist, or the GP, and having a period of treatments and investigations. And if that all fails, then it kind of gets channeled into the surgical landscape. But we sometimes get in quite early on when we know that the patient has a problem with their bowel, such as the ones that we mentioned and demonstrated here. And as the patient goes along and getting better on the follow-up, sometimes they relapse and they can come back to see you. So that's where our team can sort of overlap a little. But I think fundamentally it comes down to 5 indications why surgical referrals can be indicated. One is assessment of complex refractory cases due to our disproportionate number of times of managing difficult bowel problem in Hirschsprung and ARM, but also investigating for specific diagnoses such as Hirschsprung's. Medical optimizations goes without saying. There are lots of treatments already mentioned, but we have a slightly different slant. We tend to prefer a stimulant because of the megarectum our patients get. Surgical interventions where it's indicated, and long-term follow-up in partnership with MDT and primary care. So let's look at some scenarios, if that helps. So I'm going to cheat a little bit. Our first scenario is actually 3 scenarios, because you would probably come across a situation like this. 20-month-old boy presented with no stooling for 20 days, having previously been fine and requiring manual evacuations. All of a sudden, a 2-year-old comes along. And then a 4-year-old girl may present with poor oral intake, failure to thrive, and actually been okay until 2 years of age when constipation kicked in. And also sometimes you get a bigger kid where they have had problems since about a year of age, has gone as far as seeing the gastro, but still come back fecal loaded. And the gastroenterologists are exhausted in their management and wanted to rule out Hirschsprung disease. So you can see that when we have difficulty in making progress in medical management, that's when the surgeons may actually come in and just sort of helped with clarifying the situation a little bit more. How are we going to do that? Usually it starts off with an assessment. We're all on common ground in terms of when we take a history, we want to establish severity, etiology, the impact on the patient, and the best management plan. So these are some of the things that we consider when we are looking at the assessment. Okay, but fundamentally, when it comes to best management strategy, you're looking at, so is this the time to do it? Is there anyone that I can refer to? Does the patient have enough financial support? Is the health economies sort of allowing me to refer very loosely to surgeons when the time comes? Some of the questions hopefully can be answered. Yeah. So as we talk about how our bowel management program is protocol driven, this is kind of our overview of the protocol, right? And it's a lot of words there. I don't expect you to see it, but it basically splits down the whole process into first assessment, followed by disimpaction if indicated, followed by the first treatment, which can either be laxative or enema. There's common strategies that has all been mentioned in terms of drinking, toileting advice, and diets. Once you have started this treatment, there's really a lot of monitoring to go on with. And if things don't work well, generally what we suggest is really have a low threshold of escalating. Okay? May it be laxative or enema program. So when we just look at history, to determine the severity and impact, we can take a history at the beginning, but oftentimes that has been done already very well by colleagues. But what we tend to find is later on, following treatment, we will also be able to determine how severe and how much impact it has on the patient. Yeah. When it comes to etiology, right? So not only the history counts, but the investigation also makes a lot of difference. Okay. But sometimes investigation requires surgery, such as rectal biopsy. And the best management can come from, what we talk about, potential use of rectal biopsy, but also sometimes if you fail, a laxative therapy, you may move on to doing, the arrows are all over the place, looking at stomas, ACE, which has also been mentioned. So this is kind of our framework when we come to surgical management. We want a systematic, scientific way of finding out, is medical therapy truly not working? Are we now ready to move on to surgical therapy? So that's what we're going to demonstrate. So in this case, we are suspecting Hirschsprung disease, right? Or these 3 cases. So the question is there any guidelines? And there is actually a guideline called NICE guideline, National Institute for Clinical Excellence. So this hasn't changed for the past more than 10 years. And basically, it doesn't talk about when you should do a rectal biopsy, but it talks about when you do not perform a rectal biopsy unless you have all these 5 things that happened: delayed passage of meconium, constipation since first few weeks of life, chronic distensions, family history of Hirschsprung's, or faltering growth. Okay, so when we look at this, we want to know how useful is it? Is it applicable to my patients? So a few years ago, we've done a study looking at if you combine the NICE guideline with neonatal intestinal obstruction and any genetic predisposition for Hirschsprung's, about 200 rectal biopsies were looked at. And we found that you kind of have a 78% chance of getting a non-Hirschsprung biopsy. In other words, about 22% of the time, you probably will pick up Hirschsprung's, once you follow that. So our key message from our study was that, rectal biopsy has a 22% positive rate. But when you do a red flag, if you look at the red flag, is it useful? We find that it's clinically relevant for risk stratification. But as it indicates here, sensitivity is not great, but specificity is not bad. So that just means that if you do it on your patients, you probably find that we can't tell with certainty. But if you get a negative result, probably it's negative, right, with the red flags being absent. But absence of red flag doesn't mean that the patient doesn't have Hirschsprung's, because in our studies, 9% of Hirschsprung's actually had absence red flags, which you do not want to miss. So in other words, we haven't gone very far. There's no one test in your history taking or clinical assessment that can support whether or not to refer for Hirschsprung exclusion. So this is our reflection on case 1. It's useful to use red flags for risk stratification, but it really doesn't exclude Hirschsprung's. So do refer when it's suspected. Yeah. But the question is, how long do I persevere? Do I do it, after a month, a year? So this is a paper we look at. When you do delay the diagnosis of Hirschsprung, what would happen in a 20-year series? So late diagnosis of Hirschsprung was really defined as more than a year when they were diagnosed. And these patients have more pre-op stomas, unplanned surgery, fecal incontinence, permanent stoma, and major complication, as well as redo pull-through rates compared to those who had timely diagnosis. So delaying referral for suspected Hirschsprung can significantly compromise the outcomes. Yeah. This is kind of our logical pathway looking at this, but I'm not going to go through it a great deal, but except to say that when children are referred more than 6 months, they need a general anesthesia. So from a simple bedside procedure to becoming a GA case. So that does mean something that we have to consider when we are referring. So we move on quickly to scenario 2, or else we might run out of time. So this is a 1-year-old infant who has been constipated since 6 months post-weaning. With dietary adjustment and medical therapy, she's still having defecations, painful defecations, and very loose stool. So our pediatrician could not do a PR examinations after they've seen a few, and therefore referred to our clinic. So we could see that this is a funnel-shaped anus with a Hager 6. So I don't know whether you're quite familiar with Hager sizing. A newborn anus should be around about 11. Yeah, so small. So basically the x-ray didn't look like there's a major spine problem, but there's fecal loading, right? So our first instinct was, well, impactions, disimpact. So, well, in our bowel management clinic, we have 4 or 5 different ways of disimpacting. The ones that we can do in the hospital, we tend to do a washout, yeah, like this. So we very quickly arrange a contrast to demonstrate, and where the point is at the bottom here, that's where the anal verge is. And you can see that there's a good 4 to 5 centimeter up where it's narrowed. That's an anal stenosis. So in anal stenosis, we immediately think of Currarino, and we do an MRI spine. And in this on these occasions, luckily, there's no spinal problems, as the X-ray also confirmed that. And there's no presacral mass that we can see here, right? So all these are reassuring. So we move on very quickly to think about how to resolve the obstruction for this child. So we have the choice of anal dilatations, or we can just go straight to doing surgery. But meanwhile, we have to maintain it with dietary control and bowel management. So Hager dilatations was thought to be a reasonable way forward, but we did manage to dilate the child up to a reasonable size. Failing which, we thought we were going to do this operation, which is pretty invasive and would usually have a 30% breakdown rate. So we didn't have to do that for her. So learning points for this is anal stenosis presents with funnel-shaped anus, which will make you think about anal stenosis. But this is the kind of children that you really can't wait very long, because it's very hard for them to defecate, and they are essentially obstructed but unable to fully obstruct, so they can some kind of poo in the early months of their life. But as time goes by, they get worse. Presacral mass is a real concern, because if this is a sacrococcygeal teratoma, with time it can become malignant, so we want to exclude them, right? So Corioreal triads happens when there are anal stenosis, presacral mass, and also sacral agenesis. It is a genetic mutations, happens on chromosome 7, and is autosomal dominant in nature. So a bit of history from the family may well reveal that. On this occasion, you see the MRI has a presacral mass low down that's compressing on the bowel. On this occasions, the patients actually had a contrast. You can see that the colons is a little bit dilated, megarectum, but not super big, and actually tolerated this well. So when we reflect on this case, it's important to do a PR in your first encounter when you see a patient, particularly if there's funnel-shaped anus. Okay, and you need to think about working out for Currarino by ordering an MRI, and escalate quickly if failed bowel management is very important. The third scenario is a 5-year-old boy which is referred with chronic constipations, not too dissimilar to the first one, but about a year old, and then just after the surgeon saw, was prescribed home dilatations and softeners, but the child never came back. But he was struggling actually at home for about 3 years before he turned up again and then was referred in. So basically very distended abdomen, straining despite softeners. So sounds familiar, like the first case? Yeah. So indeed, when we think about it, anal stenosis sometimes get missed, and the surgeon didn't really investigate further, so we had to, right? So he already had some medical therapy which failed, and as you can see, we have the options of laxative on one side and enema therapy for anyone who have bowel problems, constipations. So on this occasion, the patient does have continence potential because sphincter sensation motility probably are reasonable, or was it? So if you look at the contrast, this colon is huge. We weren't confident that we were going to be able to disimpact him, never mind doing ongoing enema, and quite rightly, after about 2 to 3 months, we gave up. Basically, we tried our very best. But it was the parents that took time to really agree to doing an operation. You can see if we were to remove that big dilated colorectum, we can actually connect to a sigmoid that is of reasonable caliber. So a few years ago, we did a review on a megarectum in anorectal malformations at the Royal London. And we saw that about 20% of patients with ARMs do develop megarectum, and generally defined as, by Mark Benninger group, a rectal diameter over the largest pelvic diameter greater than 0.61. So this is clearly about 95%, wasn't it? So it's definitely a megarectum, and there's a huge obstructed element to it. But what we did notice in our study was that actually doing surgery is not that great, because oftentimes they end up still with functional problem, most of them requiring ACE. One even had an ileostomy permanently. So, but what we did find out is important when the strategy for surgery changed to make sure that we've got good caliber anus at the end of an anorectoplasty. We can prevent megarectum from developing, and we certainly stop needing to do a rectal resection. For these patients, unfortunately, we're not winning. We have to escalate. So 3 months later, we decided that enough is enough. The patient needs a surgery for resections. So we did an EUA, examination and anesthesia. There's dentate line. We did a rectal biopsy. There's no Hirschsprung disease. So we took out the huge dilated rectum. So if you compare pre-op versus post-op x-rays, it's a massive improvement. And this is the pre-stoma closure. When we did the contrast, you can see an interesting change in caliber here. The rectum is really still dilated, but a small, thin sigmoid is now anastomosed to it. So the reflection on this case is that initial treatment really matters. Yeah, when you see a patient that you're worried about it and you have some threshold about this being a major problem, then you should probably follow up very tightly. If patients don't come, you probably have to make a point to call them back. Social circumstances can negatively affect long-term outcomes. So how we communicate the risk is important. Yeah. Sometimes we talk about, okay, well, they can have leaks, when you do a megarectum resections, you can have sepsis. Yes, that's true. But what else can we do? Leave the child to be forever incontinent? That's not possible, right? So salvage bowel management must be systematic. If you want to offer surgery, be very sure, or we have to be very sure, that we have gone through the whole process from beginning to the end very systematically. We know that we've left no stone unturned. We can justify the operations. Yeah. So this is an important case. Scenario 4, 1 year, 3 months old baby girl, only came in last year. Baby check was normal, and stoolings quite normally the first 6 months. Yeah. But after weaning, the baby actually got really straining a lot and crying. There was not much distension to go with, but there was weight gain, and then stool keeps coming, right? So, but the GP noted an anterior anus before they referred to us. So they actually came in through the ED. You can see that the anus is a bit anterior. You agree? Yeah. So, and when you look at this anus, you can see that the opening is just a little bit too to the front. And if the baby was crying a lot. Oh, our sound effect is gone, but it's actually on the background. And this is what's happening, like toothpaste light. Yeah. So the actual anus should be there, right? So this is a delayed diagnosis of a rectoperineal fistula. So knowing that this is an anorectal malformation that's missed, we basically had to really decompress the child because actually there was a dilated system on the x-ray. Initiate diet modifications. You're no longer able to eat solids because you don't want to build up. You want to be like back to your 6 months old baby. So you got loose stool so you can overcome the small opening. And it's not just the passage is small. The angle coming out from the rectum down towards the fistula is a right angle. So it's going to be quite difficult for stool to come out, especially when it's a solid stool. We also wanted to think about vector association. Therefore, we went for KUB ultrasound. We went for MRI spine. It was fine. Yeah, so we had to plan for early surgery. So nowadays, with a perineal or vestibular fistula, we do a cystovaginoscopy to start with to make sure there's no Mullerian abnormalities, followed by the surgery, which is done in a prone position called PSAPT, and colostomy was formed to defunction. So you can see that a lot of rectum has to be taken out in this process, and it is quite a big operation. Yeah. So you have seen there's been lots of discussion in the recent years, certainly in the British front, talking on the Europeans, seems to have some issues with late diagnosis, and I think we have this as well in our country. So late diagnosis generally saying that more than 72 hours after birth, only you pick up an anorectal malformations, and it ranges from about 5 to 18%. The symptoms are significantly more compared to those who are not diagnosed late, of course. But the impact could be significant. In the short term, patient can have perforations. In the longer term, patient can have really big megarectum that is going to be difficult to manage. Yeah. This is a good way of looking at this, and I wanted to share with you how the spectrum ranges when people talk about anterior anus. So from the one end on number 1, which is vestibular fistula, followed by Fourchette's fistula, so these are all the same within the spectrum, and they all can be subject to being missed, and they all can lead to really major complications down the line. And therefore, I was going to share with you how to examine the perineal examinations in a girl at birth. So the first thing you have to do is really pull the labia majora and forward, and to look at, there are 3 openings, anus, vagina, and urethral meatus. Yeah. Occasionally, you see this kind of perineal groove where this mucosa line perineal body that looks a little bit unclear whether it's anorectal malformation. You're right, it's unclear. So even for us, when we see them in clinic, we sometimes, as long as the bowel function is normal, we can wait, and we can actually wait until epithelialization with skin, then we make a decision whether we need to do an examination and anesthesia. After you pull the labia, you should push down again to really then demonstrate if if you have seen the anatomy properly. It should be surrounded by sphincter, so that can be shown on Ruge. And the anal canal must have a dentate line. That can only be done under EUA. And there has to be a good perineal body. So you can see in red, there are certain areas where we have to confirm with a general anesthetic, which we don't always need to. So it is probably better for this patient to be seen by us if you have concerns, and it doesn't fulfill the criteria. So the reflection on this case is that anterior anus is not a diagnosis. It is either a perineal fistula or a normal anus, depending on where the sphincter complex is. And if it's in doubt, please do a surgical consult. Delayed diagnosis of ARM is commoner than it should be. We should not really delay, and if we actually examine the perineum properly, we should be able to avoid that. Even if there is no pediatric surgeon in your center, you can always refer out. Every newborn examination should be carried out competently, and if in doubt, surgical consult. Yeah. The last case, I'm not going to dwell on too long. It's a bigger boy, because colleagues have talked about, Ms. Pungodi and my colleague Simon, about the use of ACE in children who have neurogenic bowel and bladder. And these patients, I just want to highlight the fact that a lot of them are wheelchair bound. This one particularly has lumbosacral agenesis, neurogenic bladder, already has a mitrophanol, doing CIC. So there's no continence potential. This patient unfortunately requires evacuation with fingers. Yeah. So, and you can see how difficult it is. So I suggest that we, have to consider ACE carefully, and please do refer them. So I'm going to skip this because it's kind of mentioned. Yeah. And I don't have to tell you that it actually does improve the quality of life. And I'm not going to have much time to talk about transitional care, except to say that transitional care is crucially important, and this is where surgeons can really lend a hand in improving the quality of life through surgery. So with this, I'm going to run to my key summary slides, if that's okay. So constipation is very common, mostly functional, and it's not always the case. Organic causes should always be ruled out, especially in refractory cases, and please recognize it and escalate it. We are very happy to hear from you. Surgical consult can be deployed anytime when indicated, and not simply following a prolonged failed medical therapy. And bowel management is an MDT approach. So this is our bowel management workshops across the country. Thank you very much for letting me discuss.
So please grab your chance if you have any question. We will probably give chance to the people who is present here before we actually open it to the online questions. You can raise your hand. Okay, Dr. Yao? Yeah. Can someone pass?
Sorry for stealing your time. I have a question for all three of you. As you know, I'm a peds nephrologist, and unfortunately, I think the gut and kidney tract, they are sitting side by side. So when you have a constipation, I too have a problem here. So we are quite inseparable. I think my first question to Dr. Simon is, okay, when you talk about constipation management, I think you are referring to the normal mental state children. But I think we are seeing a surge of autism and ADHD. And we are, with that, we are starting seeing more dysfunctional bowel bladder. And the thing in the sense that if we don't manage the constipation well, I can't get on top of the bladder management. So in this group of patients, I think you have given lots of options for the medicine to use. But the other problem with this child in the sense that they are quite restrictive in their feeding habit, and especially taste. So what's your management strategy when you come to constipation management in this group of patients? For Acharya, it's quite amazing to see that your center have a biofeedback mechanism for bowel. We do have a biofeedback mechanism here for bladder. But again, do you have are you working along with the peds urologist and peds nephrology, have a combined biofeedback mechanism for the bowel and bladder in your center? And what's the outcome like? Okay, for Prof, okay, Dan. We talk about anterior place anus, okay. I'm talking about the normal anus appearance, not those with the fistula formation kind of thing. In this group of patients, okay, and especially when they come along, they appear along with the dysfunctional bladder and until, UTI and the arising complication, everything, is there a role for surgical correction? When they came together with the constipation. Yeah, thank you.
I think we have three questions. But we start with the first question to Dr. Fu. Is a question about children with special needs. Yeah.
Thanks for the question. I think it's not yourself that having difficulty in management children with autistic spectrum or ADHD or some behavioral issues. It's a struggle. But I think the principle is a customized kind of treatment. I think number one is discussion with the parents or the caregiver on the behavior of the child. And also, I think we have to come up with some treatment strategy. I don't think there's a size fit all kind of treatment. And number one is I think my approach is to educate the parents first about what's the expectation, how's their compliance, what's their difficulty they are facing. The other thing is about getting the right treatment. But I think number one is to disinfect the child, to make the child more comfortable or happy. And by doing that, we need to use two strategies. One is stool softener, a good dose of stool softener. I know it's very difficult to add on the polyethylene glycol into milk or into juices whatsoever. But I sometimes I discuss with them whether or not they prefer lactose or different tastes of polyethylene glycol. Give them a chance to try first before we commit that this child is having difficulty. The second thing is disinfect from the bottom end by using enema. I know some of the being exposed to enema without any understanding about the medication. But you'll be surprised that those child who has had this infection or who had some bowel opening, I think this is probably just my experience. But anyway, I think what we do is, number one, discuss if it is option A, they can't take, we go with option B, or up to the extent of using some stimulant, which is suppository stimulant, where we just give them once a day dosing or twice a day dosing, give a try, disinfect them first, and eventually we are just hoping that they give in about the options of taking in those kind of things. But this is a real struggle. I don't think I can answer you, to give you a good answer about the strategy. I guess it's just case-to-case basis.
Okay, next is on down your question.
So can I also add to that? So normally I won't do the rectal enema. I try to avoid it. So if the child has fecal impaction, I try to increase the laxative, oral laxative first. And the first one we're going to choose is the polyethylene glycol. And for the biofeedback, at our center, we also have bladder feedback training as well, but it's in different units and different department. Previously before we have the EMG biofeedback, I also adapt the urology machine to do the bowel training, but it's a little bit different. And in my opinion, I think it's better to focus only on one objective. So to do the bowel training or to do the bladder training, because with the child, it's difficult to educate them, to make them more comfortable with the procedure and also adapt that training into normal daily life. Yeah, thank you.
Thanks, Chair. My question to me was whether an anterior anus, which is normal anus, should require any surgery. The answer is no. If it's a normal anus based on the criteria I narrated under GA, no. But we do tell them that there are some risk of increased risk of UTI, increased risk of tear, third-degree tear during parturition. And so they should take vigilant actions, and they should drink plenty, and they should wipe from front to back, all those things, right? But I wanted to slightly disagree with my compatriots here. I liked to use enema disinfections, presumably because most of the conditions that we manage have a megarectum, but also most likely the problems is down there, is the evacuatory problems, whereas you probably deal with a lot of slow transits, which understandably can work better from the top. Of course, the concerns about being anally averse in the long term is true, but this is where when you have a really dedicated nurse who know what they're doing, it makes all the difference. I have never had a difficult time after I've disinfected a child from enema and then come back later and say that you need long-term enema therapy. Yeah, because that would have been a marker that they really averse with their anal therapy. So I think it really depends on the circumstance you are in. Yeah, thank you.
Thank you. Yeah.
Well, I think the issue actually depends on which one you are dealing with. So actually uses, the principle of disinfection and then maintenance. Moving on, actually, the next question actually come from online participant. Actually, this is quite straightforward to Dr. Fu. Since fiber intake is important for constipation, can we advise the patient to take soaked chia seeds or xylem husk?
Those chia seeds and serum husks, they are available in the market, but I think the management of constipation is slightly different from adult. We don't need so much of fiber. I think it average about 10 gram to 15 gram. I forgot what's the formula, about 7 plus the age, something like that. So too much of fiber, number one, it may cause the stool to be getting more harder. The second thing is that I think the management, the issue with children with constipation is withholding retention kind of stooling pattern, whereby even though the stool is formed or in a good shape, it doesn't cure or treat the constipation issue, while when the child is actually stopping the passage of the stool by withholding the anus or the anal tone. So I think that's a struggle.
I think taking a variety is actually the key, rather than actually focusing on one particular fiber. So that is important. I think quite easily reference that you can refer to is actually the Malaysian Healthy Plate, that how much of fiber. Then we're going to move on to the next question to what is your thought of scintigraphy's transition study compare with radio opaque marker studies?
Thank you. So both transit study can be useful, and it is like transferable. But with the scintigraphy, you need a special radioactive, and it's a little bit expensive and also not available in every center. Like with the colonic transit scintigraphy, you need indium or gallium, so it's quite expensive, and you need a lot of patients to perform all the tests together in one day. Otherwise, you lose all the substance. Yeah. And also with scintigraphy, you have to bring the child into the hospital every day for 5 days, and they need to stop laxative during the test. And after that, with the refractory constipation,
I don't have so much in terms of scintigraphy. So it depends how you look at it. I find diagnosing either slow transit or rectal evacuatory disorder using marker studies is really difficult, as Acharya mentioned. You have to disinfect the persons before you do that. Oftentimes it's not possible to do that. And if you don't disinfect them, the markers just accumulate where the fecal impaction happens. So what I use in the colonic transit marker for is to assess effectiveness of treatment. So if patients on treatment and then they take the marker studies and it shows that actually empties out after 24 hours, you had it, yeah. Or if someone is still incontinent because of soiling and you don't know whether your medication is too high in dosage and you want to just use that to confirm, that also helps. So I think we don't use enough of that, and perhaps it's due to availability. Is that right? Our gastro colleagues, CIS marker.
The next question is actually it's Dr. Tan. Because I think recently or past few years, actually people were given the idea about redundant colon. So question about how common is sigmoid volvulus in children with intractable chronic constipation, being one of the indication for surgical intervention.
Yeah, is that for me, right? Okay, thanks. So the sigmoid volvulus in redundant megarectal sigmoids is a real entity. I've operated on a few of these, but they tend to be, back in the UK, it was mostly in black children who somehow have a preponderance for connective tissue related, issues. So somehow the bowel can dwarf, and it often happens because the anchoring of the bowel is not very good. So usually your descending colon should be fixed to the retroperitoneum, right? So the other group of patients is the one with Marfan syndrome, where the connective tissue disorders in association with their dilated bowel. And I have also operated on cerebral palsy children, where probably it's due to aerophagia. Everything is dilated, including the rectum and colon. So I've not seen a typical
I need 4 mics. All the mics not working. So the question that follows immediately is actually when constipation is associated with a redundant colon, what are the indications before embarking for surgical option, including bowel shortening surgery? Yeah.
So as I've demonstrated on some of the studies we've done previously, the group that's most at risk in the surgical practice cohort is really the anorectal malformations. A lot of them, they are born with a megarectum. There's no opening to start with. So this group of patients, if you manage them well from day one, a lot of them progress well, even though if the megarectum, megasigmoid is persistent. So that means that I tend to move towards stimulants very early on and ensure that they get water-soluble fibers to bulk out the stools, so the emptying becomes complete every time it happens. For those ones that kind of develop later on, when it's gone beyond the point of elasticity return, you find that they can be really challenging, and a lot of them are heading towards surgery. But as our study showed, actually you can still manage them quite effectively with enema therapy. Now, the way I do this is if the enema works, then I will give them an ACE later on. If the enema doesn't work, they probably need resection, because even an ACE is not going to resolve that. We have also published in distal colonic motility issues from Great Ormond Street that when you have dilated systems at the bottom, you can also defunction them for a period, either with an ileostomy or colostomy. Yeah, I'm sure you have that experience. And a lot of them actually recover in their colonic motility if you do a colonic manometry later on. And then that allows us to actually just return its continuity without resection. So you can actually save the bowel that way. Yeah. But I have very, very high threshold of taking anyone's colon.
Are there any other stimulant drugs for children less than 2 years old who comes with functional constipation?
Very comfortable for them to have so big of increased peristaltic movement for such a young age. I think the issue with, but when we feel something, I think we have to assess back whether or not the patient is not taking the medication or the dosing is inadequate or we are dealing with a wrong diagnosis. Anything to add?
Yeah, I agree with you. So you have to rule out Hirschsprung disease for younger children. And yeah, stimulant is not like the best medication for a young child. It causes like more side effect than effective. And normally, I mean, the pathophysiology is involved with the withholding. So you have to focus on like a non-pharmacological therapy more than pharmacological therapy.
Okay, so Andrea, so this is quite interesting. What's your thought on electroneuromodulation therapy like interferential therapy or posterior tibial nerve stimulation in overcoming constipation?
Yeah, so this is an option that we can also use for biofeedback or for training, but it's not available. I think in the eastern side, in the western side, there's many literature tell us that it is working and effective. So I also try to like adapt some machine that we can also perform the electrostimulation, but it's in process.
Tan, for children who are referred to exclude Hirschsprung disease, what further tests if Hirschsprung is excluded?
Oh, okay. Okay, it goes down an algorithm. So if rare is absent, rectal biopsy shows ganglion cells, they have internal anal sphincter achalasia, they get Botox. If they then have, well, the contrast sometimes tells you whether or not there are other issues with regards to the bowel. And we can look at colonic manometry, as you say, and usually if we do a rectal biopsy in an older child, we will start with an anal rectal manometry anyway. So if that also fails, colonic manometry seems to be the way forward. But I also understand that in Malaysia, we don't do much colonic manometry. So that could be a challenge. So if all these fails, we sometimes would just treat it as a functional constipation on a pragmatic level. And then because oral laxative, if it's not working, then we move on to enema therapy. And if that keeps the child socially clean, we accept that as the good end goal. Yeah. And obviously, if that doesn't work, then it comes back to you for people.
In pediatric patient. Mentioned the concern here, would there be a risk of bowel prolapse?
Safety age, my neonatologist colleague actually using graduate enema as well. And small dose, or sometimes they use some bowel anal stimulation to induce defecation. I don't think there's a good dosing guide for enema. It's also depending on the history, the chronicity of the symptoms, the size of the patients. And for me, I use bigger dose. Yeah, and I understand my surgical colleague will also use a bigger dose. Correct me if I'm wrong. And okay, for rectal prolapse, depends on the intensity. Rectal prolapse actually happens when the child is on the sitting position more than when they are on the standing position, when they are doing the defecation. Sometimes when they have prolapse during the sitting position, what we are do is that I continue to give enema, but I will get the parents to to make them stand while defecating. This probably they have a better control on their inner tone, and hence they preventing the rectal prolapse.
Sorry, I'll just quickly mention our enema regime is typically saline with 10% of the volume of a soap. So that's what we do, and it's internationally recognized as a good way of giving enema to patients. You can use glycerin if that's slightly more medicinal to you. Yeah. Yeah. So rectal prolapse, I agree, because it's the anorectal angle that you do not want it straightened altogether. So on a standing or 90-degree sitting positions, you don't get, you still maintain the anorectal angle, therefore you're less likely to prolapse. Yeah.
Yeah, agree. Acharya, I think that will be the last question to Dr. Acharya. So what is or are your selection criteria for children with constipation to undergo biofeedback therapy?
Okay, so the first to answer this question is when to perform anorectal manometry, because to do the biofeedback is for dyssynergia. So you have to diagnose dyssynergia first. So with the younger children, they couldn't undergo the anorectal manometry awake. So if we perform it under sedation, we are not able to ask them to do the push maneuver. So we need to select the cooperative child. So normally they will be older than 6 years old. And if you identify dyssynergia on the manometry with the constipated symptoms, then we may convince them to do the biofeedback. Yeah. And you also have to assess their cooperation during the procedure, because they have to understand what to do during the biofeedback training.
So I believe actually everyone actually has a better understanding about constipation in children after this session. That will wrap up our session on constipation. So please join me to thank the speakers at the grand round of applause. Thank you. Yeah, thank you.
Thank you very much, distinguished speakers, and also Dr. Ong Sik Yong for moderating the session. We would greatly appreciate if everyone could step aside to collect your token of appreciation. Ladies and gentlemen, as we continue, we will have our tea break, and I would like to share a small reminder regarding our CPD points and e-certificates. For our physical participants, our team will be scanning your MMA app to give you your CPD points at our registration counter. Kindly ensure your attendance is recorded before leaving the venue. For our virtual participants, please remember to complete the feedback form so our team can proceed with issuing your manual CPD points. For both physical and virtual participants, please complete the feedback form for your e-certificate. Thank you, everyone, and we would like to kindly invite you back to the hall by 4:10. Thank you.
Say.
Thanks. Sombong thing.
I think my phone tak cantik gambar. You know, my colleague always confirm. When I ambil gambar, she take my Sasha lah. She take my phone, she give me her phone. Hey, Dr. Chia. Oh, give me a second. Give me a second.
I would like to introduce our last and final symposium. So our next speaker is Dr. under the Ministry of Health Malaysia. His clinical expertise includes caring for children with life-limiting and life-threatening conditions, with a focus on complex symptom management, chronic pain, transition home care, and end-of-life care. So with that, I would like to invite Dr. Lee on stage to give his talk.
Thank you. Thanks for giving me this chance to share what is pediatric. How come children also got palliative care and also children got hospice? Yeah, actually we have, okay? So with the improving of our health situation worldwide, especially in Malaysia, so less and less people die from all those infant mortality, infection, but more and more chronic care, even for children, coming out. Unfortunately, when they survive, a lot of them are surviving so-called dependent on the technical, either surviving on the oxygen or we will have to going more and more dependent on the machine. So they are called, this group of people called complex chronic condition, where the medical condition definition is the chronic complex medical condition can be reasonably expected to last at least 12 months unless death intervened and to involve either several different organ system or one organ system severe enough to require special pediatric care. So this group of people have been growing up the number, and even with the WHO latest number have shown that 1/3 of the child who pass away, 1/3 of the child who have a medical condition, they are all fall into this complex chronic condition. And 40% of those pediatric hospital deaths are also belong to this group. So you can see that the old model, last time we always have this curative, rehab, palliative, very clear phase of illness, phase demarcating. But actually the current situation is wrong. With this improve of technology and thing, sometimes the disease may not be cured, but they can still prolong life for years and years. And this is very different from adult palliative care, where in adult palliative care, 80% of the patients who go for incurable disease are still cancer, and so but in children they are more on like they're still growing and with this chronic condition that they are facing. So if you look into this, what is the best model to take care of this kind of patient? The answer is palliative care. And palliative care is the total active care for patients' body, mind, and spirit. But not only, and for those children who have life-threatening and life-limiting diseases. And not only for the child, but also the family. And you should start from the diagnosis and continue until regardless the direction of the disease. And because too many things need to take care, we also need a broad multidisciplinary approach. And it should apply in every kind of health system, either including the palliative care need to go to the community with the whatever resources and go to patient home. So with this, the summary of the definition is this 5W definition. It's a whole person care, whole family care, whole process, whole team, and whole community. So you can see this is the concept of care that never mention disease, never mention any organ, but I mention mostly about patient, the human, the art of healing. So this is the concept of palliative care. So for children palliative care, we range from 0 to 18, but actually nowadays they even go to perinatal period when the mother still having the baby in the womb. So that when they have diagnosed some complex condition, sometimes we get a referral from MFM also. So you must fulfill two criteria. One is life-limiting and one is life-threatening. So a lot of people not so sure, my colleague, like when should I refer to palliative care? So if you're not so sure, if you want to have anything black and white, you can go through this pediatric palliative screening score. They comprise of 5 domains, and you can download from the internet. And it look at the trajectory of disease, the outcome of the current treatment, symptom burden, family burden, and your life expectancy. So this is filled by the doctor. And these are the questions. So if you fill out the form, and anything more than 15 marks, you should consider refer to palliative care, because I think the disease and the patient and the family have suffering more and more complex, and they need more help. So other than that, objective measurement, what you can look at is following the Royal College definition. There are 4 categories of patients fall into this life-threatening and life-limiting. The category 1 is the one life-threatening condition, where you can see the graph. Initially, still got treatment. These are patients like, for example, oncology, still got treatment. Then come to the point, either they get healed or they get deteriorate and dying very fast. Or other organ-based problem, like for example, dialysis. So this is the group of patients where the parents and caregiver very anxious because they keep waiting when is that day coming. Then second category is those who slowly deteriorating the function. The function can either the hormone function or the organ function. For example, the dilated cardiomyopathy, it can be slow, deteriorate, crossover, sometimes go up to the teenager or early adulthood. For this kind of problem, usually the patient can speak, can talk, and they can tell you how they see themselves deteriorating. Another issue is the whole family maybe have 2 or 3 people having the same genetic problem for this. So the grief issue may be the problem in this kind of group of patients. Number 3 is those who initially are well, suddenly have some infection or some genetic condition like causing neurodegenerative function. So very fast, usually they will die within 5 to 10 years old. So this is the progressive condition without curative treatment. And the last one is the most common one is the one having some problem from the beginning, early childhood, either meningitis, severe jaundice, or having the HIE. So having the low function from beginning. So this group of patients have actually need a lot of support, especially for the long-term caregiving for this kind of bedridden patients. So this is the total 5 group, but what I say is that now currently we have added the number 5 is a perinatal and neonatal. So for MFM, they start referring for palliative care even to support the mother, especially for this kind of pregnant mother. Last time when there's no palliative care, the only option is only termination of pregnancy. But because have the choice now, a lot of parents, they may want to continue the pregnancy, and we need to support them from the beginning. So this is the study done in 2017. They've gone through the 15 hospitals in Malaysia to look into what the disease that fall into what disease group that fall into palliative care. So you can see 37% is a congenital malformation, chromosomal abnormality. And then followed by the nervous system, anything that is due to the brain and the nerve. Then neoplasm is only 19%. So this is very different from adult palliative care, where usually 60 to 80% of adults palliative care are all cancer. Then the rest we have those perinatal or other more rare disease. Then how burden is Malaysia compared to other country? You can see the first one, the India with the biggest population. Their need is about 4.2 million children need palliative care with the ratio of 34%. But you come down to Malaysia, with our current population, that means 80,000 children every year need palliative care. And under that 80,000, 30,000 of them need specialized care. Unfortunately, in my hospital, every year I only see 200 new patients. So where are the rest? So you can see our ratio of palliative care needs at 28.5%. But compared to a more developed country like UK, they also need I think UK population is 3 times than us, but their population need is less than us. So you can see actually with a more developed country, the need for palliative care maybe is less. I would say maybe because they have their primary care have been doing very well and been doing all the prevention and treatment, or maybe the rehabilitation and curative have been doing very well. So that's why their need for palliative care is less. So the first concept of the palliative care is called whole person care. My first case when I came back from UK in 2018, that time I have no patient. I just like when I first came to this Sunway also. So I follow those doctors, I went to see them, and I want to look for those patients. And then suddenly got one patient referred to me. And this girl had been 4 years being pain over the neck and the shoulder for the past 4 years. And this girl has this low-grade glioma or lower cervical medullary region. So this glioma will not kill her, but the pain is there. And the pain have causing not attending school, causing the family, have been causing not only the pain, this child also have autonomic dysfunction because suddenly she can have a breathless, she can have a temperature swing, or she can have a sudden blurring of vision, in which the NS may think that that is the cause of the side effect of the morphine or all these things. Actually, it's not, but it's patient have concurrent multifactorial, have concurrent other symptoms where we need to treat together. So that is the physical. For psychology, we also, when the patient have depression, anxiety because of the physical problem, that will catastrophizing the symptom more. And then in social, because of the pain cannot control, most of them cannot go to school, and she cannot go to school. And the father we're getting no more coming to the clinic time every day. Then because father said that this child is not my child, already different from the past, I cannot accept it, I don't know how to face it. So you see, because of one problem of the child, the whole family will disturb. So we need to support the whole family as well, especially in the spiritual care. The mother will every day keep asking, why my child, why not other child? Actually, when anyone asks about this why thing, it's actually they may be into the grieving process, the grieving of the loss of the normal healthy child. So with our help from this girl, currently the pain is still there, already with me for 10 years, but she knows how to use what medication to control the pain, and she can go back to school and can sleep and can do anything that she can. And this is the photo that she get the competition of cooking in the school. So this is how we look into the whole person care by ask this kind of question: physical, social, psychology, and spiritual. A lot of people don't know how to ask about spiritual. Is it related to religion? Not really. Spiritual means like you look into the meaning, you look into how the patient understand the disease, what's their hope, what's their wishes, and also the overall of care for this child. So when people always ask me, what's the difference you managing pain compared to NS team or other team who manage pain? To me, it's first, when we manage pain, we always know that pain always comes with at least three other symptoms, which is the common one are anxiety, breathless, and fatigue. So you cannot just manage the pain because all will become a cycle and come back again. So you need to break the cycle, you have to treat the rest also. So because one will lead to another, that is called the holistic management for the symptom. So this study also showed that you can see the average, the top one, the average, every 6 not treat the symptom well, we don't not cover them, a lot of time they may end up defaulted your treatments or your treatment may take some. So how do we look into this symptom? So all my oncology patients, when they come, they will fill in the form, they will answer this, for example, memorial symptom assessment score, where the child will fill himself whether I have pain, I have nausea, vomiting, I have constipation, I have image problem. The image problem also is also part of the symptom. Yeah. So there are many questionnaires you can use to measure. So I always ask myself, I only see 200 children per year, but where are the rest of the child? So I don't know, I have no idea. Until I've been working for a few years, then I realized that a lot of patients, they're stuck in the hospital, they are with you, and they cannot go home. And why cannot go home? Because of too difficult. For example, the first case, this girl, and initially they have been in the NICU for 7 months, and RESPI have seen the patient, have go to the hospital, have gone to the home visit and assess and fill all the criteria to go home. And that's why the child have been stuck there. But actually, when referred to me, I just need to spend more time and get more communication, and then we lower down a bit of the criteria, but not the safety. I mean, the other criteria. In the end, with the 2 hours conversation with the parents, we finally found there's one home she can go home, and we just send patient home to one of the relative home. The patient only need the NIV for 2 months at home. After that, we can off. The child stuck with this NIV because of recurrent infection and aspiration in the hospital. The other boy is a 11-year-old boy, Indian boy, have this cancer with multiple mets to the spine and causing the tetraplegia. The only thing that he can move is the eye. So we see the patient in the ICU, and with the eye tracking system, we're able to let him spell the sentence, the ABC. The only sentence that he spelled is, I want to go home. So then we tell the parent, but the parent cannot accept. He said, no, we cannot. If we go home, that means we are giving up, and then this is not true, and we cannot do this to our God. We believe that God will help us. So then, unfortunately, the child died after 2 weeks and get another infection in ICU. So you can see that a lot of our patients, the 80,000 is because they all stuck in somewhere. So they cannot go home. To you, go home is a very simple thing, but to them, go home is so difficult. In order to go home, they need to get a machine, and machine, you have to apply, and maybe one NIV will cost you 20K. Where to get the money? So you have to apply. They apply, you wait for 6 months to 1 year. But so we have to think of other alternative to help them. So I mean, there may the physio to look into the tower chair. We actually use a lot of rehab concept in the palliative care as well. So then we will talk about advanced care van with the parents and the child if the child can speak. So in the end, nobody will make the decision alone, because we are doing the decision by using the understand the best interest of the patient. So with this goal of care, we follow through the patient from point A to point E. From the point A is during diagnosis. Point B, when the patient is stable in the clinic. Point C, when recurrent admission and the disease deterioration in the point D and pass away in the point E. So actually every single point of them, they require different things. For example, at the point A during the diagnosis, the problem is they have a decision-making problem, they have so much symptom need to manage, they stuck in the NICU, they stuck in ICU. So these are the strategy we can use when we have our team, how we can help all these new patients. But more importantly is to do the transition care program. So what we need to go through with the parents are their knowledge. They need to go through the education program, their knowledge, their skill, all the documents to prepare as well as their technique. Then we go to, when they come to clinic also, actually many things we need to look into as well. The care is not finished. So we also look into the patient, start looking into the hope, the patient risk, and their understanding, for example, and then how much we can bring them back to the normal life despite they have the chronic illness, as well as their parents. We also look into the caregiver burden score, caregiver competency, all these things we will do in the clinic. There's so many things can be done. When they're unstable, recurrent admitted to the ward, the symptom management need to intensify because every child come in, for example, increase. Then when they come to, when we have done enough good palliative care, when come to deteriorating phase, the parents start accepting, then they will, then we can reduce all the unnecessary management. So this, for example, I say just now, if the patient come in pneumonia, the 5 things in my team will do. First, we treat the symptom, pharmacology and non-pharmacology, symptom of breathless, fatigue, cannot sleep. And we also try to look for the cause, to reverse the cause. For example, maybe seizure uncontrolled because of constipation, poor absorption of the drugs, and also recurrent pneumonia, we want to find the cause. Then at the same time, we also enhance the comorbidity management. Sometimes we have to increase the dystonia medication or the reflux management while in the admission. Then we also look into the caregiver assessment and home care burden and challenges and their need while patients still in the ward. Then we also involve the MDT to look into the transition of home care management. So when they are dying, we based on the advanced care plan, we follow what the parents and the child want, we do. If they prefer to go home, so we have involved the hospice or community as soon as possible. So this is our whole team. Like for example, we run this MDT clinic. You can see in one clinic, we have one-stop center, we have physio, OT, counselor, social worker. We settle all the appointment in one appointment. So this is what we run in the MDT Pediatric Palliative Clinic. So if you want to look at the standard for pediatric palliative care, in the NICE guidelines say that there are 6 things you need to have in your service. First, you need to have advanced care planning. Then you need to have a named care coordinators. You need to have psychosocial support, MDTD care, end of life and bereavement support, and the last, 24 access to the specialist support. So where are we in the whole world currently? So if you look at here, Malaysia is where, so we are not so bad. We are about 3 to 4, where we are already established. Unfortunately, we are still far from the specialized in our pediatric palliative care. So with the effort of 8 years, initially in 2018, in KKM, we only have 5 hospitals have this pediatric palliative care. Now, after 8 years, we have 23 hospitals with KKM have this pediatric palliative care. And in private, I think this sunmed Medical is the first one. So, and also, if anyone of you interested to join this field, there are actually many education chances you can go through. Either you can go for the 2.5-day course for national training in peds palliative care, or you can join the special interest group or area interest and fellowship. All kind of level of education is ready. So as I said, palliative care involves also community. We cannot just build the palliative care in the hospital. What we need also palliative care in the community. So we built out the one association called Malaysian Association of Pediatric Palliative Care, MAPAC. After 5 years of work hard, fundraising, advocacy, finally in 2023, we opened the first children hospice. Before that, actually, we have 22 adult hospice, but adult hospice only see oncology patients above 10 years old. Those non-oncology and less than 10 years old, they won't see. So we have to build our own children hospice. So children hospice, so until now, this year we have total 6 children hospice, and we hope in 2030 we'll have the first children hospice with inpatient care. So in order to run this service, actually it's not cheap. Even with 3 hospices, you need to have 1.2 million fundraising every year because we charge 0 single cent to our patients. And you see the workload that this is the only 1 year. If we add it up, we've got about 2,000 home visits carried out by these 3 hospices. So this is the first children hospice. If you have time, can visit in Jalan Kuching, the first children hospice. And we also publish a lot of caregiver handbook in order for us to run the caregiver education program. So in the final, I want to say, complex care, I think all of you have been doing complex care, continue your chronic care, see your patient, but at the same time, don't forget there's I think all the patient family, they need also palliative care in order to help them to reduce symptoms, talk about what they want in the advanced care plan to empower them and support them from beginning, even before patient pass away, and psychosocial and spiritual care. And we can see that a lot of time when there's a current gap in the chronic care is the one thing is the intractable symptom management, complex decision making, and advanced care plan. A lot of time I found that a lot of my colleagues, when they talk about advanced care plan, they let the parent make the decision. But actually that's not the right thing. We should educate, we should guide them, and we should tell them we should share the decision together. So if you can see that the patients. So there are many studies taken care management, and then 6.5% have this improved in terms of the management of the pain, and 7.59% have talked about advanced care plan. So in the end, I would say pediatric palliative care is not end of the road. It's just one of the truths. For example, from here you want to go to Ipoh, you can use the highway, but not everyone can use the highway if the patient condition, the car is not good. You can choose a smaller way, go slowly, but enjoy the every scenery on the wheel. It's just we look and to combine the medical and the humanity and the art, so that in the end they still complete the whole journey, but in the other way. Thank you. This is my reference.
Does the crowd have any questions for Dr. Lee? Okay, if there are no questions,
Recording in
rehabilitation
progress.
medicine at University Malaya. Rehabilitation at the Women and Children's Hospital in Adelaide, Australia. Let us welcome Dr. Chen to stage.
Hi, very good afternoon. You can see the beauty of having an assistive device that helped me you all can see me now. Am I right? Okay. This is what rehab is doing. We're using whatever extra to actually help people to function more. Without the assistive device, the stool, you all will not see me. Okay, so this is rehab. Oh, you can go back. Okay, I would like to take this opportunity to thank Sunway Medical Center for inviting me to share a little bit on what is pediatric rehab. Okay, let me see what happened. I thought I can have that presentation thing. Okay. The topic I wanted to tell you about is maximizing potential, what if pediatric rehab care across the life cycle. You can do it. It's like age limitless. It's just like a palliative, but we are a bit more joyful. Okay. Okay, let me start with telling you what is rehabilitation. You can know that I'm not that young with that, since I'm not that tech savvy. I think can have that full page or something. I don't know. Never mind. Should be fine. Okay. WHO definition for rehabilitation is defined as a set of intervention designed to optimize functioning and reduce disability in individuals with health condition in interaction with their environment. Okay. So without this help, I am disabled. If I take off my glasses, I am disabled as well. I'm visually impaired. I will not see any one of you clearly. So glasses is my aids and is part of the rehabilitation tools to help me. Okay. In simple terms, I like this very, very old definition. It's by Cruzen in 1965. It just tells you what is rehabilitation. It's a process of helping people to reach the fullest potential in all aspects: physical, psychological, social, vocational, avocational, and education. So in a whole, we see patients as a whole. They are expected to involve them in life as a whole. Okay? But of course, it's going to be consistent with his or her physiologic, anatomic impairment, environmental limitation, and desire and lifespan. I want to ask, how many of you like to cook? Oh, less than 10%. You know that when you go for occupational therapy, one of the domestic skills that they always like to train patients is to cook. You just imagine you don't like to cook and you are forced to go into a rehabilitation to tell you, teach you to cook. I hope got someone to cook for you, isn't it? And grab and order online is so easy. So why do you need to learn? Of course, you will not be happy with the rehabilitation process. Right? Role of rehab is very simple. We determine what is the functional capacity to perform in a situation, in a stage. Determine what is needed to be independent, and we provide the difference. Simple, isn't it? 3 lines only. No need to come for the lecture. Okay. Like for disease classification and coding, we have ICD-11 now. All right. But disease doesn't say you have a certain disease doesn't mean that you are going to have a certain function. You are going to perform as well. You have a diabetes. Am I right? ICD got one certain code, isn't it? So, but whether you have a diabetes, you have an amputation or not. And if you have an amputation, can you walk? Can you do work? Can you go anywhere? If you're given a prosthesis, you still have an amputation, but you can go to work because of the prosthesis. So then this is why ICF can tell you what is the function. ICF was started is by WHO since 2000, year 2000. It's quite old. It's not there. So it says that in this here, we actually tell you that the health condition actually affect your body function and structure, and you actually affect whether you can perform or not, and whether you can participate in the community or not, and do your role or job. But it also is not just one way. It's actually interconnected, but also the importance of the contextual factor, the environment factors, and the personal factor, your motivation, your likes and dislikes. the environment. If I'm just telling you that day I went to my son, I went overseas with my son and we rented an Airbnb at 7th floor. Got leave, okay lah, huh? Then it suddenly got that fire drill alarm, evacuation, evacuation, evacuation. I was like, 7th floor. I have to walk down the steps, 7 flights. So that is the environment. And luckily, I don't have to walk up the stair. I just need to walk down. So that is it. The environment factor actually play a very important role. Okay, I'm going to tell you about rehabilitation cycle. What do we do basically? You can see that in rehab, anytime you've seen us, we are also like palliative. We don't have a disease. We don't see patient by disease. We see patient with impairment, if some issues that can hinder their function. So we assess and identify what is their needs. And as usual, we work in a multidisciplinary team. It's not every patient who need an occupational therapist, physiotherapist, speech therapist, audiologist, psychologist, nurses, doctors, and everyone. It's not every patient who need that. So we have to assign, allocate the resources. Who come first, who is more important first. You need to see the patient back, see whether medicine work or not. The same thing with rehab. When you assign for other therapy, you need to see whether it works or not, what hinders it, whether it's any spasticity that causing it, contraction that causing it, or any pain that causing the patient's not performing. So that is why we need to evaluate, and we like to talk. As usual, we have a weekly or monthly team meeting to discuss the progress of the patients and then see what's the things that we missed. And we started with a common goal among the team. You can just imagine, you have a physiotherapist that says that I want to train the patient to walk. And the occupational therapist says, no, the sensory problem is more important. We need to tackle the sensory first. So our physiotherapists gave 3 types of exercise. So the speech therapist, you need to go for speaking, you need to practice speaking, learning everything. And at the end, when the patient come back, why no progress? I don't know what to do. I do the simplest one that my child like. Of course, it will not have progress. Then that is the role. To introduce the concept of inverted ICF. Those that have toilets that are disabled can go. To be rented, but she don't want. She wants to walk. Should I say, no, I'm not going to allow you to walk? Should I say that we cannot do anything, you need to use a wheelchair? She don't want to go to school without walking. We have to think of what sort of other orthoses that will help her to move better, not the current method. This is what the rehab is about, to get the patients back to their life, to participate in the community. Okay. Pediatric rehab is slightly different from adult rehab. Adult I have learned how to walk, isn't it? I have learned how to talk. Then we have a disability, you return back what you have to learn. But children, they need to be taught how to walk, how to talk, how to think. If you don't give them the opportunity, they will be that baby forever. Okay, and it's more joyful and more colorful in pediatric rehab. And you see that the ICF framework is converted to the F word in a good way, not the F word. Okay. So we talk about fitness, the physical body structure and function. You need to be fit to go and play with your friends, isn't it? To have function, you need to know how to eat so that you can enjoy the cooking, the eating outside with your friends. You need to go and participate in the community so that you can have friends. And environment factors, a lot of time, is actually your family. Children, how can a child go out and play without the family? You will not have that heart, and they will not allow them. And you need to do something in a fun way. Do you want to join something that is not fun? No, for us, that also we don't do, isn't it? So, of course, in children, you need to do it in fun. And you need to look into the future. Prepare them and the family to the future. Okay, so when you do an assessment, think about the most important one is actually patient. We tend to forget. As children, we always ask what the parents want. And we tend to forget what the child wants. You need, and a lot of parents actually tell me that when they are younger, it's much easier to do the home exercise program, and they do a homework much easier. When they are teenagers, they're not that dengar cakap according to the parents. They don't listen to you. But why? Because they don't see the point of doing the boring exercise, not doing anything. And the goals that the parents want is not what they want. Then that is why we need to take into consideration the whole family as a package, not what the parents want, what the child wants, and we have to educate the parents and come to a middle place. Sometimes what I want the parents to do, what I want the kids to do, the kids doesn't really do. But they are very clever. You cannot say that children that we see with disability are not clever. They will know that when they come and see me, I will ask, do you do exercise at home? To do that. I said, then the parent will say, then I will ask, do or not? Then the parent said, yes, last week started because they know that they are coming to see you. So you can see, our kids are very clever. We just need to give them an opportunity to practice. At home, exercise are very boring. How many of you are actually exercise regularly exercise? 1, 2. Oh my God, it's less than the cooking. You just imagine if the physiotherapist tell you, you need to do sit to stand 100 times a day. Practice. Sit to stand. You do that. But you have to tell it, maybe you have to change it. You give them the opportunity. Then you say that when you sit down for eating, then you have to come up and then get the things. It'll be one time already, is it? But nobody count. But you come up for a side, you have to do a sit then for 100 times. You, of course, will not do it. But you put in the sitting there, then your favorite toys is over there, then I have to stand up and get it. So there is exercise in another way. So we need to make it fun and functional. I need to do it. If my parents are so nice, or my siblings said, oh, that boy, now they actually order the siblings to help him to take things. If I have something I got order, I want water. Can you help me to take, please? I don't need to move, isn't it? So I have lack of practice. So we need to create the opportunity for them to practice as well at home. And here where parents are very important. Because the parents will not say, kesiannya kita have to care. We have to take care of them, isn't it? Having a child with disability. We need to help them. But if we don't give them opportunity to practice, to be independent, they will never do so. Okay? And then with the ICF, I'm just looking at the most common physical kids that we see, cerebral palsy. Cerebral palsy is because of the brain, a non-progressive insult to the brain at the immature brain. But it affects the musculoskeletal problem. We have contracture, we have spasticity, we have constipation, we have respiratory problem, we have pain, we have all those everything. But then it will affect how you perform in the activities of daily You can't ask a baby to say that brush your teeth, isn't it? No, at 7 years old, you still help them to dress, even for normal kids. Sometimes when you run fast, isn't it? But when the kids is 18, a CP kid is 18, and my mom is so old already. By 18, I think I'm 18-ish, but more, isn't it? I cannot help to dress, and it's getting the weight. I cannot carry anymore. So how to perform the activities of daily living? You cannot actually tell the kids, you are big now, you are 18, you need to be independent. You will not be able to do so. You need to train them from the beginning. This is why rehab is important and start at very, very young. Another thing is meaningful participation. Kids, the job is to study as to play. All right. If you don't have an environment for them to play, you don't have to go out. As what Dr. Lee said just now, when I was started many, many years ago, we don't really see disabled kids outside, isn't it? CP kids, cerebral palsy kids. We only see them when they are young. But what happened to them? We don't see this in teenage. We don't really see. Is it why? Young adults, the severe one. How to carry a 30-kilo kids up? You all got kids, isn't it? When my kids are small, when they are around 3 kilos, still can 5 minutes, 10 minutes. But when they are going into teenager adult, how are they going to come up? How are they going to carry them? 20 years ago, wheelchairs, pediatric wheelchairs is a luxury. It costs more than 10K. Now it's cost more than 5K, also is very hard to get, okay, because of the financial. Children grow. You cannot have one wheelchair for 10 years. You cannot get a big one so that they can sit there, so they can last longer. You can't do that for children. Okay, so ICF framework also apply for children, and then you need to look at the environmental barriers and facilitator. What are personal matter? Because the interaction, in fact, function is determined by how the environment and personal trait interact with health. Okay? And you always say that, hey, the child can do in the work in the clinic. You always use that paper for them to write A, B, C, 1, 2, 3, isn't it? In the clinic, the child can do. They are so clever. Why are they not in school? I have a kid before studying in a special education class in the school. He was very bright. He can speak CP, cerebral palsy, GMFCS of 3. That means that using a walker to walk. Cognition very good. He can answer you, kind of thing. Then he was admitted when he was, at that time, was 8 years old. He got number 1 in his class. They asked, can you write your name? He cannot write his full name. He's been receiving special education for 3 years. He can write AB, because in the clinic, we don't ask them to write until Z, isn't it? We only ask ABC, okay? And that is can do. But with that education, going to the special needs class, when he graduated at 19 from the secondary school, what is he able to do to find himself a paid job, to earn a living? This is what rehab wants to help them to be able to function when later on. We are not seeing what the patient is capable to do in the clinic, what they are able to perform at home, because the parents are actually modify the house, modify the environment to suit the kids. And a lot of parents with chronic disability modify the house to become a mini hospital, mini gym. When you go out to the real world, here, do we have a mini gym? Do we have a barrel bar for them to walk? How many companies will have that disability accessible services, facility, toilet, restroom, car park, even our public transport? We have parents that cannot come to the hospital or church because the Grab doesn't want to take them. So we need to look into children with disability. They are growing up one day. They are going to be adult. How are we going to help them? So we are not going to see what they can do, but how they can perform in the real world. Okay, and pediatric rehab is not just outside. You can be in acute, in ICU, in inpatient, when in during acute care. Early mobilization, prevent complication, and medical family education from your side, like what Dr. Lee said, is very, very important. It's easy. TB meningitis, I think you have a lecture yesterday on TB meningitis. I used to have one patient before, was in the acute hospital for 6 months, TB meningitis. Bedridden, 6 months, and all already when it comes, we have an ankle contracture already. So the ankle is inclined, so it cannot move. So it's not in one way. So only like wearing a high heel all the while. I want to tell you is, if you do an early mobilization, we take care of her well. I think it's why I'm talking about this TB meningitis, because the first thing that whoever patients that transfer to my ward, it will bring it that go bathe, take a bath. That bit sponging on the bed is not taking a bath. Okay? It's not. So I said, has the patient take a bath? You know, like, I think that time was quite a long time ago, about 5, 6 years or maybe 10 years ago. So they have that whitening cream, face cream, very popular. Then they have that skin tone thing. You will go and use this product, you have reduction of one skin tone. After she take a bath, I said, where is the patient? I said, become 2 skin tone reduction. So you can imagine. So this is the patient that come to us with because we have a shower bench that she can actually bathe. But when she go home, how is she going to take a bath? We need to think from the day one that they admit. Okay. So then all those contracture and then the constipation is also very important, because I have a traumatic brain injury boy that was very agitated and very stiff because of the stiffness, spasm, and spastic. When they come to us, we just clear the bowel, cognition improve. The next day, patient walk back after 3 months. So these are the things that we need to say. We see patient as a whole, not as one of the symptoms. So acute stabilization in ICU, in inpatient, we can do a lot of things to prevent the complication, especially pressure ulcer, contracture, all those things, and respiratory care as well. Then in the post-acute or outpatient, we build their skills so that they can go back home, and also to teach the parents how to actually handle the kids, prepare the parents to take the kids home. As what Dr. Lee said, we don't want to keep the patient a long time in the hospital because of all the hospital-acquired infections and all those complications. Then after they go home, they are able to be independent at home. We need to think about how about in the community. So it's so the assessment, we cannot give you what are the assessment tools that we use, because it's very dynamic and age specific, and it's different for every condition of the kids. But the most important thing is it's a family-centered goal setting, okay? And you use a multi-screen team members. Okay. And it's not just in the hospital, it's the lifelong. Okay. So pediatric rehab is not only in the life, can be in the early childhood to promote them, focusing on their mental milestone and early intervention for the school years, so that they can actually manage the growth-related changes throughout through like spastic control, the bracing, school integration, and also the teens transition going towards the university. I do need to share that children with cerebral palsy can go to university. We have one that spastic dystonic has been following out with me for 14 years. She graduated already. She's the same age as my son. She's now working as an assistant accountant in one of the library in Selangor. So she went to uni, quite far away, dystonic CP, using a reverse walker to walk. She drove herself. She got a car, modified car. She got driving license, and last time when she go to uni, she went to uni, she actually just drive from house to the uni. And when she work here, she's staying alone. The parents are in Perak.
And the mom, that day I met the mom, I met them, and then my mom was saying, she went to KL, explore good food. She went by herself without informing the parents, and she drove from KL back to Ipoh. And the parents was like shocked because by the time they knew, she was already home, alone, driving by herself, without the mom sitting next to her. So, but this is what she's independent. She got confident that she can do, and if we have as a family support, you can actually give a child a life. Okay, conclusion. So rehabilitation cycle is actually a lifelong roadmap to functioning. So you can do from children to elderly to adult. It's just the 4-step cycle is always the same, depending on the situation of it. I wanted to share this as by Dr. Nathan Jones, a rehab physician from Australia. Say, disability should be recognized as a major risk factor for future disease, advancing disability and decline. Rehabilitation medicine, therefore, is a role that extends beyond restoring the function, getting them to move, to be able to eat, to be able to dress, to be able to go to school and work. We help people maintain health despite disability by preventing deconditioning, preserving participation, and reduce the cascade towards further disease and decline. It's for adults. For children, I think that pediatric disability is a risk factor for secondary health complication and functional decline, and which are rarely inevitable outcome of the primary diagnosis alone. They are driven by modifiable factor, reduced participation, deconditioning, and the secondary condition. So pediatric rehab is not just about restoring function. It's about protecting a child's future and safeguard their well-being across their entire lifetime. UNICEF says every child, every right. That's why I would like to share Robin Rich. I went for a conference in Darwin. I was at opening ceremony, has this lady that on an electric wheelchair and went up. In Malaysia, opening ceremony, normally we'll have some big shot to come and give a talk. So I was saying, who was this? So this lady, Robin is actually a senior. She's a disability service advocate, which seems that every person with disability have rights. She's founder of Ability. She received other Australian medal. She has a Northern Territory Senior Australian of the Year in 2020. She released for her. And she says something. And normally, whenever I go from her, I seldom take down notes. But this one, I cannot help it. She is a CP-like elderly lady. CP-like. She said, I was told by my doctor I'm a CP-like, so I'm going to stick with the CP-like. So she said, I could not have done what I have done today without rehabilitation. That shows that rehabilitation can go across the lifespan. She's doing what her responsibility. She believes in every child, everyone have a right. She's doing her responsibility as an advocate for the person with disability. That's why she was there talking to the whole bunch of young rehab physicians in Australia. Because she remember what her father told her. You have the same rights as everyone else, but you also need to take up the responsibility like everyone else. If you are not going to take up the responsibility, you don't talk about rights. Now, to help every child have the rights, for them to use their rights and do their responsibility, we hope that pediatric rehab will help them along the journey. With that, I thank you.
Thank you very much, Dr. Chen, for that insightful presentation. Does anyone have any questions for Dr. Chen?
Anything you can email me.
Okay, we actually do have one single question from, We do have a single question from our online participants. They asked, what about posterior fossa syndrome and whether following surgery it can still be recognized as a medical condition?
I think the posterior fossa condition, whether tumor or not, is still a medical condition that causing the disability. The diagnosis is there. But whether it affects the function or not depends on what is the recovery of the patient. Okay, we do have posterior fossa tumor where you have a spastic, you have ataxia and balance problem. Then you still have a disability. Whether the disability is temporary or long-term, permanent. Okay, we can recover. So we can see. Okay.
Okay, thank you very much, Dr. Chen. Appreciate if you could step aside to collect your token of appreciation. As we come to the close of today's symposium, it is my pleasure to invite Dr. Ng Lili, General Manager of Women and Children Services at Sunmed Medical Center, Sunway City, to deliver the closing remarks. This symposium would not have been possible without her vision, leadership, and unwavering support in bringing this initiative to life. Ladies and gentlemen, please join me in welcoming Dr. Ng to stage.
Thank you, Farah. Yeah, thank you, everyone. Thank you so much for being here as participants and still here, even, it's 5 something already. So I will keep it very, very short. I just want to use this opportunity to actually take everyone through what we have for the Children's COE in Sunway Medical Center. So just a very quick one. Yeah. So as all of us are aware that Sunway Medical Center is one of the largest quaternary hospital in Malaysia, where we have 853 licensed beds, one of the largest, and we have 370 specialists under one roof, and we have 27 years of experience. And everyone now is actually in Tower A, and our Children Emergency Department is actually located in Tower D. And in Tower E, we have the pediatric ICU, the pediatric wards, and outpatient departments at Tower D. And you can see there's a little Tower F there, and that will be our future children's tower that's actually opening soon. And in Sunway Medical Center, our focus of service is actually, for children, is actually in Tower D and Tower E. And we have 56 consultants for now, and the numbers keep changing every year. Last year, I remember telling everyone we have 52, and now we have 56 and 28 pediatric subspecialty. I remember telling everyone last year is 26. And for this, we actually have children emergency departments, which is the first dedicated children emergency departments in the private hospital in Malaysia. And we have a pediatric intensive care unit, which is the first and the largest private pediatric intensive care unit in Malaysia. We have a dedicated pediatric hemato-oncology wards and daycare, and also children developmental departments in Tower D. So for now, we have 138 pediatric wards, dedicated pediatric wards in Tower E, and 17 PICU beds, 12 NICU beds, 27 nursery beds, 6 hemato-onco daycare, 8 hemato-onco ward, and this is going to be expanded to a bigger one soon. And 10 A&E beds and 16 surgical and daycare wards. And this is the team. This is our heroes behind all the subspecialty service that we put in. Now is 56, 28 pediatric subspecialties. And of course, of the 56 consultants that we actually have 33 under the 17 medical paeds subspecialties, and 15 consultants under the surgical team across 7 pediatric subspecialties, and 8 consultants from the ancillary departments, where we have 4 pediatric subspecialties, including the nuclear medicine and the pathologists. So Children Emergency Department is located at Tower D, ground floor, near the aquarium, which is one of our very famous place for our children to play, because there's a big aquarium at that tower. And in this emergency departments is actually being, it's a purpose-built place where we keep the environment very safe and friendly for all the children that uses that service. It's a one-stop center where you register until you see the doctors and you discharge with medication. It's all at the same place. So pediatric intensive care unit, is actually established in May 2023. We have 17 beds. Tower E, level 4. We house all our critical ill patients there, and we accept patients up to 18 years of age. So this is a team behind the PICU wards, where we have 3 full-time pediatric intensivists, which is Professor Gant, Dr. Anis, and also Dr. Alift.
Okay, so we also have an NICU newly built, and we newly opened it last year, where we have 12 NICU beds fully equipped with level 3 and 4 newborn intensive care unit service for all high-risk deliveries and also our preterm babies. Pediatric care, cardiac care service. So this is actually something that we have developed. We enhanced this service recently, where we have Dr. Ahmad. You have heard his talk yesterday. So what we do is we actually work very closely with public hospital as well, those we do not have a pediatric cardiothoracic service, where we accept patients referral from them. And what we do is we work with the NGOs to get funding so that the child has the opportunity to get the surgery and the repair done faster, because we understand that the waiting time in the government facilities is actually taking too long. So that's why we took the initiative to reach out to everyone, and we are helping the child to get funding to get their surgery done in appropriate time. And of course, pediatric hemato-onco unit and our bone marrow transplant unit, which is championed by Dr. Yap Xiao Yi, Dr. Najib, and Dr. Ernie, is actually doing very well, as we are recently part of the St. Jude Global Alliance, which is the first private hospital in Malaysia to have joined this prestigious alliance. So with this, I will also share you our corporate video. I think some of you would have, seen it before.
It truly look like when it is made just for your child? Is it the gentle welcome that greets you at the door? The comfort of being seen, heard, and understood? Or the quiet courage that begins to grow when you know that you are not alone? At Sunway, our emergency team is always ready to care for your child with calm, clarity, and the unwavering assurance that every family deserves when it matters the most. Every beep, every scan, every careful observation is thoughtfully considered to guide the next step in your child's care journey. When your child requires highly specialized care, you need more than just medical expertise. You need hope. Here at Sunway, we walk beside you through every step of your child's treatment with deep knowledge, reassurance, and a compassionate heart. With over 50 pediatric consultants across 28 subspecialties, we are here to support your child's growth, medically, developmentally, and emotionally. We approach every procedure with clinical precision, child-specific expertise, and a commitment to safety. When your child needs intensive care, you are not only seeking medical attention, you are placing your trust in us. Our neonatal and pediatric intensive care units provides 24/7 monitoring, partnering with families to ensure each child's healing journey is guided with meticulous care and compassion during your child's most vulnerable times.
Okay. So we didn't stop to improve to serve our patients better actually. So soon we're going to open up Tower F, and Tower F will be our future children's hospital. And I would like to take this opportunity to also share you a sneak peek about what this Tower F will offer to our future children that's going to walk into Sunway Medical Center. Yeah, stay tuned to more that is coming. So next time if you have an opportunity to come to Sunmed Medical Center when we open the Tower F, do feel free to visit us. Thank you everyone and thank you for your time. And now I think I will pass the mic back to the Farah for the next event.
Okay, before we move on to our lucky draw, I would just like to announce to our online participants that the 2 days